Otherwise, we are also having quite a good efficacy with thalidomide in the children. Thanks.
Any thrombotic complications
No,
we
sir,
had
no,
during
no,
the
no,
study?
no, sir.
We too have almost similar response, but we are very careful selecting patients. Hardly 7-8 patients we have started, and most of them had responded.
Divakar, how much ecosprin you give? Weight per kg or standard dose?
No, sir, sir. We have given ecosprin at 75 milligram standard dose, sir. Only to
Everybody?
patients who have platelet count of more than 4.5 to 10 lakh. Means we have used aspirin not in all the patients, sir. Only 1 or 2 patients who have used aspirin, sir.
And the IRB approved the study
Yes, sir, they have.
without aspirine?
Yes.
I am not sure.
So
Anybody has an answer?
Because when we are doing a literature review, sir, only patients who had a higher platelet count, splenectomized patient, so in those patients they have given aspirin, sir, because we have not taken splenectomized patient and we have not, so that's why, sir, there was no thrombotic event, sir, in our study.
Okay, thank you.
Thank you, Divakar.
Low dose, sir.
So, thank you, Divakar. So our next participant is Dr. Shekhawat.
Good evening, chairpersons, judges and the audience. I will be presenting this when less is not less. It's an outcome comparison between ICL protocol and BFM 2002 in pediatric ALL in our center. Means why we have decided this to do, because in developed world the outcome of ALL is almost 90%. It's more than 90%, but we in third world countries we are still lacking behind. Mainly we are lacking behind because we have poor diagnostic facilities and we have less number of specialized centers, and the bed occupancy is also high, so we can't afford a bed to each and everyone. That's why, because of these certain feature, and one more is a cytogenetic disparity. We have more of aggressive high-risk cytogenetics in our patients. So because of this, we do poorly. So that's why we have decided to this, that can we improve our outcome. So we utilize this protocol and we are seeing our analysis. So the aims and objective was to analyze outcome of this childhood acute lymphoblastic leukemia patients treated with ICL protocol, and to compare these with our historical BFM 2002 patients and their outcome. So it was a prospective study from May 19 to December 20, which was conducted in our hospital, and we have included 47 patients of newly diagnosed childhood ALL, and the outcome was compared with BFM 2002 patients, 90% basically. So the baseline charts and everything have been shown in detail in next chart, and we have compared event-free survival and also the early survivals, means before starting maintenance therapy. So I have divided these early and whatever till time study was followed. The overall survival they were compared using Kaplan-Meier. So inclusion criteria was age more than 1 and less than 18 years at the time of involvement, de novo ALL, previously untreated, and the exclusion criteria was Burkitt was excluded, any history of previous steroid, 7 days in this case, and MPAL, Down syndrome, and all secondary ALLs were excluded. So this was like our workflow. Once we diagnose a case of BCP-ALL, according to the risk categories, it was decided in standard risk or intermediate risk. And then on day 8 with CSF and cytogenetics, if the patient went into high risk, he was treated at high risk. If intermediate or standard, then we continued, and depending upon post-induction MRD status, if it's high, then he was further escalated to high risk. Otherwise, he was continued with the same category. And these are the high risk cytogenetics which we commonly see. So we have done a FISH for ALL. So it was basically BCR-ABL, then IM21, translocation 17, 19, MLL, and low hypodiploidy. These carries high risk cytogenetics, and straight away put the patient in high risk category. So this was my consort. All of the TALL were, to start with, they were considered high risk, and these were BALL, LBL 36%. And we have started them like standard risk 20, HR 6, and IR 10 patients. And then post-induction MRD based, out of 6, they continued in 6, and some from SR category and some for IR category. They have also been moved to HR category because of high MRD status. Then in respective branches, their arms, we have continued their further chemotherapy. And unfortunately, we have 3 deaths also. These are baseline characteristics. The mean age was 7.13 years, and most of them were male. It was 62% male, and B lineage was common. And the median hemoglobin was 9.1 gram per liter, and the median TLC was 13,000 with a 40,000 median platelet. And in most of the cases, the median LDH was markedly high. It was 986. And we see the bulky disease was also, it is in lowermost part, it was seen in 10.6% cases. So this is the karyotype, and as we can see, most of them were deployed, and after deployed, the next was hyper deployed. And the favorable one is only 15% compared to very high in the Western population. And this was a PSN correlation, and most significant is with MRD. When you see the bulky disease, if a patient has bulky disease, his chances of MRD positive was very high. And treatment outcome means the early events. Out of 47, we have 3 patients who died. Then out of remaining 44, 43 went in remission and 1 was not in remission. And in post-induction MRD, 54% had low MRD and 29% high MRD of those which was done. And bed occupancy, median bed occupancy in induction was 25 days. And in total bed occupancy, including induction and post-induction, it was 44 days. And we have 3 induction mortality and 3 post-induction mortalities. This was survival curve. This was event-free survival between B and T. There was no difference. And if we see overall survival in early phase between male and female, male was slightly better because all our induction deaths were in female. And when we compared with this BFM 2002, those full cohort and those who were treated simultaneously within the same study period, we see this icicle was way better compared to these two, mainly because of reduced early death. In this also, if we see the post-induction MRD status, those who have low MRD have done nicely in both these two. And if we compare with our historical data, for including BFM 90 also, we see in this arm we have significantly less number of death than the previous protocols. And in terms of bed occupancy, here we can see this protocol as a very less number of bed occupancy compared to this one. So more bed will available for other patients. And these are the previous, some of the national and international studies which we have taken, and these first 3 are from NRS itself, and remaining some of them are from abroad also. And we are almost lagging behind than the international data. So in conclusion, I would like to say that this MRD-based protocol and approach is feasible, very much feasible in government centers also with limited facilities. And it has improved early outcomes, especially because we are giving less chemotherapy, so the induction mortality has come down. And it has significantly reduced the bed occupancy, which can facilitate more and more patients to get in-house treatment. And because most of the patients are dependent on government hospital. So it can be a sigh of relief for the government hospitals. And these are the references.
Over to judges.
You said the bed occupancy rates are quite low compared to the BFM. Any febrile neutropenia window differences or compared between the two?
Yes, febrile neutropenia was there, but it was low. So because we have not, we actually have given very less chemotherapy to the SR group. Means literally they didn't receive any anthracycline, no anthracycline. So neutropenia was very less, sir.
I mean the number of days or whatever was not compared in between on a head-to-head comparison. That is
No, sir.
anyway.
It was compared, sir.
Okay. Okay. So you feel in that way it's relatively better.
Yes, sir.
Okay. In short, what is it for the audience, for the benefit of the audience? Because at the end of the day, ALL works with any combination of doxorubicin, vincristine, steroids, and asparaginase. This is what the basis of all protocols for that matter. In short and just what is the difference between these two protocols on dose-wise?
So means in our country with the risk of MDR infections and facilities and blood support, if we can minimize the chemotherapy, especially in the early phase, induction phase, when the risk is maximum, and especially to at least to the SR and IR group, we can save them. We can, if they survive.
Not at the tune of compromising with the outcomes.
No, so because we are seeing the MRD. No? So MRD is the best marker, and at the end of induction, if they are turning in MRD negative, that means the drug has worked.
Sorry.
MRD and cytogenetics, is it done in-house, in hospital?
So, with National Cancer Grid support, it was a tie-up between TMC Kolkata and NRS Medical College. So, National Cancer Grid has supported this, funded, and we have done all the tests at TMC in collaboration.
Okay.
Those cases where you have not done MRD, in those cases, how you have
Sir, because 3-way LBL, lymphoblastic lymphoma, so we can't do MRD in those cases. And then it was decided in the TALL that we will repeat MRD post-consultation. So post-induction, then MRD was not done for TALLs also. 6 patients we not done. For all BALL we have done MRD. For LBL it was not done. It was measured with the baseline imaging study. For one patient it was PET scan, for others it was CT scan.
Hematological parameters?
Yes, sir.
Hematological parameters?
Hematological parameters were seen, but in lymphoblastic lymphoma, the baseline also it was normal. So marrow was not involved. So.
Now from the audience, one question.
Yes, sir.
Any question
Yes,
from
sir.
the
PH like
audience?
ALL was there, sir. PH like ALL was also there. IM21 was one case also there, sir.
From the audience? Thank you. No question.
Welcome,
Dr.
sir.
Sekhat, for your presentation. Now the turn is for Dr. Sudeshna Kundu for her presentation.
Good afternoon, everyone. Myself Sudeshna Kundu. Today my topic of presentation is the characterization of Eastern.
Not here. Mic.
Sorry.
Take the mic.
Good afternoon, everyone. Myself Sudeshna Kundu. Today my topic of presentation is the characterization of Eastern Indian snake venom, their hemotoxic effect, and neutralization by anti-snake venom serum. Starting with the snake bite, which is one of the 4 most neglected tropical disease affecting the world today, and India, which is one of the global hotspot for snake bite, having 1,64,000 envenomation in 1 year, with the highest burden coming from West Bengal according to National Health Profile 2019. And the main culprit is snake venom, which is basically a cocktail of enzymes and non-enzymatic proteins. And enzymes are basically responsible for causing severe damages. And the central roles are played by phospholipase A2, metalloproteinase, serine proteinase, L-amino acid oxidase, etc. Components and their quantity highly varies from species to species, and the geographical location is the key contributing factor for within species venom variation, which leads to the development of damages of varied types. Venom causes various types of damages, and hemotoxicity is one of the consequences of these damages. Basically, after snake bite, venom is released from its reservoir to the circulation, where its components interacts with different components of the blood. Basically, venom phospholipase A2 comes in contact with the membrane of red blood cell, and it cleaves the membrane phospholipids, thereby disorganize the lipid bilayer structure and ultimately causing intravascular hemolysis. In association with that, phospholipase A2 with other venom components convert the oxyhemoglobin to the methemoglobin, and this is also a fatal consequence. Next, coming to the snake bite therapy, which is the anti-snake venom serum. It is the only therapy available till date, and in India, it is raised against the big 4 venoms solely sourced from the snakes in Tamil Nadu. And it is found that it is more effective against southern region, but found less effective against northern and eastern Indian snake venoms. Therefore, the aim of this study is to characterize the components of snake venoms collected from eastern India, evaluation of their hemotoxic effect, and assessment of neutralization efficacy of available ASVS over them. In study design, we have included Naja Kautia, and Daboya Raseli, the 3 common snakes found in West Bengal, and we have characterized their protein profile and catalytic profile. Hemolysis was also assessed, and their neutralization was studied with ASVS, and in association with this, the neutralization study was also performed with gold nanoparticle conjugated anti-snake venom serum against Russell viper venom. And coming to the result section, native page analysis revealed that the Naja venom proteins are mostly basic in nature, whereas Russell viper proteins are mostly acidic in nature with few high molecular weight proteins. SDS page analysis revealed the presence of L-amino acid oxidase class 1 and class 2 metalloproteinase and serine proteinase of those venom proteins where L-amino acid oxidase and serine proteinase are high in Russell Viper venom. And the activity of the enzymes was also done by in vitro assays, and PLA2 assay revealed the maximum activity in Russell Viper and Naja Kautia venom compared to Naja Neja venom. SBMP and Lao assay showed similar pattern in which is highest in Russell Viper venom compared to Naja venom. Hemolytic activity was also performed, and here plasma free hemoglobin and plasma lactate dehydrogenase levels were measured, and both these results showed that the hemolytic component is highest in Naja venom compared to Russell Viper venom. Next, we have checked whether the available ASBS is potential and how much it is potential. So, we have found that the commercially available anti-snake venom serum is required 10 times more for Naja venom and 100 times more for Russell Viper venom as compared to manufacturers' proposed dose. So there is a need to increase the potency of ASBS. And studies are there which proposing gold nanoparticle conjugation increases the activity of the protein, and as commercially available ASBS showed less potential against Eastern Russell's Viper venom, so it was chosen to check whether ASBS potential increases after GNP conjugation. So for this we have prepared gold nanoparticle by citrate reduction method. We have prepared 20 nanometer size particle and conjugated it with anti-snake venom serum. We have characterized the conjugate with UV visible spectrophotometry. We have found the bathochromic shifting of the conjugate, and the hydrodynamic diameter of the particle increases after conjugation, zeta potential decreases, and intrinsic fluorescence of the proteins, tryptophan fluorescence, gets quenched after addition of the gold nanoparticle. All these results confirm successful conjugation of gold nanoparticle with ASBS. To check whether it is more effective compared to available anti-snake venom serum, we have done in vitro assays against Russell's Viper venom, and all the PLA2 and metalloproteinase assays reveal that the conjugate has better potency compared to available ASBS. We have also performed Russell's Viper venom induced RBC morphological alteration study, and we have found that the normal discocyte morphology gets altered after venom injection, which is not properly restored by the anti-snake venom serum, but comes to the normal level after gold nanoparticle ASBS conjugation. These studies further emphasized by this data, and here we can see that the normal discocyte morphology is restored after gold nanoparticle ASBS conjugation compared to ASBS, available ASBS. So to summarize, the collected 3 common snake venoms of the West Bengal were characterized. Horizontal native page analysis revealed the basic nature of Naja venom proteins and acidic nature of Viper venom proteins. PLA2 assay exhibited maximum activity in Russell Viper, followed by Naja venom. SBMP and Lao assay showed similar response, maximum in Russell Viper, followed by Naja Naja and Naja Kautia. Commercially available ASBS showed less neutralization potential to the collected venoms at manufacturer specified dose, and gold nanoparticle conjugation increases the activity of ASBS tested against Russell Viper venom. Further studies are required to validate its potency in vivo.
Thank you. Over to judges. So very interesting topic you have presented.
Yeah, really, and it has got a lot of implication for state, like whatever the leukemias I treat, I don't make a difference to the society in general, but this makes a lot of difference. But only thing I want to ask, you said the venom from Tamil Nadu, I am from Tamil Nadu to be more frank, and you say gold nanoparticulation, whatever the addition of gold particles makes a big difference in vitro. I just want to ask, is there any commercially available ASVs outside India which have been proven to be working?
No, sir, it is not,
not available. Because
for the first time we are doing this work, and it is not yet published.
To be more frank, I talk about gold intake and whatever, because our ex-chief minister MGR died of heavy metal poisoning due to intake of gold. So I think practically in vivo we really have to wait, but data looks great, to be more frank. Sir.
Thank you very much. This is one very wanted presentation. In fact, from West Bengal, the snake bite is so common, but we are not our venom from the snakes of this region. We have to take venom from outside. And I think, in fact, one of my friends is also struggling these things to get so that that can be done over here. Though there are some policies, there are problems are there. But this is one definitely eye-opener. It proves that yes, this is needed. And say special thank. But I was thinking that some electrophoresis, the separation, this is, you have done it?
Yes, sir.
Wow, it's excellent. Your separation is excellent. Very good. And your another point, you have done all those CBC study before and after CBC study and RBC morphology.
Yes,
You have studied it.
All this work was done in vitro, not in vivo. So we have incubated blood with venom, and we have tested whether the gold nanoparticle conjugation increases the activity of the available ASBs or
So
not.
in experimental level, you have done it.
Yes, sir.
Not in the patients.
No, sir. It is just for preliminary study we have done.
Oh, very good. Okay.
Not in view, still.
Thanks to the participants, young participants. And any questions from the audience? So,
One question.
1 or 2 questions permitted, as this is the last session. Audio, please.
Reaction. Nanoparticle has got.
It is not audible. Please, correct. Rectify the mic or come closer.
Nanoparticle has got anaphylactoid reaction. Does this gold nanoparticle has got anaphylactoid or anaphylaxis reaction? For the addition?
In vitro
There
study.
is a proof that the nanoparticle causes anaphylaxis or anaphylactoid reaction. Does it?
This
By adding this.
is in vitro studies.
Actually, sir, we have done this work only in vitro. We did not experiment it in animal model. Oh, okay, sorry, sir. I will. Thank you, sir.
So, no question? So, thanks to the young participants, energetic participants, you have presented very nicely. Thanks to the judges for their duties they have done, and thanks to the audience for their patient hearing and questionnaire. Thanks. We end the session here.
Thank you, chairpersons, judges, and speakers. And now we move on to the next session on acute leukemias. As chairpersons, I would like to invite Dr. Kalyan Kunsum Mukherjee, sir, and Dr. Sanchita Saha, ma'am, on stage. Dr. Kalyan Kunsum Mukherjee, sir, is a senior hematologist at Chittaranjan National Cancer Institute. And Dr. Sanchita Saha, ma'am, is assistant professor medicine, SSKM, Kolkata. Over to you, sir and ma'am.
Good afternoon, everybody, and welcome you in the post-lunch session. And this session is on something somber in acute leukemia. Okay. So, Dr. Saurav Bhabe, he's consultant hematologist. He will give a talk on newer inductions in AML. Dr. Saurav, please.
So good afternoon all. It's 20 minutes lecture on newer induction regimens in acute myeloid leukemia. We have been using these regimens quite often and lot of excitement about that. But to me, it is like a controlled excitement. So let's see why, how. So these are my views on the newer regimens. Everybody may not have the same view. So AML is a poor condition. In last 10 years, I have learned that most of the people of AML will die. Some die rich and some die poor, but probably many of them die. So what can we do to improve their longevity? So is there a need for a complete response? And above all, a need to achieve an MRD negativity. Is there a need to add something new to whatever is already existing? What are the new regimens? And as of today, are they feasible to most or to some? So these are some prognostic markers in acute myeloid leukemia. Probably the most important is finance. It overrides all other prognostic markers in acute myeloid leukemia. This is one disease that if you are poor, an adult, and elderly, almost always you die. Pediatric little bit different, but for adults almost always. Age, performance status, WBC count, though it is not counted in routine criteria, it's one of the worst criteria. Cytogenetic markers, molecular markers. If you have achieved a CR with incomplete recovery or incomplete platelet recovery, and now the new boy is MRD. So this is one trial which was a S0106 trial. It was a cooperative group trial. In newly diagnosed AML, around 600 patients were treated. Out of them, 25 did not achieve a remission at the end of an induction. And if you see the outcome, only 20%. So if you don't achieve a remission at the end of induction, the survivals are extremely poor. So probably achieving a remission is important. Now you see this. These are all patients treated over a long period of time and studied. CalGB data. These were not APMLs, not secondary or treatment associated AMLs, and they were not given transplant as a form of treatment. If you see this core binding factor leukemia, 178 achieved a CR out of 185 with standard treatment. So most of them achieve a CR, and if they achieve a CR, only 74 amongst these 178 are alive. That means 100 died. So that's pretty poor. So if you see this, aged less than 60, 1,600 patients, at the end of 10 years, only 16% have survived. And those who survive, probably the CBF AML is the highest group. If you see those more than 60, only 2% survive. 2%. So most AMLs die rich or die poor. It's up to you how to make them die. So this is really a poor situation. So can we improve over this a little bit? So how do we assess a response? Morphological assessment, imaging assessment, and then a measurable residual disease, not a minimal residual disease, what you can measure. And that can be done either by an immunophenotype way or a molecular way. It can be Sanger sequencing, it can be next generation sequencing, and multiple methods available with its sensitivities and specificities. Now this was a study which was published in ASH Clinical News. 2,297 samples were analyzed, 1,000 bone marrow, 1,000 peripheral blood. These were all in favorable prognosis AML to see assessment of MRD negativity, whether it predicts survival. So all patients received standard treatment of 7+3. And after that, 77% achieved remission, which we also see. At the end of one more cycle, the CR rate increased to 98%. 4-year OS 75 and relapse-free survival only 60%. So even if you have 98% achieving a CR, only 75 survive, 25 anyways die because of some or the other reason. And probably this is the reason. Only 52 achieved MRD negativity in bone marrow, and in peripheral blood 74% achieved MRD negativity. So achieving MRD negativity probably is a factor which is known to reduce the cumulative incidence of relapse. So if you see this 4-year CIR, if you achieve MRD negativity, it's only 17% versus peripheral blood, it is 23%. So probably doing repeated marrows at a defined time point and having an adequate test available to detect MRD early And if you detect MRD, you have to act on that. So all these factors are needed to help them survive longer. So defined time points are needed to assess MRD, and these defined points are different for different types of AMLs. So that's one more problem with that. Deeper MRD is also important. Log reduction in NPM copies or RT-PCR or RQ-PCR copies is different for different diseases. Almost all relapses in their study was within 1 year at the end of treatment, and very short latency from molecular to morphologic relapse. In 821 AML, you hardly get 2 months. You don't even get 6-8 months from detection of molecular relapse to actual frank relapse. So standardizing MRD assay and choosing the right time points to inform treatment still remain challenge as in 2020. So these are minimal residual disease status predicts outcome of acute AML undergoing a transplant. So if you see no molecular CR, more relapse as compared to a molecular CR. Across the board, relapse incidence, LFS, OS, and graft versus host disease, relapse-free survival. So probably MRD is important. Now the problem is how to do it. Again, same, MRD negativity, good survival compared to MRD positivity. This was a long-term study of 11,500 patients. So what is the use of monitoring of all these things? We have to early detection of MRD and then probably change in treatment. If I am not able to change the treatment, what am I going to do with monitoring the MRD every 2 monthly or 3 monthly doing a bone marrow and doing these expensive tests? On top of it, you don't have adequate markers as you grow older to detect MRD. If you are young, you may have a little bit more marker to detect. As you grow older, the number of markers to detect become less and less in number. So that is also a problem. Now this is the molecular relapse and actual relapse time frame. So different AML subtypes relapse at very different relapse speeds. And relapse kinetics data may help to choose different treatment regimens. So if you see MLL, within a month it relapses. Even the next one, within 3 months. Inversion 16 probably give us a very long time to decide and think, 6 months. In these patients, probably it is important to monitor because it gives a pretty long time for us to decide. Most of the diseases relapse within 3 to 4 months of actually a molecular relapse. Now, can you change treatment as per MRD? This was an algorithm in 2019, basic law favorable risk, because these are the patients who relapse more frequently and also respond to allogenic transplant most. So favorable risk, ELN risk criteria, MRD status if positive. If you do not do a transplant, 50% will relapse. If you do a transplant, probably 20% will relapse. So MRD positivity may change the way you treat these patients. And MRD negativity, these figures are really good. That means you have to continuously document MRD negativity at post-induction and after that. So now, after all these things, all these new agents, if we add, are they really going to increase the CR rates, which already are not so bad? Increase molecular CR rates, and they have to remain sustained. Improve PFS and OS, probably is less toxic and able to replace conventional regimen, affordable and also available on time. If that regimen is fulfilling all these, then there is a point in adding a drug to the existing one. These are all the new agents and everybody knows it. Out of that, midostaurin, available tablet form, inacidinib, tablet form, expensive, liposomal, not available, very expensive, ivosidenib, tablet, available, expensive, gemtuzumab, available, expensive, gilteritinib, available, expensive. All these are available. Out of them, probably venetoclax and gemtuzumab are used more often as compared to the other agents. Now, these are generally used for older, frail patients, not fit enough to take intensive treatment, but probably they are again used in untreated AML which are fit, and they are added on to different agents, all these agents. So initially started with older unfit patients. Now trials are being conducted to add these agents upfront in fit patients with 7+3 or any other intensive treatment. Similarly for this, fit patients, CPX versus standard, GEO also fit patients. So let us see one drug in one slide, 5 minutes more. CPX 351, this is the trade name. This cost is $8,000 a vial. And see how much it is given. Induction, 3 doses. 2 induction, 2 dose, 1 dose. And 2 consolidations, 2 doses. So that much will be the cost if we give this. And if you see the CR rates, not different. And if you see the median OS, not different. But probably there is a subset of very high risk patients in whom it has improved. That's why it got approved. But in our sense, see 12 months, 14 months, 6 months, 8 months, 6 months, 12 months, 4 months, 3 months. Not really a big difference, but it is available as per the FDA approval. So in their cost analysis in US, they said that there is a favorable balance between the clinical gains and the incremental cost of treatment. So for them, this may be a standard of treatment for secondary AML or treatment associated AML or AML with MRC, but it is prohibitively expensive. Second agent is GEO, UCF5, a good meta-analysis, and it shows that the CR rates were almost same in both rims, and EFS was significantly prolonged in the GOR with a good p-value. So favorable risk works best, intermediate risk plus minus, because if you are taking up a patient of IR for transplant, probably you may not want to try GEO for the increased risk of VOD. And in high risk, it is not recommended. This is a good data from MD Anderson where they replaced IDA with GEO. So flag GEO versus flag IDA, better PFS, but in favorable risk AML, and probably GEO the OS was better due to better MRD negativity. So this pushes, but for that we have to know MRD. Cost is 24,000 US dollars for 1 cycle. So still pretty expensive. So this is again for NPM. If you see the cumulative incidence of relapse, GEO arm versus standard arm, there is a significant difference between the relapse in NPM also. So this also suggests that the favorable risk patients do well. These are all the trials with GEO, and if you see the CR rates are not much different. But probably EFS and OS are a little bit more different. Venetoclax, everybody used it. Again, there was difference of only 6 months between AZA alone versus AZA plus venetoclax. So both these trials, even with low dose cytosine and with azacitidine, the difference was not that significant. OS was not that significant. And if you see the leukopenia, 33%, febrile neutropenia, 39%. Many of these patients continuously go in and out of the ward. Eventually costs become very high. And it is recommended that both of these agents be started simultaneously, escalate doses with TLS monitoring, can reduce the dose if using azoles as antifungals. These have more prolonged neutropenias. Response is better in NPM mutated AML. In response in IDH is variable and TP53 is not good. Stop after 2 cycles if no response. If given for 2 cycles, do a marrow. If no response, better to stop. There is no point in continuing. This can also be used in IDH or FLT3 associated AML, and probably they are doing well, better than the IDH inhibitors. That is one good important information. Elderly patient with IDH, probably instead of giving inacidinib or ivosidenib, we can try venetoclax, generic plus hypomethylating agent. IDH inhibitors, this was a median age of 62. See the number of chemotherapy cycles given. IDA plus cytosine plus IDH inhibitor in induction, mitoxantrone, etoposide 4 cycles with IDH inhibition as consolidation, and then plus or minus allogenic transplant. After doing all these things, these are the survival rates. So if you are going to do all these things, then you may get such figures, but with lot of toxicities, both financial and physical. So this is single agent IDH1 inhibitor, which is now approved for AML in elderly patients. Little bit improvement in CR, but major side effects are QTC prolongation, GB syndrome, differentiation syndrome, but has less myelosuppression. Cost of ivosidenib is 36 lakhs a month, and inacidenib for 1 month it is 78,000, 7 lakh 80,000 rupees. So that much cost patient has to pay for, see the survival. Median survival is hardly 8 months, 10 months, 12 months. Similarly, for FLT3, the ratified trial, no differences in CR rate by adding midostaurin to induction, but probably it is important that the median OS is pretty good as compared to placebo. 4-year OS is also good, but not as good as this one. And the cost is patient has to pay 10 lakhs and he gets 23 lakhs drugs worth free. These are patients who don't go undergo transplant and are on maintenance midostaurin. Plus you have a prolonged thrombocytopenia, and then you have to support that thrombocytopenia for a pretty long period of time, and you almost get a similar CR rates. Glasdejip, new boy on the block, it is also approved with ISA or decitabine and IDAC and IC, and these are the safety data, a little bit more. We have some compassionate access to Glasdejip, which we are using for a second or third line. The cost is $19,000 for 60 tablets. That is a month of Glasdejip will cost $20,000. Not great benefit. TP50 mutant AML, we are also having compassionate access at the moment. These two agents are present. There is some efficacy, but also not so easy to tolerate. So this is the current algorithm. This mentions only if you have comprehensive profiling of AML. So right from morphology, immunophenotype, cytogenetics and molecular analysis, we have to get it quite quickly. If it is a good risk, add gemtuzumab. If it's FLT3, add FLT3 inhibitor. And others, you can choose among whatever you have. So for us, the new things are probably gemtuzumab and FLT3 inhibitors, if patient can afford, and you can get the drug pretty on time. So for us, as a routine to add these agents, either you should have finances or you should have a compassionate access. Second, early availability of data and molecular data with a very fast stat. If you take 15 days for the NGS panel to come, it is of no use to us. Second, GO to be given by day 4. So we need to know whether patient has NPM or 821 or inversion 16 or SEPA by day 4 or day 5 by whatever method you are using. And patient is intermediate risk, plus minus, depending upon the ability to undergo allogenic transplant. All these decisions have to be made within first 7 days, but that is not easy. Midostaurin by day 8 we have to get, and the cost is around 2 lakhs. Similarly, for these agents, you have to start on the day of starting of HMA. If you start by day 8, day 10, day 12, then they lose the efficacy. HMA also similarly. So method it MRD, they need standardization and validation. So probably we are lacking here. We are lacking here. So we don't know what to do really with these new agents. So what can we do? Early and complete diagnosis, collect samples for re-stratification, probably give Buffy codes to reduce the infection rates and push the patients to sustain the treatment more, reduce induction mortality, some literature of replacing idarubicin with daunorubicin, but not clear-cut data, and try for compassionate access programs to get newer agents. So for us, probably these agents still are not to be used for the masses. Occasional patient, it may help. So thanks for a patient hearing.
Thank you, Dr. Bhave, for elaborate newer drug in AML and some hope also for the treating the AML. Any questions from the audience?
Yes, Anubhav. there are trials in younger patients, but still not good randomized control trial, but there are trials. For us, probably we know that giving 7+3, by day 14 the blast will go that way, by day 21 the blast will come up, and by the end of day 30 probably the patient will recover, whatever 70% patient. But I am not sure whether this type of figures are available for venetoclax and AZA. Prolonged and prolonged and prolonged. And then the patient remains in hospital, some sick, not too sick, but suddenly can become sick. So to counsel somebody that your count is 100 today, by day 10 it will become 900 if you are in remission. I am not sure on venetoclax whether we are able to say these figures. Is anybody here able to say such figures? 7.3 is able to say such figure. And nobody other than 7.3 has shown a good CR rate. Addition of new agents has not improved the CR rates at all. Somehow they have improved the EFS, PFS, but not the CR rates. And they are the cheaper drugs. Venetoclax, if you want to give 400 original brand, 1,30,000 rupees. And that too, azoles we gave, sometimes we give amphotericin B, and then liposomal ampho B, and then the cost increases. So probably for us, 7.3 or go home. No other choice. Venetoclax is very, very difficult. Unless there is a pneumonia, you cannot give 7.3. I am not sure whether venetoclax and AZA will completely replace 7+3 in routine, standard, fit, young AML patients. I am not sure. Anybody has any suggestions? There is no definite time period for that. Yes, sir.
Yes, I have a comment. Actually, I agree with this. So far, the young adult is concerned, nothing is going to substitute to 3+7 with predictable information. But elderly patient is concerned, I saw the data from the others also. Combination of hypomethylating agents along with the venetoclax, the CR rate goes up to 80, even 90%. I don't know what is the long-term effect, but the CR rate and they achieve remission in quite good percent of cases. Whether the remission is being translated into the overall survival or the progressive survival, I don't know. I don't have any idea.
If the count is more than 30,000, even in AML adults, elderly, HMAs work poorly. Second, the path to achieve CR is through a lot of suffering, sir. They just remain in the ward, and you cannot do anything. They achieve CR, but after 4 months, maybe 6 months, not earlier than. Occasional patient with 1 or 2 cycles achieves a CR. Anybody has clear information about this? Yes. 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 Older drugs fulfill most of these criteria which you have suggested, sir. Newer agents are still not able to fulfill all those criteria. Agreed.
Thank you, Dr. Bhave.
Thanks.
Next.
Okay, thank you. May I request for the second speaker, Dr. Avinash Singh, on relapse adult ALL optimization in 221.
So, good afternoon, everybody, and thank you, respected chairperson, for kind introduction. I would like to thank organizers, especially Dr. Prakash, for organizing this annual meeting and giving me opportunity to speak today. And this is really a great experience after 1 year of COVID lockdown almost, that we are together and we have interacted. So, my topic is relapsed adult ALL options in 2021. We know that ALL is a common hematological malignancy that we see in our clinical practice. And in both male and female, there are 2 peaks that we see, less than 6 years and after 60. So adult ALL number is huge that we, if we see all ALL that we encounter. So for acute leukemia, when we suspect acute lymphoblastic leukemia, we have to do all these investigations to confirm whether it is ALL or not. And we need to have a good cytogenetics and molecular tests done to prognosticate ALL. It's very important. So there are some difficulties or challenges of adult ALL, they are same as has been discussed by Dr. Saurav in last talk. These are flow cytometric markers which are important to see whether it is T or B. Cytogenetics is important. 22% of adult ALL can have normal cytogenetics. Philadelphia, 15 to 25 mentioned here, but over age, its incidence increases, and more than 60, even 50% of them will have Philadelphia positivity. This is very important. Novel genetic determinants. It's very important to know that whether this particular patient of ALL has these abnormality or not. So TALL can have these genetic alterations. Philadelphia positive, PH like ALL, again they can be CRLF2 positive or negative. And in all them, there can be some targets. Fortunately, we have some agents which can be added to pull out some difficult to treat patients of adult ALL to remission, or we can improve their survival. So adult ALL doesn't have as good prognosis as we see in pediatric ALL. And the regions most of us know, they are clinical factors, biological factors, that is the incidence of adverse risk cytogenetics or molecular abnormality are more common in adult ALL, and the good risk abnormalities, they are less common. And social factors and other factors are also there. There are some real life challenges which has been discussed in AML talks. So financial, in adults, though they have 2-3 siblings, as age increases, there is separation of family, and hardly brother or sister, they come to see their siblings when they are ill. So you can't think of stem cell transplant, stem cell donation in all patients. Elderly, they are living alone, so support is compromised. Treating center or doctor is also very important. I always feel that hematological malignancy should be treated in an institution with team approach. Single doctor handling all difficult patients, it is difficult to give the best care. MDR infections are real challenge. Education, expectation of family and patients are important. Supporting staff, nursing is an issue, and both setup, private has problem of frequent change of nurses, and government setup, there is problem of attitude. Social media or internet-driven resistance to treatment is another challenge that we face whenever we come across any hematological malignancy or serious sick patients. Outsourcing of tests that are not done at local place has their advantages as well as limitations. In my practice in last 6-7 years, if suppose I have sent 100 cytogenetics, hardly 3 or 4 has shown some abnormality. 50-60% they come normal, and 20-30% time it is test not performed TNP, it comes as TNP. So it's important. Adult ALL treatment is multi-agent chemotherapy as we do for pediatric ALL, and about less than 40% will be long-term survivor. MRD in adult ALL, it's not so clear as in pediatric ALL, and about 80% will have some detectable MRD at the end of induction, and MRD positive means higher risk, relapse risk. And we don't know what is the best test to do MRD in adult ALL. So this has been seen that MRD negative has good prognosis both in pediatric and adult ALL. It is already proved. It is one of the strongest single prognostic factor in ALL management, and limitations are that many a time we see that MRD negative, they relapse, and positives are not relapsing. Maybe the method that we are using for MRD is not so well validated. So NGS and droplet PCR, yesterday there was one talk, is the need, but they need standardization. MRD assessment should be done after induction, after consolidation, and every 3 months thereafter. And it should be done before a stem cell transplant. It has got prognostic as well as a role in deciding treatment. Relapse is reappearance of leukemic cells, and resistant or refractory disease is defined as patients who fail to obtain remission with induction therapy. Type of relapses, it can be isolated marrow relapse, isolated extramedullary relapse, or combined relapse. Depending upon the time at which relapse occurred, it can be late, very early, or early relapse. And there are different groups who treat adult ALL. They have different prognostic factors. So as per MRC, age and WBC count they consider as prognostic factors. Whenever we see a patient in remission of adult ALL, we follow them up with history, physical examination, and CBC peripheral smear. When we suspect relapse, we should do all these investigations along with extramedullary site evaluation to look for whether it is isolated marrow or combined or isolated extramedullary relapse. Once a patient of adult ALL is relapsed, the prognosis is very poor, 5 to 10% long-term survivor. You can see CR rate is around 30 to 40%. And this is just showing that multiple relapse again has poor prognosis as expected. In first salvage, CR rate is 40%. Second salvage, it drops to 20%. And in third relapse, third salvage use, hardly it is 10%. So we understand that adult ALL treatment or relapsed adult ALL, there is need of some improvement, some addition of some agents which can pull out some patients into remission, and they can be subjected to a stem cell transplant in some of them. So recently there are some drugs which has been approved. I am just going to discuss them in detail. Inotuzumab ozogamicin is a monoclonal antibody anti-CD22 which has been conjugated to cytotoxic calicheamycin. So inotuzumab combines with CD22, it is internalized. CD22 is expressed on more than 90% of BALL, and it is best internalizing receptor. So once it is inside, it is dissociated, and the calicheamycin, it enters the nucleus and causes DNA damage and apoptosis. So this was innovate study around, it was multi-center, multinational phase 3 study, and in adults with CD22 positive relapse refractory ALL patients, total around 326 patients. They were 1:1 randomized. One group received inotuzumab, another group received standard chemotherapy. And these were baseline characteristics which were matched in both the groups. These are results. Inotuzumab group had significantly better CR or CRI rate and MRD negativity compared with the standard chemotherapy. And when all other factors were analyzed, it was found that they favored inotuzumab compared with the standard chemotherapy. Again, here all these factors, they favored inotuzumab use compared with the standard chemotherapy. And when long-term treatment response and MRD negativity were analyzed, it also was significantly better in inotuzumab compared with standard chemotherapy. PFS was better in inotuzumab. Overall survival was better in inotuzumab compared with chemotherapy. And when patients were in remission, how many patients has gone for a stem cell transplant successfully? So that number were significantly better in inotuzumab compared with the standard chemotherapy. Coming to adverse effects, so hematological side effects were almost same in both groups. Only the liver side effects or the VOD side effects were significantly more in inotuzumab compared with the standard chemotherapy. So this is a summary that I have said. Then inotuzumab has been used in different phase 2 study with MRD negativity of around 60 to 70%. This is innovate trial, and it also has been used with low intensity chemotherapy in elderly patients with good MRD negativity, around 80 to 90%. It has been tried along with bosutinib in Philadelphia positive ALL with around 81% overall response rate. Then second agent is blinatumomab. It's a CD3, CD19 bispecific T-cell engager antibody that has shown a high efficacy, and this is blinatumomab. So once this molecule binds with CD3 positive T lymphocytes, it leads to activation of T lymphocytes, the release of granzyme perforin, and it leads to activation of caspases, apoptosis, and there is death of malignant B cells. So this is Tower study. It's prospective randomized phase 3 trial. 101 centers, 21 countries, adults that is more than 18-year-old with PS negative BALL were included. All difficult to treat relapse refractory patients were there. These were exclusion criteria. Then treatment were given 2:1 randomized with blinatumomab and standard chemotherapy. So blinatumomab arm, they received induction, consolidation, and maintenance, and standard chemotherapy received as per protocol, they received the chemotherapy. These were baseline characteristics. They were matched in both groups. And these are results. Blinatumomab had significantly better overall survival, and event-free survival compared with chemotherapy arm. These were some subgroup analysis which favored blinatumomab better than chemotherapy. And these were all subgroup analysis which favored blinatumomab use. And the best hematological response at 3 months were significantly better in blina compared with chemotherapy. These were adverse events, so adverse events were almost same in both group except the cytokine release syndrome which were seen only in blinatumomab. These were different study of blinatumomab in this pH negative as well as positive ALL. Phase 2 study, MRD negativity again is around 70 to 80%. And so other than single use in these difficult to treat patients, there are some trials where these agents has been combined with common conventional chemotherapy protocols like hyper-CVAD in young patients and mini hyper-CVAD in elderly unfit patients. And they have shown that there is benefit. So mini hyper-CVAD with inotuzumab with or without blina, CVP with inotuzumab has been tried around 80% MRD negativity. Venetoclax plus navitoclax has been combined in relapsed refractory ALL with around 56% MRD negativity. They has been tried also in frontline, in pH negative older ALL, mini hyper-CVAD with inotuzumab with or without blinatumomab. And in younger ALL, sequential hyper-CVAD with blinatumomab has been tried with success. Around 96%, 95% MRD negativity has been found. These are some other drugs of interest like venetoclax along with liposomal vincristine, combinations of venetoclax, navitoclax, then monoclonal antibodies, CAR T-cell therapy, though it has been approved for young patients less than 21-year relapsed refractory ALLs. For adult ALL, some encouraging studies are there. Maybe in future we will have CAR T-cell therapy available for them too. In, regarding CAR T-cell therapy, so these are some study in adult ALL, and they have found that CR rate is around 60 to ranging from 60 to 90% in different study. Coming to pH positive BALL, so before TKI presence, prognosis was very, very bad. With introduction, the survival has improved. So these are some study of intensive chemotherapy plus TKI with use of different TKI, and they also that as you increase the generation of TKI, the improvement, overall survival improved. So best is with ponatinib. Lower intensity chemotherapy with TKI has been tried, steroids plus TKI has been tried, and blinatumomab with TKI also has been tried with success in different study. Which TKI, there is no head-to-head comparison among 4, 5, 6 TKI which are available, but most of the patients who relapsed on first or second generation TKI, they were 70 to 80% were T3155 mutations. So whatever study with ponatinib are there, they are showing the best response. So pH like ALL is a novel entity. It has got poor prognosis, and best intensive therapy followed by HSCT should be used in this patient, but things are not so clear that what should be the protocol. We are using intensive therapy and we are using a stem cell transplant when facilities are available. Addition of dasatinib or JAK inhibitor in subsets when there is ABL type of rearrangement or JAK mutations are there are useful, but benefit is uncertain. TALL is generally treated with as BALL except the ETP-ALL which has got poor prognosis, and nelarabine is an agent which is T-cell specific, can give 30 to 40% of CR rate. It has also been tried along with hyper-CVAD in some TALL patients. ETP-ALL shows BCL2 overexpression, so venetoclax can be useful in this group of patients. Regarding adolescent and young adults, alliance trial is ongoing, which has combined inotuzumab with CalGB backbone, which is intensive chemotherapy protocol. CNS prophylaxis is almost same IT, high-dose methotrexate and radiation in some patients. CD20 positive BLL patients who are less than 60 years old, you can use rituximab, there is benefit. This is just my understanding. If we compare the three modalities, only inotuzumab is available in India. It's an OPD procedure, 1 hour infusion. Blinatumomab is continuous infusion, so patient has to be in IPD. Side effect, unique side effect is VOD or SOS, or Blina, CRS and neurotoxicity, and CAR T-cell again CRS neurotoxicity. In US, CAR T-cell is 3 times costlier than inotuzumab. For extramedullary disease, there are some case report series that it can be effective, but all these three agents are almost not so good response, or in many trials they have excluded extramedullary disease with these agents. Evolving role of HSCT. So historically, all patients of adult ALL, when they achieved CR, they underwent HSCT as consolidation. But in last 2 decades, with better prognostication and understanding of unique biology, the HSCT has been limited for very selected patients. So these are some indications for BALL adverse risk cytogenetic features like low hypodiploidy, near triploidy, 411 complex karyotype, and pH like ALL. For pH positive BALL who do not achieve early deep molecular response, for TALL, ETP, and lack of Notch1 or FBXW7, and persistent MRD is another indication. And this is very important that HSCT and non-HSCT, both options in adult ALL are evolving. So maybe with time, things will change. So this is just an algorithm to suggest that if patient is pH negative B-cell ALL, see the MRD if it is negative, and patient has poor risk cytogenetics or genomics, do HSCT. If MRD negative and there is no unfavorable cytogenetics or genomics, continue consolidation or maintenance. If MRD positive, you can give BLINA or ETO and then consider HSCT. pH positive B-cell ALL, see complete molecular response at 3 months. And if they achieve, continue chemotherapy plus TKI, maintenance TKI for indefinite, no CMR within 3 months, BLINA or INO plus TKI, considered HSCT based on MRD risk, response and HSCT risk, and following that maintenance TKI has to be used. For T-cell ALL, MRD negative, even if they are MRD negative in ETP, we need to do HSCT. If non-ETP, continue consolidation on maintenance. If MRD positive, MRD directed clinical trials should be used, followed by HSCT. So to conclude, a story of adult ALL is not as lucid as that of pediatric ALL. Relapse refractory has poor outcome. Introduction of new immunotherapeutic agent has hope. So novel risk stratification model and MRD can guide us better for suitable treatment or to choose best treatment. Use of novel agents alone or in combination upfront has hope in some high-risk patients so that they can prevent relapse for better outcome. Thank you.
Thank you, Dr. Singh.
Thank you, sir.
Discussion about acute lymphoblastic leukemia. Any questions from the audience? Hello. Any questions from the audience? No. Okay, thank you, Dr. Singh.
Thank you, sir.
For the next session, may I request Dr. Tusti Ganguly. She is consultant hematologist and hemato-oncologist in Saroj Gupta Cancer Hospital as moderator. And Dr. Pritish Chandra Patra, he is assistant professor in IMS and SUM Hospital, Bhubaneswar. He had a number of publications in national and international journals. Dr. Sombit Samanto, consultant hematologist. Dr. Orijit Nag from Tata Medical Center, and Dr. Ankita Sen, senior resident in NRS Medical College, consultant in Amri Hospital. It's a case-based discussion. Dr. Tusti, to you, what do you?
Very good afternoon to everybody, and thank you for the Madam Chairperson for the kind introduction. And I would also like to thank the organizers. Most of them are my teachers for giving me this opportunity to speak in this August platform. And most of my panelists have already been introduced. So without further ado, we'll just dive into the topic. So the topic today is a panel discussion on Philadelphia positive ALL. And we'll be going through a few of the questions regarding what, why, and how. So first is a case. This is Mrs. P.S., a 46-year-old female with no significant comorbidities, was admitted with progressive pallor, fatigue, and occasional gum bleeding since last 3 weeks. The physical examination revealed pallor, cervical and axillary lymphadenopathy, a spleen of 2 centimeters with wet purpura. The CBC on admission showed a hemoglobin of 6.8, WBC count of 1,67,000 with 86% blasts and platelets of 12,000. The bone marrow studies revealed a pre-B-ALL on the immunophenotype, and the cytogenetics was sent and report awaited. So what are the next steps? Anybody in the panel can take the question. So what would be the next steps in this stage?
I think the first step is when we are waiting for the cytogenetics, but I think we would be more interested in doing a FISH because with a shorter turnaround time.
Yeah.
And we have very specific mutations which are actually prognostic and important in ALL. So that's the first thing. I won't wait much for the cytogenetics. The second is, since there's a high count, I would like to start on prednisone for sure. And by that time, probably attain some kind of a cytoreduction, deal with some infections, see if the patient has got any problems initially and monitor tumor lysis.
Okay.
And yeah, and wait for the, I think wait for the BCR-ABL because that's the only targetable, meaningful mutation in ALL.
So as Dr. Arijit has rightly pointed out, we started her on steroids at 60 milligram per day with supportive transfusions. She didn't have any specific infections at that time. And we were just continuing with prophylactic antibiotics. And cytogenetics came out around 5 to 6 days later and came out to be 922 translocation with 1, 6 in 7 metaphases. The RT-PCR BCR-ABL was sent and it was also positive for E1A2 or the P190 transcript. So diagnosis is at this stage a Philadelphia positive ALL. So now the questions to the panel would be, what is the choice of first-line therapy in this patient? The choice of first-line TKI, when to start the TKI, whether to send for kinase domain mutation analysis at diagnosis, how to monitor this patient, whether allogenic transplant is a must for this patient and for all patients, and whether you would consider TKI maintenance and what would be the choice of the drug and duration of therapy. So let's tackle these questions one by one. And my questions are not directed to anybody particularly. So anybody who's comfortable, what would be the choice of induction to for patients, for this patient maybe? Pritish?
Definitely, the choice between starting intensive versus less intensive therapy, definitely we have to add a TKI along with that. But the intensity of therapy not only depends upon the only diagnosis, but also the ECOG score, age of the patient, other comorbidities also. So earlier studies were usually in favor of intensive chemotherapy along with TKI like hypercivard. But the recent studies also show that even if with lesser intensive therapies, like only with steroids and vincristine also, if you add a TKI, even 100% CR can be achieved.
So any other opinions from the panel? Anybody else would? So basically, I think Dr. Pritish has summed up that for younger patients, we would probably like to consider an intensive regime. But for older patients, particularly with those with comorbidities, we'd probably go with lesser. But because it has been seen from several studies that less intensive regimens carry almost similar CR rates in the early 1 month of therapy. So these are this is the table which is showing the same thing, that this above regimens are TKI with intensive therapies along with imatinib, dasatinib and nilotinib, which are showing an CR rates of 87 to 96%. TKI with non-intensive chemotherapies with all imatinib, dasatinib and nilotinib are showing similarly high rates, and even as low as TKI with only steroids are showing as good as 94 to 100% CR rates in first 1 month, as you can see. So the CR rates are pretty much same in all the groups, and what is notable is that the early mortality is very, very low in the non-intensive regimes. So when we are considering elderly patients who are probably sick with low ECOG performance, high ECOG performance status, we should probably go for a less intensive regime, because, however, we have to have a caveat in this, because the long-term results of these patients mostly had gone into transplant or taken up into a higher consolidation regimes has been given post the induction. So a low induction maybe is yes, but similarly continuing with a low consolidation would probably not be as justifiable.
I think I'd like to add one thing. It's very important that we make a decision
has a
as to
question.
whether to transplant the patient or not. Because I think when you are going to transplant the patient, you should have a very clear idea this patient goes for transplant or not. The patient is going for transplant, you have to achieve a MRD, deep MRD negative status. And in there is no question, you need a intensive chemotherapy. If the patient is not going for transplant, then I don't think there is any benefit of adding a high, at least from the data that is available, because the CR rates and even the molecular remission rates with a good TKI is similar within hyper-CVAD. So if it's a patient is going for transplant, there is no question that the patient needs a intensive regimen. Bhavesh was asking.
Sir,
if a patient young who is fit and has an allogenic donor, will you bombard him with hyper-CVAD and then achieve a CR and an MRD negativity and then take up for transplant? Or you will give small treatment like VCR, PRED and a good TKI right from the beginning, minimal treatment, achieve the same goal and take up for transplant?
That's another great question. So actually, sir, there is definite data that although the CR rates are same, but the molecular remission rates with only low intensity chemotherapy TKI is lesser than, so basically you'll have to give more of those regimens before you get into a deeper molecular remission prior to transplant. The question is how? If you are not achieving a molecular remission after the first induction, how do you get to a deeper molecular remission? Then either two options, changing TKI or going for a consolidation regimen. So if you think the patient is not stable enough upfront, then I think there may be a difference. But other than that, I think I would prefer to go for hyper-CVAD, go into a deep remission, take up for transplant,
Because
especially there is a sibling available.
Even with hyper-CVAD, we need to give at least till 2B.
Of course, till 2B,
to
yeah.
say a good molecular remission.
Yeah. Yes.
That means 4 months of intensive treatment and almost 100 days of admission, not less than that.
Yes.
And then he may not be in a good condition even to be transplanted. So older patients, easy. Young patients, not affording easy. Young patient affording and has a donor, probably I am not sure which way I would go, but I would still prefer to go the lesser intensive way, achieve a complete response. If possible, I don't know. Tushti, do you have information that who achieves CR at the end of lesser intensive induction, do they also achieve a molecular CR in a certain percentage of patients?
Yeah, so yes, there is data. There is data. So there is data which shows that there is lesser molecular remission rates than with hyper-intensive regimens, especially with the hyper-CVAD regimen.
so this is the data, sir, as you are
In
asking.
continuation to that, Tushti, I would like to just ask something. So if you are giving a more hyper-intense therapy, say hyper-CVAD, so would you like to start the TKI as soon as the report comes?
It's the consensus, but it's very difficult because to maintain counts, it might be difficult.
Yes, so would it be better to possibly give TKI from day one with a lower intensive therapy like sir suggested? I mean, it's just a question I'm asking that was...
Molecular response is more important to continue with the TKI and probably give a higher TKI to start with. So that because I will show in the data also that there have been studies in which they have shown that at the very baseline there are a low level of mutations which are already present at the very baseline. So if you are starting with a higher TKI, you are going to achieve a deep molecular response at the end of 3 or 4 months, regardless of whatever intensive or non-intensive or less intensive you are
No,
giving.
so in continuation
So
to your...
probably yes, I would go with sir only that I would probably go for a less intensive regime.
So that you
and
can
try
start
and
it
achieve,
earlier.
Deep molecular response as early as possible.
Right.
Because as Arijit has rightly pointed out, that is the most important factor. Yeah. So next, which TKI to use? As you have seen, there are comparable CHR rates with all 3 generations of TKI. And many patients will exhibit the kinase domain mutations, which is contributing to the TKI resistance. But however, resistance is of a lesser concern if treatment-naive patients are treated upfront with ponatinib. Because it has been seen in several NGS data that many patients will harbor very low-level mutations which are undetectable by conventional techniques. And these patients, if many of these mutations are the T315I mutation, which is only sensitive to ponatinib. So if the patient receives ponatinib at the upfront, So probably the emergence of resistant mutants would be lesser. So if it is available and possible to get the patient to give the patient ponatinib, probably that would be a better choice. However, there are no head-to-head comparisons. That has to be said, that there are no head-to-head comparisons. There is one trial going on about imatinib versus ponatinib, but it's still recruiting, so we don't have the results as of now. So, however, the most important thing that we need to achieve prior to consolidative HSCT is obviously complete molecular response. So, in case of complete molecular response, as you can see, the CMR rates with imatinib, nilotinib, dasatinib and ponatinib, except for ponatinib, the rates are not expressively very much different. It's 50, 45, and here it is 65 with one study with dasatinib, but again 24 with one study with low intensity chemotherapy. Nilotinib, it's a little bit on the higher side, and obviously ponatinib is showing a higher rate of CMR if we are starting it at the upfront status. So anybody with any experience on ponatinib as upfront? I have never used it. So anybody?
We haven't used it upfront. I don't think we have used it upfront. We've only used it in, I think, T315I.
Okay. So again, kinase domain mutations. So having said that, kinase domain mutations are present at low level at the outset. So would you consider kinase domain mutations at the diagnosis?
No.
No. And why is that?
There are two reasons. Basically, firstly, I would like to go to the logistic reason. And so it's not really practical to do it for every patient. And secondly, like you said, not in every patient, a T3151 mutation will be there. Mostly it's seen in case of relapse. So it is more prudent to start with any of the other three generation, the first and second generation TKIs, most commonly used as dasatinib. More often than not, the patient will respond to it. If not, we can go on to the next step. Yes.
So probably that is what...
Another question. I think I'm not a pathologist. Somebody might be better, but I think mostly we are doing it by Sanger sequencing and with a sensitivity of around 15 to 20%. So basically, to pick up those resistant mutations, you need a high size of that clone. And it's usually seen that even if there is a clone, if a resistant clone present, the size of that clone is less. So you won't be able to pick it up when you're doing by Sanger sequencing. Unless you're doing by NGS, it's much more costly and it's not
So
feasible.
this is what this study has also said, that the main changes if patient is receiving first line versus second line TKIs are, there is a change in the type of mutations but not in the frequency of mutation development. If a patient is receiving first line imatinib, he would develop any of the other mutations along with T315I. But if a patient is receiving a dasatinib, in most of the cases, in about 2/3 of the patients will have a T315I mutation at the time of relapse. But that is at the time of relapse, not at the upfront. Upfront, the levels are so low that they will not be detectable in standard testing. So standard testing for kinase domain mutations at the diagnosis is not yet recommended. So to summarize, the combination of intensive chemotherapy and TKI is necessary for fit patients with Philadelphia positive ALL. The TKI should be administered early, concomitantly with chemotherapy and indefinitely rather than starting late and eventually with stopping the TKI treatment. And obviously ponatinib is a very efficacious agent. And this is what they have said. In the future, we eventually hope to get rid of the intensive chemotherapy by using a combination of TKI plus a novel agent such as blinatumomab or any of the other new monoclonal antibodies. So this is the future that we might really consider later on. But as of now, it is still intensive therapy with the TKI. So a TKI should be incorporated and to be introduced as soon as possible. The choice again is unsettled. Imatinib is favoring is longer track record. It should be continued as a maintenance therapy indefinitely or until allo-SCT is done. And quantitative molecular assessments of the BCR-ABL transcript should be used for monitoring patients after achieving hematologic CR. There is no head-to-head comparison between the two TKIs. However, this trial I've already mentioned, EVOL-03, which is recruiting now. The mutation at diagnosis or subsequently will determine the choice of TKI. Certain specific groups like patients with CNS disease, probably dasatinib would be preferable. Ponatinib looks promising, but more data is needed. Few trials are showing as good as 97 to 100% CR rates. And tolerance and comorbidities are important as it is important in CML also. So, it would not be wrong, this is from ASH 2019, it would not be wrong in 2019 to treat patients with de novo ALL with imatinib. So imatinib still holds. So this patient was started on mini hypersevad protocol with imatinib 600 milligrams per day with intrathecal prophylaxis. The CBC normalized after 1 month and bone marrow showed morphological remission. After 3 months, the RQ-PCR BCR-ABL was 0.1%. Patient developed an intolerance to imatinib, so dasatinib was started at 100 milligrams per day. She then underwent an allo-SCT from HLA identical sibling. There were no major complications and the patient was started back on dasatinib, 100 milligrams daily, 100 days after the SCT. Dasatinib dose was reduced to 50 milligram owing to persistent thrombocytopenia. She is currently on 50 milligrams dasatinib and doing well. Now, how to measure for residual disease? So as is there in all leukemias, there are 3 methods of doing it: by flow cytometry, qPCR and NGS. So I would like to ask my panelists which is the method that they are using in their practice and what they would think would be best for their patients.
Actually, there is no standard guidelines and methods to check MRT in Ph positive ALLs. Though RT-PCR is a standardized method to determine the response in CML, but that too detects the P210 only and standardized about P210. But in this case, which you have mentioned in these slides, is having P190, which is not standardized. And apart from that, multiparametric flow cytometry and T cell receptor gene rearrangement and NGS also can be used, but all these are on experimental basis and not yet standardized. No, what to choose, when to do this test are also a matter of question nowadays.
There are no clear time points actually, like in CML, there are no clear time points when to do it. So, Origin?
I think we would prefer doing both flow and an RT-PCR. There's definitely data that P190 can be used. I'm not very sure about the standardization. I think it's standardized. The second point is there's data showing that qPCR is better than flow cytometry. NGS, although it's better in terms of sensitivity, cannot replace qPCR because of its own flaws. Not in all patients will you find the specific primers that you can track, and it has got a high turnaround time. So definitely qPCR plus minus flow.
In some of the European countries, I believe they are currently in the process of standardizing the RT-PCR. So maybe a couple of years down the line, we might get something.
Published by the European Consortium. It was the standardization and consensus guidelines for MRD assessment in Ph positive ALL with the P190 transcript. So this was done in a multicentric trial, and they have actually designed those primers and plasmid primers. There's the Europe Against Cancer study, and they have actually provided detailed laboratory recommendations for the standardization and MRD analysis of routine diagnostic settings and in multicentric clinical trials for P190 transcripts. However, I don't think, yes sir.
Tushti, what is the RQ-PCR value for Ph positive ALL if there is a P190 transcript type saying below this value this is negative, above this value this is positive?
Sir, again, this is not very clear. There are differences in different studies. Some have said 0.01, some said 0.001. So basically, there is not very clear cut which is MRD negative or what is deep molecular response.
So in terms of survival, there is some data which shows that MR4 is the rate that you should achieve. 4.5, it's not that, there is dicey, but 4, there is data showing that MR4 matters.
So if this patient had achieved, which the case she had showed 0.1%, would you like to give more chemo and make it 0.01, 001 and then take up for transplant?
Yeah, that would be probably better, sir.
You will be battering the patient with so much of chemotherapy that he may have a lot of complications post-chemotherapy, post-transplant. Then all purpose of transplant is lost. If you have achieved such a deep molecular response even with chemo, then why transplant?
That is another question.
I am still not sure what level you should say below this I am going to take for transplant anyway.
Sir, actually there are other factors also other than the molecular response, which are not also accounted for, like the presenting WBC counts and the presence of additional cytogenetic abnormalities, which are also high-risk features. So probably on those grounds, this patient had a very high WBC count at presentation and had a 1/6 translocation.
No, the decision to transplant is not questioned. The timing of transplant may be questionable. Decision is no problem. Patient may transplant because he had so-called high-risk pH positive ALL, according to the risk stratification. So one more question, like in CML, is there information that pH positive also hits at different levels? And are the neutrophils in pH positive ALL pH positive or they are pH negative? If so, because we have seen the flow cytometry is MRD negative at the end of induction, and RQ-PCR and the flow cytometry are not correlating with each other. So the explanation may be that the hit is higher and probably the neutrophils also are pH. And then this may be CML into blast crisis rather than pH. So after reading literature, do you have any evidence like that?
Sir, in pH positive ALL also there has been papers published which shows that the neutrophils also express BCR-ABL. And I mean, that's exactly the point why flow and BCR-ABL does not correlate. And I think that's also the point why like purists would always prefer an IgTCR because that's the standard for the blast. So you're actually targeting the blast levels irrespective of which cells you are taking it from. So if the IgTCR is negative, then you probably know. Provided you have a standard IgTCR at baseline.
Yes, baseline patient.
That's time is limited. Sure. The discussions we may do later. Now the next questions, next case you can go.
Okay. So the predictive value of minimal residual disease in Philadelphia positive ALL treated with imatinib was based on this was a study which was compared immunoglobulin TCR and BCR-ABL in all patients, and this showed a degree of concordance, but also the overall concordance was 69%. That means there is only 2/3 around concordance. So there were around 1/3 of patients who are positive by IG and negative by BCR-ABL. So I think if we have to monitor, we probably have to monitor by both, and that would be, I think, a better way to monitor the patients instead of just relying on one method. So this was it. So those patients who had negative to start with, and they're divided into negative, low positives and high positives. As you have seen, the patients who are persistently negative have a high EFS and EFS rates and a lower cumulative incidence of relapse. However, those patients who have become low positive or newly negative or high positive, sequentially these patients will have a higher incidences of relapse and therefore lesser event-free survival. So post-induction transplant and pre-transplant MRD responses in a representative selective series with intensive chemotherapies has been shown with various TKIs and intensive versus non-intensive therapy. The thing that is important here is that with the ponatinib arm, we have seen there is a very high rate of CMR and MMR, as high as 83 and 97%. It is only with imatinib and intensive, and the second one, which is showing only ponatinib, that is also showing quite a high 60% CMR rates post-induction. So probably this point is again highlighted that probably if you can if you can make ponatinib available and you can give patient at the upfront setting, it would probably increase the CMR rates and therefore the long-term survival would improve. So which method to choose? As I've already read, BCR-ABL should be monitored early and often. If possible, you should monitor both and BCR-ABL and the IG and TCR rearrangement, because both of them will give you the proper data that whether this patient is actually becoming MRD positive or not. However, qPCR is more readily available and can be done from peripheral blood. This is obviously for the 2110 transcript. For the 190, I don't think there are standardized assays available as of now. We would probably go with FISH. I think there is no other option as of now, but maybe later on the consensus guidelines have been published. So maybe in a few years' time, we will have the data to establish 190 transcript cutoffs in the pH positive patients. As I've already mentioned, these are additional cytogenetic abnormalities, certain molecular aberrations, the type of the BCR-ABL transcript and kinase domain mutations, which are also additional factors, and these define the high-risk ALL, high-risk pH-positive ALL, particularly mutations of the IKZF1, the cyclin-dependent kinase 2A and 2B. These patients tend to actually do poorly even with allotransplant. So these are the very high-risk groups of patients. So pH-positive ALL is not a homogeneous entity anymore. It is actually a heterogeneous group with a different risk stratifications. There are other studies in which they have seen that the presenting WBC counts of less than 30,000 and early achievement of molecular responses within 3 months are associated with a lesser risk of relapse, and many of these patients are actually can do well even without allogenic transplant. So that is another study. So serial monitoring of BCR-ABL is needed. The prospective assessment of molecular response and imatinib dose intensity is useful, and in a clinical scenario is the best advice currently to be offered is to carry out mutational analysis in case of lack of response, rising MRD or overt relapse. So this is a case 2. A 15-year-old girl presented with low-grade fever and progressive pallor since 1 month. She has generalized lymphadenopathy, moderate splenomegaly. The CBC shows low WBC count. IPD shows pre-BALL. She was started on the BFM 2002 protocol. The cytogenetics revealed a high hyperdiploidy with 922 and a P190 transcript. After 15 days of induction, patient developed severe pneumonia with grade 4 cytopenia. The steroids were tapered. Patient was managed with IV antibiotics and antifungals. The HRCT chest showed a large cavitary lesion in the upper lobe of the right lung. The biopsy from this lesion revealed COX. The patient had a 4-drug AKT was started. Since we had already stopped the induction, the bone marrow was done, and MRD was negative by flow cytometry after just 21 days of therapy. Kinase domain mutations were absent. So what to do next? My panelists, do you have any idea of that?
Patient needs it was diagnosed with tuberculosis, right?
Yes.
Yeah, so I mean tuberculosis and TKIs will have interactions. I think they will need drug modifications.
Yes. No, would you continue with the intensive protocol?
No, I think there is, if there is MRD negative status and the patient is immediately not planned for transplant, we can shift to a maintenance sort of a protocol, continue on the TKI at modified doses with the ATD.
It's 15.
Yeah, but you don't plan for a transplant right now, so I mean, you can go
So
for just for a TKI at modified doses and a maintenance.
Yeah, so that is basically what we did. We put her on imatinib because we didn't get any mutations, and we put her on a sort of maintenance kind of chemotherapy, and she's at present doing well. Let's see what the future holds. It's still early to say. So the role of allogenic SCT, it's been the only means to reach a cure in sizable fraction of Philadelphia positive patients. The TKI-based treatments allowed through transplant more patients by increasing the CR rates. In the TKI era, an allogenic transplant can be performed in up to 45 to 80% of patients, and with contributing to an OS of 35 to 45% at 2 to 5 years and 60 to 70% among allografted patients. These data have supported the current standard treatment of adult PH-ALL, consisting of the induction followed by allograft. So these are the data with imatinib and dasatinib and nilotinib. So we can always see that most of this patient with CT, with SCT are doing better than those patients who are not received any transplant, excepting for probably ponatinib. Most of the patients who are on intensive, non-intensive, whatever may be the kind of therapy, the patients would probably do well with allotransplant. There is no doubt about that. But is it possible for and necessary for all patients? So this was a study where it's a viable option in patients with high and intermediate risk, but for low risk, which they defined as less than 30,000 counts with no high risk features and early molecular response achievement, in those patients probably would do as good as patients who have undergone transplant, even without the transplant, with only chemotherapy and TKI. However, these conclusions will need further verification through randomized studies with larger samples. This is one study. And this was another study in which they showed the addition of dasatinib has shown improvement in long-term outcomes with patients who have undergone allo-SCT. So another last question, is auto-SCT an option?
CRPMTR has mentioned that it's not an option, but I think for patients, I don't think it's an option, but
Well, there are studies actually. So there have been studies in which, can I just finish this? Yeah. So there have been comparable results of autologous and allogenic transplants for adults with Philadelphia positive ALL. This was done and they have actually stratified these patients into 3 groups, and they have shown that the non-relapse mortality or the TRM is actually quite high in patients who have received matched sibling as well as unrelated donor transplants. And when we compare that with relapsed incidence of relapse and EFS, so there is an increased risk of death, particularly in low risk patients. So if the patients are low risk, we can consider, again this is can consider, this is just 1 or 2 studies, but this is an attractive option because auto-SCT is pretty easy to do, and for low risk patients who are doing well with chemotherapy, we can consider, according to the study, we just can consider an auto-SCT, and probably these patients would do well without the added transplant-related mortality. So this is one study which is giving us another idea, another angle into this thing.
But there are various other studies, those have mentioned that even chemotherapy is better than autologous transplant in many cases.
See, there are actually controversies, but this is one study which is showing that yes, this is one a viable option which you can approach. So this is also, other studies are also showing comparable rates with auto versus allogenic transplant. So I don't think I have time. I'll just stop here. So I'll just conclude that therapeutic advances and technological evolution have significantly improved the way we treat Philadelphia positive ALL. However, personalized approach based on risk, treatment endpoints and BCR-ABL mutation status are becoming a reality. In Philadelphia positive ALL, clinical studies are investigating how to optimize the currently available treatment options of TKI, monoclonal antibodies, chemotherapy and transplant in an attempt to minimize toxicity and treatment-related mortality while maximizing the molecular response rates. If the past decade has witnessed the TKI revolution, the next will become a fine-tuning of the TKI use with the definition of rational decision algorithms taking into account biological and clinical prognostic or predictive factors both at diagnosis and dynamically during the course of treatment. So probably it will become individualized. To summarize, it will become individualized in the future for each different group of patients. Thank you.
Thank you, madam. Thank you, madam and panelists. As time is short, okay, one comment. Only one.
We have well-established guidelines.
I can't hear.
We have well-established guidelines. When to stop,
I can't hear you. Sorry. Could you take off the mask? It's vibrating. Yeah. Yes.
When we stop therapy, when we restart therapy, it becomes cytopenias. But in case of ALL also, during induction particularly, we frequently face cytopenias.
Yes.
So, can we adopt that approach in case of ALL induction, and what is the effect of MRT?
So actually, I've not read up this, but what the recommendations are is to give it as early as possible for as long as possible. And whether, I have not gone into the studies, whether if there is a drop in TKI, obviously, there are studies in which there is the study called the ESPH ALL study, which is a study on pediatric ALL, which they do on the BFM kind of trials with intermittent pulses of imatinib during each phase of the HR blocks. And then they take 3 HR blocks and put the patient into transplant. So even with that, they have actually achieved quite a good molecular response. So yes, of course, intermittent therapy is not what is justifiable. We have learned from our data from CML that TKI should be continued uninterrupted for as long as possible. But even with these patients, which is a pediatric trial, they have shown that with intermittent dosing also, they have achieved good CMR rates and they have taken up the patients for transplant with fairly good, I would say, long-term outcomes. I really don't have data on adults, but pediatric trial, one trial is there.
Okay, thank you. May I conclude the session, and thank you all, panelists and madam, and over to the organizing committee.
Thank you, chairpersons, speakers, moderators, and panelists. So we move on to the next session on pediatric hematology. children are not miniature adults. So for that, I would like to invite Dr. Supratam Datto sir and Dr. Madhusmita Sengupta ma'am to chair the session. Dr. Supratam Datto sir is Professor and Head, Department of Pediatrics, IPGMR and SSKM Hospital. And Dr. Madhusmita Sengupta ma'am is Professor, Department of Pediatrics, Calcutta National Medical College. Over to you, sir and ma'am.
Also, there are attractive prizes, first, second, third prize in each category for poster, oral presentation and open quiz. So, names will be announced later part of the day.
Thanks, organizer. In this important conference, a very important session is going to be start now. And the title is Children Are Not Miniature Adults. The topic on pediatric hematology. And the first topic is novel therapy in thalassemia. The speaker is very prominent academician, Dr. Tufan Kanti Doloi. He is Professor and Head, Department of Haematology, NRS Medical College. And he has got interest in thalassemia, including stem cell transplantation. Several publications he has got. We all know him, and he doesn't need any further comments on it. Okay, Dr. Doloi, please start.
Thank you, Chairperson, ladies and gentlemen. So I will be speaking on the novel therapy in the management of the thalassemia. I think this is a very hot topic today, and also in the field of the thalassemia, this topic is very hot because you know the management of the thalassemia is a blood transfusion, the chelation therapy, and also the little bit of the stem cell transplantation. So in the last decade, there is a few development in terms of giving something for our transfusion-dependent thalassemic children. That is, we call that the novel therapy in the management of the thalassemia. But before going to the treatment part, I will give some highlights of the pathophysiology of the thalassemia. Then you can be able to understand how we can apply the novel therapy for the treatment of the thalassemia. You know the thalassemia, we divide mainly in the clinical point of view, the transfusion-dependent thalassemia, and that transfusion-independent we call the NTDT. In terms of the transfusion-dependent thalassemia, patients require transfusion. They cannot survive without any transfusion. We have to give the regular transfusion not only to the month, but sometimes there is 1.5 month, 2 months, the transfusion is required for their survival. And on the other hand, there is a non-transfusion dependent thalassemia, means that the transfusion requirement is not so frequent. They receive the transfusion even sometime the 4 year, 5 years, sometime during the stressful situation, they require some form of the transfusion we call the non-transfusion dependent thalassemia in the clinical point of view. So in terms of this, the transfusion dependent, in general we know the beta thalassemia major and the HBE beta thalassemia, and the same thing also in case of the non-transfusion dependent thalassemia, depending on the genetic heterogeneity, they can divide into the two different categories. But how the symptoms of the thalassemia develop? What is the exact pathophysiology of the thalassemia? So long from this, our undergraduate teaching that in terms of the beta thalassemia, there is a beta chain deficit. So there is a excessive alpha chain production that is called the free alpha chains. This free alpha chain is the culprit for developing the different problem in patient with the thalassemia. In the one hand, there is alpha chrome is there, alpha hemichrome is there, and this alpha hemochrome, this clustering to the brain 3 that leads to the immune revival, and ultimately the hemolytic system becomes involved, leading to the hemolysis of the RBC and developing the anemia. In the other hand, this is the free hemoglobin, the free alpha globin that causes the generation of the reactive oxygen species, and the reactive oxygen species is one of the important culprit for different symptoms in the patient with hemophilia, not only in the terms of the ineffective erythropoiesis, but also developing the hemolysis and developing to the anemia. And on the other hand, the free alpha hemoglobin is also the stimulating the sequestration of the HSP17 pathway. There is a degradation of the GATA1, and ultimately there is a maturation arrest. So in the one hand there is hemolysis, and the other hand there is ineffective erythropoiesis. So till today we are treating the patient with the anemia, but ineffective erythropoiesis we are not treating. So the novel therapy is mainly focusing to the ineffective erythropoiesis for the patient with thalassemia. So in short, there is excessive alpha globin chain production leading to the ineffective erythropoiesis and leading to the hemolysis, and also there is a lot of the problem, there is a transfusion, the chelation, there is a different organ dysfunction in patient with the thalassemia. If we consider the different the problem in patient with thalassemia, I will not go into the detail, but the main thing is the ineffective erythropoiesis. I am trying to highlighting here. That's the ineffective erythropoiesis that lead to the extramedullary hematopoiesis, the expansion of the bone marrow that leads to the bony changes, the skull changes, and sometimes the fracture. In the other hand, there is anemia. If you treat the anemia with the transfusion, there will be iron overload, and that iron overload leads to a lot of the problem in terms of the heart disease, lot of the liver disease, and also a lot of the endocrine. This is the main problem in patient with the thalassemia. And in terms of the NTD group of the patient, they have some hypercoagulability test, and that lead to the thrombosis, the leg ulcer, the pulmonary hypertension that lead to the problem of the patient with the thalassemia. In terms of the NTD, the more or less the pathology is more or less similar, but the hemolysis is slightly little more in terms of the NTD patient, and that recurring the bone marrow expansion is become more, there is hypercoagulable state, the leg ulcer, the extramedullary hematopoiesis. This is the more common seen in case of the NTDT. So if we compare the NTDT and the TDT together, in case of the NTDT, in terms of the extramedullary hematopoiesis, the pseudotumor, the splenomegaly, the osteoporosis, this is the more frequent than the transfusion dependent thalassemia, where there is a transfusion induced the endocrine abnormality, the liver abnormality, and the cardiac abnormalities become predominant in patients with the transfusion dependent thalassemia. So to ameliorate this problem, there is a lot of the therapeutic modality is there for the treatment with the thalassemia. Till now we are treating with the transfusion. We have been giving the Paxil, and to prevent the iron overload we were giving the chelation, and also sometimes we need the splenectomy also to prevent or to decrease the requirement of the transfusion in patient with the thalassemia. But in terms of the cure, there is nothing is there. So we have to give the therapy continuously. So there is accumulation of the expenditure that leads to the hectic problem in terms of this family of the thalassemic child. Stem cell transplantation, this is the only form of the curative treatment in patient with the thalassemia, but you require the HLM sibling donor, and this HLM match sibling donor nowadays in the nuclear family is also become problem. And also in terms of the stem cell transplantation, there is a conditioning regimen, there is a GBHD, there is a opportunistic infection that leads to the increase the morbidity in patient with the thalassemic children. So the other aspects people are also trying to improve the outcome of the patient with thalassemia by giving the HVF induction therapy. There is a 5-azacitidine is there, erythropoietin is there, but the few novel agents will be there, will be coming, and also the supplementing by the antioxidant and the vitamin, there is a doubtful role, and the molecular therapy, the gene therapy, that is called the gene editing technology. Yes, this is the novel therapy has been improving in patient with the treatment with the thalassemia, and also in terms of the iron overload management by giving the apotransferrin, the hepcidin modulation, the JAK2 inhibition is the novel therapeutic agent for the treatment of the patient with the thalassemia. Apart from that, the patient of the thalassemia, they develop a lot of the complications. There is a head-to-toe complication. If you read the chapter of the thalassemia, you can able to identify the textbook of the Harrison. Every organ system has become involved by the thalassemia. It's starting from the pulmonary hypertension, it's starting from the iron overload, the bone disorder, the endocrinopathy, the liver complication, there is a cholelithiasis, and also the thrombosis, the cerebrovascular problem. A lot of the problems happening in patient with the thalassemic child. So the present therapeutic strategy is not enough for the treatment with the thalassemia. So we have a lot of unmet needs for treating the patient with the thalassemic child. Delay the start of the transfusion. There is a HLA match donor, so haplotransplant, the match related transplant, unrelated transplant, there is area. And also to improving the transplant-related mortality by the manipulation of the GVHD and also the transplant conditioning regimen. And the important issue is that cost issue by continuous supporting of the chelation therapy, the blood transfusion therapy, and also you need the multidisciplinary team for the management of the thalassemic child because a lot of the complication and also the quality of the life is there. So there is a lot of the unmet needs for the treatment with the thalassemic patient. Nowadays we are giving the transfusion, chelation and the stem cell transplantation. So what is new? We are not able to cure the patient with the thalassemia. By the now giving the transfusion, the chelation, we are prolonging the life of the thalassemia. But we are unable to cure the child with thalassemia. But yes, the stem cell transplant is the modality. Yes, we can cure. More recently, the gene therapy and the gene editing technology, we can able to cure the patient with the thalassemic. So what are the emerging strategy for the treatment with thalassemia? So we are trying to modulating the immunopathogenesis of the patient with the thalassemia by giving the impaired alpha and beta globin chain imbalance, by giving the gene therapy, by giving the fetal hemoglobin induction therapy, and also by taking care of the ineffective erythropoiesis by giving the JAK2 inhibitor and also the activin inhibitor, that is called the luspatercept and the sotatercept, and also by modulating the iron overload by giving the mini-hepcidin, the hepcidin analog and the temprase inhibitor are in the pipeline for the treatment with the patient with thalassemia. So the transfusion is no more. So the other thing, the gene technology and the other things has become developing in patient with the thalassemia. So in terms of the novel therapy, the erythropoietin, you know, there is a little bit effect is there, but there is a controversial issue is there. The HbF induction, the JAK2 inhibition, the activin 2 receptor trap, that is called the fork head box class 03, and also the approaches for targeting the iron dysregulation and the gene therapy and the gene editing technology is the novel therapeutic strategy for the treatment of the thalassemia. In terms of the JAK2 inhibition, you know the inhibition of the JAK2 that lead to the key intracellular signaling of the EPO receptor that leading to the decreasing splenomegaly in patient with the thalassemia. There is a sotatercept and the luspatercept. This is the two of the TGF beta superfamily. This basically taking care of the late erythroblast and also the other things, particularly the temprase. I will be coming into the subsequent slide for the novel agent of the patient with the thalassemia. But before understanding to the novel agent, you have to understand the ineffective erythropoiesis in the thalassemia. You know, normally in there is the erythroid proliferation, there is erythroid differentiation and erythroid maturation is there. But in terms of the thalassemia, there is an ineffective erythropoiesis is there. So the erythroid proliferation is there, differentiation is there, but the mature RBC is not producing. So the defective RBCs become producing, so there is a problem of the patient with the thalassemia. So we try to taking care of this, the ineffective erythropoiesis by the different agents. This agent that is called the sotatercept and the luspatercept in the trial for taking care of this problem. This both the agents are exactly at the late stage of the erythropoiesis by increasing the mature red cell, independent erythropoiesis stimulating agent with erythropoietin and act either in the early stage and the later stage of the erythropoiesis, but they are mainly acting to the later stage of the erythropoiesis. In the luspatercept, basically it is the recombinant, the fusion protein containing the modified extracellular domain of the actin receptor 2B and it binding to the growth factor domain receptor and also the TGF beta superfamily that lead to the signaling that promotes the RBC maturation and the differentiation. It is in the phase 2 trial, both in the non-NTDT and the treated patient with the thalassemia that showing improvement of the hemoglobin and also the reducing the transfusion burden in patient with the thalassemia. In the BELIEVE 2 trial, that is called the phase 3 trial of the luspatercept, there is a 33% reduction of the RBC transfusion burden vis-a-vis the placebo and it demonstrates statistically significant meaningful reduction of the RBC transfusion in the 12 weeks and the 24 weeks interval comparing to the placebo and also it is the well tolerated. That's why the luspatercept has been approved by both FDA and the EMA for treating the patient with the thalassemia in their recommendation. Luspatercept becomes approved for the treatment with the thalassemic. So this luspatercept there is able to solve some unmet needs in the patient with the thalassemia by improving the erythropoiesis, the reducing the extramedullary hematopoiesis, improving the hemoglobin level and also the reducing the transfusion burden in patient with thalassemia. The next is the JAK2 inhibitor therapy. Basically, this JAK is become expressing in the spleen and also the erythroid. In terms of this, the ineffective erythropoiesis, the JAK is become expressing, and ultimately, due to the ineffective erythropoiesis, this cell is become scaling within the bone marrow, leading to the apoptosis. Those are no maturation of the cell is become producing. So if we inhibit the JAK2, then there is a RBC become producing by inhibiting this the late erythropoiesis. So basically, JAK2 inhibitor is becomes balancing our differentiation and the proliferation of this RBC. This phase 1 trial of the truth trial in the ruxolitinib, in particular in the TDT, there is a reduction of the spleen volume size and there is no major improvement in the transfusion requirement. There is another study is there is a reduction of the transfusion requirement also. So this, the JAK2 inhibitor, particularly the ruxolitinib, has an improvement in terms of the splenomegaly and the transfusion requirement in patient with the thalassemia. The another is the allosteric activation, that is called the PKR pathway, that is called the metapivot. This is the first class small molecule. It is basically the patients become 92% patient become responded and the responses becomes well sustained. There is an improvement seen particularly in case of the hemolysis and there is no serious adverse effect is seen, and this is basically crosses the phase 3 study both in case of the TDT and the NTT in patient with the thalassemia. The another the important inhibitor, that is called the PDE9 inhibitor. This basically the PDE9 inhibitor acting into the cyclic GMP to the GMP. If you inhibit this, there is an increasing cyclic GMP production and there is an increasing fetal hemoglobin production. So this becomes involved in case of the thalassemic mouse model. There is an increasing hemoglobin production, the RBC production and RBC maturation is there compared to the placebo. It crosses the phase 2A trial, particularly in the sickle cell and also in case of the beta thalassemia patient. There is another pathway I already mentioned, that is called the FOX03 activation. Basically, this is the rapamycin, the metformin, these are the drugs, they are taking care of the late stage of the erythropoiesis. And this basically in early stage there is a the cycle, cell cycle arresting, the apoptosis. This is basically the oxidative stress induced the damage is become preventing by this drug. So the oxidative drug prevention and the ineffective erythropoiesis is become taking care of this the FOX3 activation because it is down regulated in patient with the thalassemia. The another target agent I already told you, that is by the iron overload status by modulating the hepcidin. We know in case of the thalassemia, this ineffective erythropoiesis is due to the low level of the hepcidin and that leads to the increasing the iron absorption and there is a iron redistribution into the organ. So in terms of this potential effect of the hepcidin, particularly the hepcidin mimetics, that improving the ineffective erythropoiesis, the reducing the iron absorption, the reducing the iron organ, and the trial also they have a improvement of this the iron status in patient with beta thalassemia. There is another thing that is called the temperance. This is basically the acting onto the hepcidin. This also reducing the iron overload and improving the RBC survival in case of the mouse model. Come to the fetal hemoglobin induction. The lot of the fetal hemoglobin induction in the pipeline, the recently in the decitabine, and there is a thalidomide and this derivative. Basically, this is the HbF production. In case of the beta thalassemia, though the fetal hemoglobin is raised, but this modulation of the little bit of the fetal hemoglobin leading to less transfusion requirement in patient with the beta thalassemia major. Even in case of the beta thalassemia also, if you induce the fetal hemoglobin, the transfusion requirement is become less in patient with the thalassemia. So we have published this literature more recently in case of blood cell molecule and the disease journal. In this, we have been published in case of the 45 patient with the beta thalassemia patient, we have been giving thalidomide, the 50 mg, and also the giving the hydroxy and also the control on the placebo. And in this the short study that there data has been clearly shown us that in terms of the thalidomide group, there is hemoglobin changes become significant. So if you give the thalidomide, the hemoglobin rises is there, and also in terms of the transfusion requirement, if you give this the blue line that the thalidomide that leads to the decreasing transfusion requirement in patient with the thalassemia. So the thalidomide has a role in terms of the reducing transfusion requirement in patient with the thalassemia. Next come to the gene therapy. This is the area of the advancing going into the different subject of the in hematology, and the thalassemia is one of the important thing. In terms of this gene therapy, is basically the HbS collection has become very, very important. The stem cell become harvested from the bone marrow, or we can mobilize it, we can collect it by the apheresis technique. So we have been separating the stem cell, and this separating of the stem cell, ultimately we have to modulate them by transduction or by the gene editing. So you can modulate with them by the transduction by giving the different vectors. I will be coming to the subsequent slide. And ultimately this modified hematopoietic stem cell become reinfusing In case of the gene therapy, particularly in case of the viral induced, we have to give some conditioning regimen to create a pace, and ultimately there is expansion of this the stem cell, and there is a normalization of the blood in patient with the thalassemia. If you are comparing to the gene therapy with the stem cell transplant therapy, that the gene therapy there is no graft versus host disease there. There is not problem in case of the donor availability, and the long-term morbidity you can prevent it by giving the gene therapy. In terms of the gene therapy, the two things is there. There is called the globin gene addition, there is called the functional beta gene or the gamma chain addition, or you can do the gene editing also by giving the reversal of the fetal hemoglobin expression and that correct it to the beta globin mutation. So the factor important in terms of the successful gene therapy is the transduction efficacy and also the transgene expression profile and also the genotype, either the B0 and the B+, and also in terms of the quality of life, the bone marrow microenvironment, that becomes very, very important in terms of this gene therapy. In terms of the gene editing technology, that basically this expressing the fetal hemoglobin, if you go to the cartoon, I will be giving the more cartoon that if you modulate this area, the cutting part of this area, and that it can promote the erythropoietic signaling pathway, and this basically the gene editing technology, how we can improving the patient with in the thalassemia. So basically in the summary, if you go to the summary slide in the gene therapy, there is all into the pipeline in basically phase 1 and the phase 2, and some in case of the preclinical study is there. There is the ex vivo gene therapy is there. So we can able to do the gene therapy by doing the gene editing. The two technologies becomes upcoming in patient with the thalassemia. So in future also the people is trying to do the gene modulation by giving the gene therapy. So in case of summarize that all the novel agents starting from the ruxolitinib, there is reduction of the spleen volume size, there is overall transfusion requirement is there, short arch and loose part arch becomes effective, and also I already told you there is a mini hepcidin by reducing the transfusion requirement. So if you the take home message of my slide, that in terms of the thalassemia, nowadays the people is approaching so the cure apart from the stem cell transplantation, the different aspects of the pathogenesis become tried to taking care. So the thalassemia is basically the common inherited monogenic disorder characterized by the chronic hemolysis, the ineffective erythropoiesis and the iron overload, and the transfusion practice and the chelation therapy is the double-edged sword. Better understanding and the understanding of the pathophysiology that leads to development of the newer technology, particularly the inducing agent of the ineffective erythropoiesis by doing the JAK2 inhibitor and the activin 2 receptor traps that becomes improving and the promising and become approved by the FDA, and targeting the dysregulation by the mini hepcidin, the exogenous transfusion and the erythropoietin inhibits the preclinical study. Particularly gene therapy is basically the rapidly evolving field that exhibits remarkable progress in the recent year. We hope in future we can able to cure the patient with the thalassemia with this novel agent. With this, thank you very much for patient hearing.
Thank you. Thank you, Tufan, for a beautiful delivery of this huge topic in such a small time. I think we'll defer the questions for the end of the session. So we can call the next person, Dr. Shubham Bhattacharya. He's going to speak to us on high-grade B-cell lymphoma. He's an assistant professor in the Department of Clinical Hematology, NRS Medical College. His area of interest is mainly pediatric hematology.
Good afternoon to large audiences. Now I am here to speak on the high-grade B-cell lymphoma in children. Thank you to the organizing committee for giving me opportunity to speak on this topic. In this topic, first, after a brief introduction of high-grade lymphoma in children, I will describe the classifications of high-grade B-cell lymphoma, the individual types and topics of B-cell lymphoma, the management of it, and finally the recent advances of B-cell lymphoma. Now first of all, this is the slide depicting the cell of origin of lymphomas according to the B-cell development. This is the bone marrow, this is the lymph node. The B-cell first develops from the bone marrow, it develops naive B-cell, naive B-cell enters the germinal center, and centroblast and centrocyte develops. Thereafter, it exits from the lymph node in the form of plasma cells. So, lymphomas occurring here in this bone marrow are precursor B-cell lymphoma, namely lymphoblastic lymphoma. The lymphomas occurring in the germinal centers includes Burkitt's lymphoma, diffuse large B-cell lymphoma, and post-germinal central lymphomas are plasmablastic lymphoma, small lymphocytic lymphoma, etc. The incidence of these are very rare in children. Now, if we classify the high-grade B-cell lymphoma in children, these are mainly of 4 types. First is mature B-cell NHL, that is Burkitt's lymphoma and DLBCL. Second is lymphoblastic lymphoma. Third is anaplastic large cell lymphoma. And fourth, though rare, the post-transplant lymphoproliferative diseases. Now, this is the frequency according to the age. If we look at the colors of this picture, this one is in 0 to 14 years, the Burkitt's lymphoma is the commonest lymphoma. And the upper one, the red one, is lymphoblastic lymphoma. So, commonest lymphoma in children is Burkitt's, followed by lymphoblastic. DLBCL, which is a predominant lymphoma in the adulthood, is less in pediatric population. And the few lymphomas, like depicted like yellow zone, these follicular lymphomas are almost absent in the pediatric population. So, pediatric lymphomas are different from the adults. This is a small data from our center. Burkitt's lymphoma is almost 50% as per the data, followed by the lymphoblastic lymphoma, anaplastic large B-cell lymphoma, and followed by the DLBCL. Now, I am going to the individual subtypes of high-grade B-cell lymphoma. Burkitt's lymphoma, first described by Dennis Burkitt in the year of 1945. The first case reported was in 1938 as sarcoma involving jaws in African children. There are 3 subtypes of Burkitt lymphoma, namely endemic, sporadic, and immunodeficiency associated. Endemic Burkitt's lymphoma are mostly associated with Epstein-Barr virus infection. Age is 4 to 7 years with male-female ratio of 2:1. Sporadic Burkitt's lymphoma has a more male predominance with slightly advanced age of presentation. Immunodeficiency associated Burkitt's lymphoma is associated with HIV, and almost 30% cases are associated with Epstein-Barr virus infection. We call Burkitt's leukemia when more than 25% of bone marrow is involved by the Burkitt's lymphoma. Now, the clinical manifestations of Burkitt's lymphoma is a aggressive lymphoma, fast-growing lymphoma. Sporadic Burkitt's lymphoma mainly involves the abdomen with head and neck region. Often in children, these child go to the surgeons because they present with appendicitis-like syndrome with nausea, vomiting, acute abdominal pain, and there is also risk for intestinal perforation, intestinal obstruction, and GI bleeding. The presentation of endemic Burkitt's lymphoma is little different. It involves mainly jaw, abdomen, orbit, paraspinal region, and the CNS. But the Burkitt's lymphoma as an aggressive lymphoma, it has a propensity to involve bone, testis, or bone marrow. Regarding immunophenotypic of Burkitt lymphoma, it expresses B-cell antigens CD19, 20, 22, and surface immunoglobulins. CD10 and BCL6 may be positive. BCL2 and TDT are often negative. It is a high proliferative index of MIB1 of 99%. Cytogenetics is characteristics of Burkitt lymphoma. There is translocation of MYC located at 8q24, it can be translocated either in the 3 location. Most common is the heavy chain locus, that is 814 translocation. It can be translocated to kappa or lambda chain locus. Aberrant aberrations involving chromosome 1, 7, 13 or 22 can also be in the Burkitt's lymphoma. This is a study on secondary chromosome abnormalities which can impact outcome in pediatric and adult high-stage Burkitt's lymphoma, and it shows that if there is abnormality in chromosome 13 and chromosome 22, it impairs a poor prognosis. Staging of Burkitt's lymphoma, it's not only for the staging of Burkitt's lymphoma. This staging is important for every pediatric lymphoma because Burkitt's is a prototype of pediatric high-grade B-cell lymphoma. So Murphy staging is gold standard for staging in pediatric lymphoma. What it is, in stage 1, involvement of single nodal or single extranodal area. In stage 2, single nodal or single extranodal in one side of diaphragm, or if there is primary intra-abdominal tumor which is completely resectable. In stage 3, involvement in both sides of diaphragm or any primary intrathoracic tumor or any primary intra-abdominal tumor which is not completely resectable. And all paraspinal and epidural tumors are classified as stage 3 in Murphy's system. In stage 4, any of the above with CNS or bone marrow involvement. So what is new in Murphy staging system? All intra-abdominal tumor stage 2, all intra-abdominal tumor which is not able to completely resect is stage 3, and all intrathoracic tumor is stage 3. This is risk stratification of Burkitt's lymphoma based on the 2 groups. One is BFM, one is FAB. In BFM, they stressed on the LDH level. In R1, stage 1, RN2, 1 and 2 which is completely resected. The R2 is stage 1 and 2 which is not resected, and stage 3 with low LDH level. In R3, the stage 3 with LDH more than 500 but less than 1000, and in all stage 4 disease with LDH less than 1000. And in R4, stage 3 or 4 with LDH more than 1000 and or CNS positive. The FAB classifications of Burkitt's lymphoma is little bit easier. Group A is resected stage 1 and group C is bone marrow and CNS positive. The rest are group B. The supportive therapy in Burkitt's lymphoma is utmost important. There is more chances of tumor lysis syndrome, should be taken care of. Radiation therapy is almost eliminated. Multi-agent combination therapy is the cornerstone. Initially it was comp-like regimen in CGG group, but nowadays the LMB96 protocol has replaced all other protocols in management of Burkitt's lymphoma. What it is, in stage 1, there should be only 2 cycles of chemotherapy, and stage B, pre-phase plus 4 cycles of chemotherapy, and phase C, pre-phase plus 8 cycles of chemotherapy. So this is the concept of the study, this is the protocol of the study. This COP is pre-phase followed by the induction with COPAD or COPDAM followed by SIM1 and CYVE. The disease assessment in Burkitt's lymphoma was done in 3 stages. First, after pre-phase, if there is less than 20% reduction in the tumor burden, these should go to more aggressive group C. Second, after initial induction, and third, after SIM1. So in 3 phases, the assessment after therapy was done in LMB96 protocol. The prognosis and EFS is excellent with LMB96 protocol. In stage 1, it is around 99%, and stage B, it is around 90%, and stage C, it is around 80%. Addition of rituximab with the LMB96 protocol further improves the EFS. The EFS goes to around 95% with rituximab along with LMB96 protocol. Other protocols like Arcodosum UVAC, dose adjusted epochar and hypercbad can be used in pediatric Burkitt's lymphoma, but the data are inferior compared to LMB 96. DLBCL is a mature B cell neoplasm. There is expression of surface immunoglobulin and B cell associated surface markers. There is a rule of 10 in DLBCL. Around 10% of pediatric NHL is DLBCL, and the common between 10 to 20 years of life. Burkitt's lymphoma is predominantly extranodal, whereas DLBCL has a nodal presentation without involvement of CNS and bone marrow. There are 3 subtypes: germinal center, activated B cell, and primary mediastinal B cell lymphoma based on the gene expression profiling. Younger patients are more likely to have GCV disease. BCL2 expression is basically anti-apoptotic protein, which increases with age and imparts inferior prognosis. In ABC, the prognosis is worse, and double-hit lymphoma with MYC, BCL2 and or MYC, BCL6 expression imparts a poor prognosis. The study on pediatric DLBCL, which shows the pediatric DLBCLs are different from the adult, with more predominance of GCB subtype, and this supports the theme of today's session that children are not miniature adults. Treatment is like Burkitt's-like regimen. The initial enrollment in LMB 96 protocol was Burkitt's plus DLBCL. 4-year EFS was 92%, and there is addition of rituximab improves further outcome. The prognosis of PMBCL is poor with around 66% EFS. Thus, dose-adjusted epochar is being studied in children with PMBCL. There are novel agents in DLBCL like pembrolizumab, obinutuzumab, and venetoclax. These are not classically can be used in children, but these are useful in adolescents and young adults. Lymphoblastic lymphoma classically can be both B or T, but commonly you see T lymphoblastic lymphoma. Oncogenes involved TAL1, LMOT. Notch mutations imparts a better prognosis, whereas loss of heterogeneity of 6q imparts a poor prognosis. And gene expression profile can differ between T lymphoblastic lymphoma and leukemia. We treat lymphoblastic lymphoma with protocols of TLL. Prophylactic cranial irradiation can safely be eliminated. The measurement of minimal disseminated disease in the bone marrow at diagnosis is an important prognostic marker, and often the child who are refractory to the lymphoma, to the leukemia-like regimen can be treated with hypersevere regimen. Anaplastic large cell lymphoma is a pleomorphic large cell lymphoma with anaplastic morphology which expresses CD30. It is almost 10% of pediatric NHL. Classically, is a T cell immunophenotype diagnosed by WHO as a peripheral T cell lymphoma. Most ALCL in children are ALK positive. There are emerging prognostic markers like DUSP22 which imparts a good prognosis, whereas TP63 imparts a poor prognosis. Treatment is like CHOP-based regimen. Anthracycline-based regimen can also be used. Single agent vinblasting imparts around 70% EFS. So childhood oncology group suggested vinblastin in APO backbone for treatment. There are newer agents like brentuximab verotoxin and crizotinib for treatment of ALCL. Post-transplant lymphoproliferative disease, very rare, 100 times common in immunocompromised children associated with transplant, maybe hematopoietic or solid organs. There are 3 types: early lesion, polymorphic, monomorphic, often extranodal, and can manifest as hepatitis or interstitial pneumonitis. Cornerstone of management is reduction of immunosuppression. Radiotherapy, surgical resection, chemoimmunotherapy, or novel agent may have a role in management of PTLD. Primary immunodeficiency syndrome is a unique feature, unique thing, which is pediatric high-grade lymphoma can occur in these primary immunodeficiencies. There is 100-fold risk of malignancy. A child who has developed high-grade B-cell lymphoma, who is developmentally delayed, we should think of these primary immunodeficiencies. The management should be different from the adult because like in ataxia telangiectasia, they are more prone to radiation, so you should avoid radiation both for diagnostic and for therapeutic purposes. Role of PET-CT is yet not fully established as in adult lymphoma. There is high chance of positive predictive value. In relapsed and refractory disease, the prognosis is grim. The overall survival varies between 12 to 16%. Even after in LMB 96, the prognosis is around 28% overall survival. Combination therapy with RICE or ICE can be given, but it often serves as a bridge to transplant. When we are talking about transplant, we should not think in like this picture, there should be full match. We expect some GVL for transplant for the optimal efficacy of HSCT. Hematopoietic stem cell transplant, we consider it for relapsed and refractory disease. There are controversies whether allogenic or autologous transplant should be done, because as most of the pediatric lymphomas are high grade, there are opinion that all pediatric lymphoma should be transplanted with allogenic setting. Disease status as transplantation is a strong prognostic indicator. Salvage rates are higher for the large cell lymphoma. Whatever we may choose, but transplant related mortality was higher in allogenic HSCT. This studies issues this question that whether it is optimal source, allogenic or autologous, and these different subsets of lymphoma shows, except in lymphoblastic lymphoma, there is no consensus about allogenic stem cell transplantation is better than autologous. The efficacy is almost same, but in lymphoblastic lymphoma, definitely allogenic transplant is better than the autologous. CAR-T therapy is effective in different lymphoma, also in pediatric high-grade lymphoma. There is a study that CD20 positive cells who are refractory to rituximab can be treated with CAR-T cell therapy. Minimal residual disease and minimal disseminated disease are the two terms which is unique to the pediatric high-grade lymphoma. MRD, we have seen it in the context of ALL or AML, but MRD assessment can be also be done in pediatric high-grade lymphoma, and it imparts a prognostic significance. And minimal MDD, minimal disseminated disease at diagnosis, which imparts also a prognostic significance in pediatric high-grade lymphoma. I have almost completed my topic, and after that this session is open for question. Now the take-home message is most of the pediatric NHL are of high-grade lymphoma with aggressive behavior. There are diverse group of malignant neoplasm. It occurs in context of primary immunodeficiencies, so management should be done with cautions. There is varied clinical presentation. There is potential for oncologic emergencies like tumor lysis syndrome. Management should be done as a team, which includes pediatrician, developmental specialists. There is combination of chemotherapy with immunotherapy. Most of them has a good prognosis, but survivors are at risk of long-term sequelae, especially anthracycline-related toxicity or CNS toxicity. Thank you all for the patient hearing.
Thanks, Shubham, for a very good presentation of a common childhood malignancy. And questions are welcome at the end. And thanks for the keeping yourself limited to the stipulated time also. So we are moving to the next speaker. Questions are at the end. Our next speaker is Dr. Atoshi Basu. She will speak on refractory cytopenia in childhood. Dr. Basu, she is from a prestigious organization of Kolkata, Apollo Hospital, and she is there as consultant hematopathologist. So Dr. Basu, please.
refractory cytopenias in childhood. Yes, I am a senior consultant pathologist and slightly feeling out of place, and working now with Apollo hospitals after having done a tenure in the army. Once I started reading on the topic, I realized that it is not only difficult for the pathologist to interpret these cytopenias, but there is a whole deal of data which I could not put into 20 minutes. Hence, this is just an overview. Where does the story begin? The story always begins with the Bible. And so in WHO classification of tumors, this is the revised 2016 edition. And pediatricians have been wondering, seeing children with cytopenias, the pathologists are seeing children with cytopenias. And as far back as 2000, when WHO took up the challenge of classifying adult hematological malignancies, there was ongoing work with the pediatricians as well. And in 2008, the diagnostic categories which were established was refractory cytopenia of childhood, which I will spend some time on, and refractory anemias with excess of blasts, and refractory anemia in transformation. The criteria for refractory cytopenia of childhood, I've said, remains the same as the previous edition, which means that even today it is a possible entity. It has not gained entry into the classification echelons. It is still a provisional entity. And of course, the median age of diagnosis is 6 to 6.8 years, and the male to female distribution is the same. Now, as soon as the classification of childhood MDS came up, there were going to be limitations, there were going to be discussions. Now, the main discussion was that is there any category in the WHO to account for pre-existing constitutional syndromes, which 30% of these pediatric MDS patients seem to have. And of course, what about the pre-existing bone marrow failure syndromes? We'll touch upon that later. And there were certain features which were unique to pediatric MDS. And one of them which stood out at that time was that there was a high incidence of fibrosis. Now, MDS with fibrosis in adults was a rare entity. And probably the most glaring problem was that there was a lack of correlation. Lack of correlation between your blast percentage and the prognosis of the patient. Now, this was this is looking better. Refractory anemia with ring sideroblasts, we are being taught over and over again, it does not exist as far as pediatric MDS is concerned. They normally present with cytopenias, refractory cytopenias, whereas adult MDS has got refractory anemia. Here we have uncommon isolated anemia is probably the most uncommon presentation in a child. It is usually presentations are of thrombocytopenia and neutropenia. Hypocellularity of the bone marrow, where in adult MDS you're going around looking, is the marrow hypercellular? The first thing the clinician asks the pathologist. RAEB means in transformation has been retained in childhood MDS, whereas it has now been taken out from your adult MDS. And lastly, what I had said, I'm repeating, that the blast percentage in RAEB 1 and 2 no longer are not that significant in pediatric MDS and do not actually modify your treatment conditions. So hence, there was felt a need of a provisional entity in which most things could be put in. Just a word about childhood MDS, of course, uncommon in children. Less than 5% of all hematopoietic neoplasms below 14 years. Personally, I don't know, I'm sure the clinicians have seen many more, but pathology-wise, I think I would have seen 3 or 4, and I'm in this profession for last good 28 years. So, etiology, primary, there is, we will talk about GATA2 mutation, germline mutation, no talk will be complete without it, and of course the secondary to inherited bone marrow failure syndromes and acquired severe aplastic anemia. Monosomy 7 is the common cytogenetic abnormality, although certain somatic mutations which alter the genes of the RAS pathway have also been found. Now let's come to the provisional entity, which is almost akin to what we or the title of the talk today. It is characterized by persistent cytopenia with less than 5% blasts in the bone marrow and less than 2% blasts in the peripheral blood. Clinical features are actually because of the decrease in the peripheral is because of the various cytopenias, and the most common symptoms are malaise, bleeding, fever and infection. 20%, not a small number, are asymptomatic. Congenital abnormalities may be present, and some patients very rarely may present with hepatosplenomegaly. Now, this is your minimal diagnostic criteria as per WHO to call a person or to call a child as refractory cytopenia. The bone marrow aspirate has the maximum number of changes in it in the erythropoiesis, megaloblastoid, dysplastic granulocytes, but less than 5% blasts, and megakaryocytes, micromegakaryocytes. Micromegakaryocytes are extremely common and almost like a hallmark of not only refractory cytopenias of childhood, as well it is also there for myelodysplastic syndromes in children. The bone marrow biopsy has a very few, or it's not 20%, I'm sorry, that is an error. It's more than 20% erythroid precursor clusters, means each cluster will have 20%, and there is an arrest in the maturation. Pro-erythroblasts dominate, and unequivocally there are micromegakaryocytes in your aspirate, and it may, on your biopsy, and it is mandatory to do CD61 and CD41 to mark out the megakaryocytic markers in IHC. Peripheral blood, of course, we will come to that. That 3/4 of the patients have thrombocytopenia, half of them have anemia, and there would be some who have fetal hemoglobin is raised, and leukocytosis is generally not a feature. And if you are finding leukocytosis on a normal CBC with a clinical diagnosis query, myelodysplastic syndrome, please look back and see if you're not missing something. Bone marrow findings, it is usually hypocellular. 80% of the children come with hypocellular marrow. Dysplastic changes may be seen at least in, I seem to have lost the pointer, in 10% of the cells of a lineage, or at least 2 lineages, and islands of immature erythroid precursors can be seen. Megakaryocytes are decreased or absent, the normal ones, and few micromegakaryocytes will be found if you do a CD41 or a 61. Reticulin. Reticulin is very important, as reticulin shows background fibrosis in the pediatric age group and is associated with monosomy 7. Sometimes you see fibrosis and you may go back and do a study for monosomy 7. Oh, this is a schematic diagram making it little easier to understand. Pseudopelgia, macrocytosis, your clumping of chromatin. Then you have, if you come to the erythroid series, you have macrocytic. Macrocytic and megaloblastic changes are what are the commonest. And then you have normal megakaryocyte. You may get separated nuclei like this, or you may get a micromegakaryocyte. I'm sorry for the spelling. And there are small binucleated megakaryocytes as well. This is just to bring home that there may be dysplasia in every lineage, or there may be dysplasia in 1 or 2 lineages, but there will be usually bilineage dysplasia. Children who meet the refractory cytopenia with multilineage dysplasia should be considered to be having refractory cytopenia of childhood. I don't know how many people in the audience will agree. I look upon it as a prospective question that what is the take on this? But right now, the provisional entity seems to be growing in numbers. CD34 staining is obviously very useful for identifying myeloblasts. Be very careful of hematogones because these are small children, and of course the fatty tissues which is there when we mimic aplastic anemia. At least 2 biopsies 2 weeks apart would be from 2 different locations of the pelvis would be required or is recommended to facilitate the detection of a representative bone marrow space. Yeah, okay, some photomicrographs. I don't know this. I don't know how much you can see. Can you see the pointer? I seem to be working. Where's the pointer? This is the pointer, no? Okay, just. Okay, we have got very large erythroid precursors, the ones which have got bluish cytoplasm and have open nucleus. And here you can see, again I will seem to have, it's not coming on. Battery is gone. Achha, just put the pointer here, no? Where's the pointer from here? Come put your pointer. Yeah. Okay. Thank you. So even you have a late normoblast here, which is still showing you open chromatin. I'm fine with this. And of course, megaloblastic erythropoiesis. Extremely limited granulocytes. Most of the cells that you see are normoblasts, the one, or you're seeing megakaryocytes, and this is a bilobed neutrophil that I've tried to show. This is a bone marrow aspirate where you're seeing lots of cells, but if you notice that there are very few erythroid precursors and most of the cells actually are megakaryocytes, it's not very clear. You can make out that they are not very lobulated or do not have, they are smaller. These are also megakaryocytes which are small in size. CD34, CD117, these two are IHC slides which is supposed to, which will aid us in diagnosis of childhood MDS. And of course, this is reticulate stain with a HAD showing evidence of fibrosis. That is CD34 and that is CD61 on IHC. Okay, now the job of histomorphology or the bone marrow aspirate and biopsy, the interpretation is quite difficult. There is very little things to go with to be able to come to this diagnosis. So, and in fact, this is from WHO. They have said that these are the morphological conditions which are which cannot be distinguished from refractory childhood cytopenias. So you have infections and you have vitamin deficiency, which the list is absolutely from metabolic to autoimmune to inherited to acquired aplastic anemia, so that it is really a heterogeneous group and they all come with refractory cytopenias. Now we have the syndromes predisposing to MDS in children. I already told you that probably I will not be able to take up all of them but most of them do come to you with refractory cytopenia sometime or the other. So you have the inherited bone marrow failure syndromes. I'm sure people in the audience are quite familiar with the list. And you have germline mutations with and lastly you have Myeloid neoplasms with germline mutations within pediatrics can again come with refractory cytopenias. Just a word about your inherited bone marrow failure syndromes. This is just to depict the pathogenesis, not going into details, not going into the genes. There is a problem here in aplastic anemia, as you're all aware, with DNA repair and cytokine homeostasis. Then you have the telomeropathies, of which disc keratosis congenita is the principal one. And of course, ribosomopathies, ribosomal assembly failures and function, Diamond-Blackfan and Schwartzman-Diamond syndromes. And lastly, you have a myeloid maturation arrest, which with severe congenital neutropenia, and all of them may come with childhood MDS with cytopenias and may progress to AML. Progress to AML is also quite it's not so, what should I say, not so insignificant. So this is the workup which one should do. A blood count will reveal pancytopenia. Once you have excluded sepsis and viral suppression, then bone marrow aspirate and biopsy. I showed you a couple of things that we look for in myelodysplastic syndrome, and you are well aware that cytogenetics plays a big role. A couple of, we will have to go over the fact that we are continuously trying to make out refractory cytopenia of childhood from severe aplastic anemia. I will not read out this slide because I think I have spoken enough as it is, and I will rather go to the pictures which show the fatty, this is mainly made up of fat. And we do IHC to show the various lineages. And as in aplastic anemia, sometimes it's very difficult to find megakaryocytes, and IHC may be done with 41 or 61, and usually they are normal. Now coming to cytogenetics, monosomy 7. Monosomy 7 is the most common cytogenetic abnormalities, 8, trisomy 8, 21, and loss of chromosome, part of chromosome 20, complex karyotype, may all be present, but mostly there are chromosome 7 aberrations. But the most important factor that we have to build into this is that 61 to 67% patients have got normal cytogenetics. GATA2 mutation, just a word, because it is been extensively studied for germline predisposition in childhood MDS. We know that it can present with immunodeficiency. You know that it can present with lymphedema, alveolar proteinosis, B, K, NK, monocyte, all kinds of problems. But GATA2 status does not affect your prognosis in childhood MDS. I will skip this slide, but I had put this slide for the PGs, that with GATA2 on one side and the new marker SAMD9, and this place, in between it's all unknown. So maybe you all can take it up and study it further. Yeah, I wanted to, even if I don't know whether I have time, I wanted to go through this very quickly. This is a survey done by the North American Pediatric Aplastic Anemia Consortium. And it is an extensive study which has been done, but there is a disturbing line here which says the remaining centers felt, a lot of them reported refractory cytopenia of childhood, but a lot of people felt that these were just a histological description. And although there was a consensus on a lot of things regarding stem cell transplant, but the modus of treatment, no clear consensus emerged. Hence, probably this will remain a provisional entity for some time. Treatment options, allogenic stem cell transplant. I think it will be better if I go over to this slide. This is almost the last slide, which says that if you have a normal karyotype and the patient is transfusion dependent and your ANC is more than 1000, you can watch and wait. Transfusion dependency is there and it is less, then if you have a matched sibling donor, go ahead, transplant. If you have a hypercellular bone marrow and you don't have a person who's a sibling donor, then probably immunosuppressive therapy. But all the papers which are there do not really speak of immunosuppressive therapy in the light of MDS in children. Of course, I can always stand corrected with the clinical hematologists. Yeah, this is just a word about advanced MDS and therapy-related secondary MDS in childhood. These are actually not references. These are actually further reading material for the postgraduates. These were very excellent articles which I thought with a lot of good work has been done, a lot of work has been done, especially of course, I don't know if I've put that article, yeah, Inga Hoffman. That is an excellent review on all pediatric MDSs and does a good job of defining refractory cytopenia in children. Thank you so much, and I thank the organizers for giving me a chance to come here and interact. And I would like to place on record my thanks to my postgraduate, Dr. Rajoshi Aich, who has helped me make these slides. Thank you so much.
Thank you, madam. It was a very good topic and a very good, you have addressed it very well. Now we would like to invite the questions for all the three. That is Dr. Tufan, Dr. Shubham, and ma'am, please. Or, you can come and sit over here when they ask questions.
My question is to megakaryocytes, maybe we may not get a megakaryocyte in this RCC also. In absence of megakaryocyte and the diagnostic dilemma between severe aplastic and this.
Yeah, I had
Ma'am, do it also has increased number of plasma cell and mast cell like
No,
aplastic?
actually, that is one of those CD34 and mast cells and lymphocytes have been mentioned as criteria, but they say maybe the same, maybe increased, maybe decreased. They don't have, diagnostic significance. We do think that severe aplastic anemia means we'll find lots of lymphocytes and mast cells, but you may find them in refractory cytopenia of childhood as well. So the current thinking is that if you find by doing CD61 or 41, that is glycophorin 3 and 2B and all, if you find, then you look at the megakaryocyte and see if it's dysplastic or not. Is it small? Are the nuclei separated? So hence, I feel that it is really a challenge to the pathologist to be able to get down to that level and see things.
Like cytopenia, do we do DCT or those stuff also?
I can't hear you well.
DCT, if it's bicytopenia, direct Coombs test.
Yes, workup is going to be done because you see, if you see all the connective tissue disorders, we said rheumatological disorders are a very, autoimmune disorders. In fact, what is that one, that autoimmune lymphoproliferative disorder comes as one of the differential diagnosis. All that workup will be done. Actually, means your inherited bone marrow failure syndromes, I have really not done justice to it. There's so much to talk about in genetics and how we are doing, we will go about testing for them.
Okay. Thank you, ma'am.
Ma'am, regarding almost the same question, similar doubt. Ma'am, suppose there is erythroid dysplasia, which is more than 10%, and it's in hypocellular marrow, we are not giving MEGs. And in that case, there is erythroid dysplasia, more than 10%, only erythroid dysplasia, granulocytes are normal, MEGs we can't see. In that case, what will we go for what will be our provisional diagnosis in that case?
WHO recommends that you do a CD for 61 and 41, and it also, WHO does not, I don't know if I have the reference to the paper, which says do it twice from different sites and then see. The other interesting part was that, there are cases of refractory cytopenia who have up to 20% blasts, but still they are not being taken into MDS. Because on observation, it has been found that these children don't do so badly in the absence of monosomy 7, of course. Monosomy 7 presence with GATA2 and is sort of an indirect indication that the child might need bone marrow transplant. At least that is my understanding of it.
Thank you so much, ma'am.
Any other question? To Professor Doloy or to Dr. Shubham? I have one question for Professor Doloy. In your presentation, you have shown a very nice study, comparative study between thalidomide and hydroxyurea.
Yes, yes.
In the management as a gamma chain inducer in the management of NTDT. We the pediatrician, we are still using the hydroxyurea as the gamma chain inducer. What is your suggestion to us? Should we change our practice? Should we, because the thalidomide, you have shown that in all aspects this is superior to.
Yes, yes. Yes, this is a very critical question, and thanks for the chairperson for noting this thing. Because in terms of the beta thalassemia and even the few paper in beta thalassemia major also the people are giving the thalidomide. There is a study have been published in the several journal also. So ideally there is a no phase 3B study is there in terms of the legal aspect. But yes, if you prescribe the beta thalassemia patient and also the beta thalassemia major patient, even in case of the children, I think there is no harm. Because we recently changed the practice for last 2 to 3 years that we have been giving the thalidomide for the patient with beta and the beta thalassemia major. Because important aspect is that in that thalidomide cases, there is a major side effect is not there. The good thing is that we are not doing any harm to the patient by giving the thalidomide. But yes, we are trying to improving the transfusion frequency, means decreasing the transfusion requirement and also the hemoglobin. As there is no major side effect is there even in the study, so I think we can give it.
Okay, thank you. And another thing is that many clinicians, they are using it for thalassemia major also.
Sorry?
They are using it for thalassemia major also. The
Thalassemia major also, both intermediate and the major.
Any authenticity, any utility of using that in thalassemia major also?
Yes, because I already told you that, because the idea is that hemoglobin F productions. Apart from that, thalidomide has a lot of other immunomodulatory effect is also there. So not only the fetal hemoglobin production, but thalidomide is also aspecting the other way in patient with beta thalassemia major. But the study is more in favor of intermediate patient where the response is robust. In beta thalassemia major, the response is not so much high. Though it is the increment is around 15 to 20% of the patient, they have an increment of this totally transfusion free into the earlier study. But if you consider intermediate patient, the response rate is ranging from 70 to 100% into the different study. So thalassemia intermediate, yes, thalidomide is an option. Beta thalassemia major, if you don't have any transplant option, you can give.
Okay, thanks. Questions? Any question for Shubham Bhattacharya? Any question?
So we would like to end the session, and I would like to thank the organizers for allowing us to be the chair for this very informative session. Next session.
Thank you, chairpersons and speakers, for such a wonderful session. So we now move on to the next session on hemophilia. A little rice is enough. So as chairpersons, I would like to invite Dr. Bidyut Goswami sir and Dr. Gopeshwar Mukherjee sir. Dr. Bidyut Krishna Goswami sir is Professor and Head, Department of Pathology, North Bengal Medical College. And Dr. Gopeshwar Mukherjee sir is Professor and Dean, Allied Health Science Department, Brainware University, Kolkata. Over to you, sirs.
So we are going to start. A little rise is enough. Hemophilia. Our first speaker, Dr. Shantanu Basu. And I think she is in no need, he is in no need of any introduction in hematology in state as well as in India. Okay. Sir, you please start.
Thank you, Chairperson, sir, for this kind introduction. I am actually standing here for Dr. Moitri Bhattacharya. As you can see in your program that this was originally scheduled to be given by Dr. Bhattacharya, but she couldn't come up at the last moment for some problems. So this is a last minute hall collection of slides. So please bear with me if there are discrepancies. Okay, so the better treatment of hemophilia. The hemophiliac's life has been near normal in the advanced countries. It has gradually progressed in the 1900s from 13 years of lifespan to a near normal lifespan. How did it happen? The basic problem lay with the joint bleeds. The advanced countries have minimized the joint bleeds and the arthropathies, which are the major problems in hemophilia. And the emphasis was on arthropathy and joint bleeds for the treatment of hemophilia to start with. So, why prophylaxis? What does it do? It actually aims to increase the factor levels of more than 1%, which is from a severe hemophilia to a moderate hemophilia, so that the person doesn't bleed spontaneously as much as before. This was the original thinking behind primary prophylaxis. We owe a debt of gratitude to in the field of prophylaxis to Professor Inga-Marie Nilsson and her colleagues from Malmo in Sweden, and Professor Van Creveld and his co-workers in Utrecht, the Netherlands. These two groups began programs of prophylaxis in the boys with severe hemophilia in the late 1950s and 60s. The results have which been reported after more than 20 years of follow-up. You see how advanced they were and what importance they brought. This is Professor Inga-Marie Nilsson, and she reasoned that if the plasma concentration of factor VIII could be maintained at the level of at least 1%, you see it's 50s we are talking about, of normal in severe hemophilia A, it might be possible to change the hemophilia from a severe to a milder form. Even if I refer to hemophilia A all the time, please consider it is also true for hemophilia B or factor IX deficiencies. You see, it is not a new concept. It's there with us since 50s. And what we were thinking then was the regular replacement of missing clotting factors given in anticipation and with the intent to prevent bleeding in persons with hemophilia. What is the new thinking? All of that, plus there is an addition that allowing persons with hemophilia to live active lives. We know there are three types of prophylaxis: primary prophylaxis. It starts at the first bleed or at 2 years or 3 years of age. Secondaries after 2 years or after joint bleeds, before the onset of a joint disease, and the tertiaries are after the joint has deformed or there has been inflammations in the joint. And intermittent, we always get, we sometimes get the factors, we sometimes don't, so it really becomes intermittent, but in advanced countries, there are reasons to be intermittent even from the personal point of view of patients with hemophilia. What was the established prophylaxis regimens? There were high dose regimens of 25 to 40 international units per kg per dose, which is the Swedish or the Malmo protocol, and there was a Utrecht or intermediate dose protocol at 50 to 30 international units per kg. Now let us see a 30-year follow-up of what has happened with those intermediate and the high doses. Look at the joint bleeds. In intermediate, we have approximately 1.3 per year, which is still very low, but at the high regimes, it is 0. Let us look at quality of life. It is much better with the Swedish regimen, high dose regimen, than with the intermediate dose. And of course, the cost is also very high with the intermediate dose, but also the results are much, with the high dose, and the results are also much better. Now, so what are the advantages of prophylaxis? Reduce the number of bleeds, halt the joint damages, no life-threatening bleeds or pain, less hospitalization and need for surgeries, less frequent monitoring, better quality of life, and near normal life expectancy. There's a whole lot of advantage in going for primary prophylaxis. What are the evidences there? These are two studies. There are many, just quoted two studies. I will only talk about their conclusions, the Musvi and the Esprit study, where it says that prophylaxis is the only way to preserve musculoskeletal function in hemophilia. You know, musculoskeletal function is an important part of life. You don't realize it unless you lose it. And it has been proved that primary prophylaxis helps in preserving the musculoskeletal functions. And of course, the Esprit study, where the randomized trial confirms the efficacy of prophylaxis in preventing bleeds and arthropathy in children with hemophilia, particularly when it is initiated in early life. Primary prophylaxis is the emphasis. Let us look at the world population of hemophilia. In India, we have around 17,000 factor 8 hemophilia A patients, which is somewhere around 10% of the world population. Look at Brazil. Let's focus on Brazil, because Brazil is very much near to India in economic ties. See, there are 77% under 18 prophylaxis. It is precise estimate, but when in the adult it goes down, because you know in prophylaxis you need more dosages and it is more expensive. So in an emerging economy it becomes difficult to give adult prophylaxis. Now this is India. I am sorry to say that less than 5% are on prophylaxis. Prophylaxis is yet to take root and match the global standards. Minimal coverage of prophylaxis in India, morbidity and mortality. Look at it, less than 5% on prophylaxis, and look at it on demand, 95%. We have disability, decreased quality of life, death due to serious bleeds. So what happens in on-demand treatment in India? We have seen it all. Just to remind you, frequent acute bleeds, factor replacement after bleeding has occurred. As you know, this is the usual story, if you get the factors. And long-term complications due to late or inadequate treatment, no comprehensive care, disability, decreased quality of life, and early death due to serious bleeds. So, how does disability affect the life of hemophiliacs in India? 1 in 3 of the persons with hemophilia discontinued education. Half of the PWH aged under 18 years, more than 18 years or more, are unemployed. Many of the persons with hemophilia find it difficult to even get up from the chair or climb stairs. So it is a crippling disability, poor quality of life, and few are able to reach their potentials, all for want of a drug. Look at it, only a very small percentage of persons PWHs are free from disability in India. The disability progressively increases from 5 to 12 years of age to 25 years, where it is 38% in 5 to 12 years, has gone up to 79 or nearly 80% after 25 years. And considering that we have 17,000 of patients only, do we need to look at it this way? So why the low rates? Lack of awareness? Yes. Absence of comprehensive home care and infrastructure? Yes. Misconceptions regarding treatments amongst PWH, like, well, if I get it, it will be inhibitors, I'll be getting inhibitors, you know, little learning is a dangerous thing. Perception that prophylaxis costs exponentially more than on-demand. This is for the administrators. They are not ready to give prophylaxis in a large scale because they think the costs do go up. So, how do you overcome these challenges? We need to overcome these challenges. Would primary prophylaxis help in changing the mindset? Yes, it would, because then the disabilities would come down. The society would reap the advantages of these patients who are no more patients then. They are near normal. So, whom to start? How to start? Well, initially we could start with children if you don't have. Personally, I would prefer for everybody to start. Look at the effect of age. The early initiation, primary prophylaxis is important because of better outcomes. You see, the curve on the left is where there are more than 6 bleeds. So, those who had significantly better outcomes had less bleeds, less than 3 per year. And those who had more than 6 bleeds a year had a worse outcome. And this is the same thing, effect of number of joint bleeds before prophylaxis. So, what does the new WFH guidelines in management tell us? In 2020, they say that prophylaxis is a standard of care everywhere. Prophylaxis, we can now do better. Prophylaxis can now be tailored and individualized. We are looking beyond just giving prophylaxis as a one-shot measure. We are looking at personalizing prophylaxis. Some people may need more, some people may need less, and we can balance it for a very good quality of life. For patients with hemophilia, WFH strongly recommends that such patients be on prophylaxis sufficient to prevent bleed at all times. Now, in this 21st century, we are not ready to accept only less than 3 bleeds. We are only open to 0 bleeds. In countries with significant healthcare constraints like us, WFH still advocates for the use of prophylaxis over episodic therapy, but recognizes that less intensive prophylaxis may be used. I'll talk about that a little later on. And patients with severe hemophilia, especially children, recommends long-term prophylaxis as the standard of care, maybe lifelong. People who bleed more may need lifelong. When prophylaxis is not feasible, episodic therapy is essential for the treatment of acute hemorrhage, but will not prevent long-term joint damage. Let us get away from this. So, WFH recommends early initiation of prophylaxis with clotting factor concentrates prior to the onset of joint disease and ideally before the age of 3 or immediately after the first joint bleed, whichever is earlier. So, all forms of prophylaxis provide superior benefit over episodic therapy. Low dose, high dose, all forms. Prophylaxis is the way to go forward. It is being increasingly recognized that factor trough levels of 1 to 3%, original 50s, they said more than 1%. Then we found out maybe more than 3% of trough levels will help. But now they have found out are insufficient to totally prevent bleeds, no 0 bleeds in that. So, in all people with hemophilia and allowing occasional clinical and subclinical bleeds resulting in gradual progression of joint diseases. Even when you are on prophylaxis, low dose prophylaxis, you are having progressive joint bleeds. In the 21st century, we are trying to get rid of that. So, most clinicians would now prefer a target of higher trough levels of more than 3 to around 5% or higher. And targeting higher trough levels is essential to reduce bleeding risks to 0. We are looking at 0. So, benefits of lower infusion frequencies is only one, you need less infusions. But the benefits of higher factor trough levels are more important, and extended half-life clotting factor concentrates are very important for this because they benefit with lower infusion frequencies and people don't have to visit the hospital as frequently as they have to do it now. Tackle these. There are algorithms to tackle these, different needs and different times of life. So, the progress of hemophilia management has been from to primary prophylaxis to secondary and tertiary dose prophylaxis, and now we are trying to shift to a more economic forms of low dose prophylaxis and optimum care of hemophilia where we get 0 bleeds wherever possible. What are the patient burdens in prophylaxis? Need to come often, needs many venipunctures, needs to visit HTCs, central venous access. Well, all these are there, but I have been doing prophylaxis, I have done prophylaxis for quite a long time, and I can tell you none of these matter. When you teach the patients, it doesn't. Yes, cost burden is much, but if you look into the cost burden of hospitalization, probably they will match. I have data which shows that cost burden of prophylaxis is slightly more than the episodic with just the cost of the drugs. But if you consider all other, I think prophylaxis would not be more expensive than episodic. Important to start a prophylaxis. On-demand treatment has benefits of stoppage of bleeding, but the costs of on-demand treatment are high, as I told you. The prophylaxis treatment has more benefits in terms of quality of life, disability, joint disease, and decreased bleeding. Only the cost is a little bit of a higher cost factors are matters. So, prophylaxis determinants are trough levels now, acceptable number of joint bleeds, which is 0 for us. Bleeding triggers, arthropathy are not acceptable, and normal life. But one has to remember that patient acceptability is central to this disease. So let us see what happens in episodic. You see the number of bleeds every month, 30 bleeds per year. What happens in prophylaxis? It's only 3 bleeds per year. Stories in the Indian context. This is where the first prophylaxis study started. It started in 2010 with 104 patients on prophylaxis. We had at that point of time decided to start with 20 units for factor 8, 20 units for factor 9, once thrice a week and twice a week, 6% reductions in annual bleed rates. What were the challenges? The same one, administrative, physicians, patients. We can all overcome that. No point in discussing it all the time. Approach to tackle the challenges is education, education, education all the way for the doctors, for the administrators, for the patients and everybody else. This is the result of prophylaxis from 2010 to 2016. You see, most of the children have very minimal joint damages. They are happy and they can play very well. Now, as I told you before, there is an Indian experience with low-dose prophylaxis. Started as an overall reduction of joint bleeds for prophylaxis in the group by 88%. So that is also feasible, low dose, when you can't do. Then there is Neeraj Siddharthan from Kerala. He is a young chap with a good job. Factor 8 concentrates, he started 20 to 40 units, higher units, but 2 divided dosage a week. And for factor 9, it was once a week. And outcome is the joint damage, the bleeding rates came down from 14.9 to 0.91 annually. So yes, this is another way to go. And of course, from our homegrown NRS Medical College, you see, low dose, new dose initiative, but this was done on long-acting ones. And as you can see, before prophylaxis and after prophylaxis, the mean annual bleed rate goes down. Another study with tertiary prophylaxis with low-dose prophylaxis, quality of life, work abstinence, before prophylaxis 76, during prophylaxis 9.4. Study of secondary versus tertiary prophylaxis in hemophilia children under 12 years of age in an NRS hospital. You see, even with tertiary prophylaxis, as the prophylaxis progresses, the joint bleeds go down, the problems go down. So, in conclusion, the ultimate management goal should be the access to treatment for all people with hemophilia appropriately and adequately, supportive care, 0 infections, 0 bleeds, 0 inhibitors, and access to treatment, ultimately disability-free hemophilia. That is what we should look forward to in 2021. Before thanking you all for patiently listening, I must acknowledge the credits of the slides to Dr. Rohan Kola and Dr. Prakash Mondal, who has given me such an amount of helps with these slides. Thank you very much.
Thank you, Dr. Basu, for lucid discussion on this primary prophylaxis. That yes, very recently thalassemia control with unit, this care has been clubbed. And in North Bengal, we are also getting good number of patients, and I was just going through.
Very good effort. We already have many areas, many places where they are doing prophylaxis.
Yeah, we have already got good number of patients as well.
Very good effort. We need to collate, do it for everybody.
Yes, actually that clubbing has given one extra impetus.
Yes, we should all go back home, say prophylaxis for everybody.
Yes. And your presentation is also really, it is giving so much insights. Thank you so much. Thank you. So
thank you, Dr. Basu. Your presentation is very good and informative. And
question hours will be later on, okay?
Afterwards.
Our next speaker, Dr. Shashikant
Shashikant
Apte, Hemophilia Management in 2021. Please. Dr. Shashikant Apte, MD, FRCPA, is head of the Department of Hematology and BMT, and he's at Shajjahadri Specialty Hospital, Pune. His area of interest is blood and marrow transplant, hemophilia and congenital bleeding disorders. He has got a lot of publications. Professor Apte, please.
Please you start. I would at the outset thank chairpersons for kind introduction and organizers for inviting me. It was a great lecture to hear from Dr. Shantanu, and he has been an old friend and doing great work. And major hurdle, whenever we used to go to authorities, they used to say that on-demand therapy has been mentioned in your own textbooks. So when it was decided that the new edition came, it was clearly defined that on-demand therapy is not a treatment of hemophilia, but it's a treatment of bleed. And the treatment of hemophilia is prophylaxis. It was very nicely elucidated by Dr. Shantanu. So these are the keys. Prevention of bleeding is the primary motive when we treat hemophilia. And to give a simple example, I think hemophilia should be treated like diabetes. We give therapy and do not allow sugars to rise. When the sugars rise, we are treating the complication and not the diabetes. Same principle should be applied to hemophilia. When we look at the expansion of hemophilia therapies in last couple of decades, and especially in last decade, there has been huge expansion in products available. We started with plasma, we went to factors, then we have bypassing agents, then we had the newer products, and now we are talking of cure. Gene therapy has offered a cure for hemophilia. Barriers to hemophilia treatment are multifactorial. There are patient factors, there are treatment-related factors, there are financial factors, there are healthcare system-related factors, and there are social factors. When we start prophylaxis, there is a lot of fear among the parents about inhibitors. But now the data has come out very nicely that when you are giving prophylaxis, you are giving regular exposure to that given antigen. And in fact, the incidence of inhibitor is less when you are on prophylaxis than on demand up to first 50 exposures or what is called as the 50 EDs. And there are challenges with CFCs. As Dr. Shantanu showed, giving IV injection can be managed, but you need a trained team for that, even on OPD basis. You do not need central venous catheters to give prophylaxis. All our prophylaxis, I will show our own data which has been published now in hemophilia, that you do not need central venous catheters even for young children. But yes, you need a very good nurse who can get access in a single shot. But most important problem is inhibitor development. And whatever products have come, the incidence of inhibitor has not come down. Definitely has not come down with newer products, which was everybody was thinking that if we have newer products, we might have less inhibitor. And still ABR is not zero. So ideal therapy in hemophilia should be safe, efficacious, cost-effective, accessible, available, affordable, and zero risk of development of inhibitors. Volume and ease of reconstitution, storage condition, especially in country like India, when electricity supply is the issue, we have to consider this as a parameter. And consistency and reliability of the supply. Suddenly in state, there is no factor available for 3 months because it has not been purchased. That should not happen. Because unless you have a regular assured supply of products, you cannot give prophylaxis correctly. And giving intermittent prophylaxis may not lead to any great advantage in long run. And now we are talking of cure, which is possible and definitely possible. There are novel therapies, and the novel therapies are extended half-life products, non-factor therapies, and gene therapy. In the afternoon session, I gave a talk on Novo9 GP, which is one of the extended half-life products. But majority of our own experience has come out through World Federation's Humanitarian Aid Program. And we have around 900 patients registered with us. And we decided, okay, let us start low-dose prophylaxis, at least for young children. Because below age of 10, they have a less joint damage. Because even if you give good prophylaxis, with a bad joint damage, it is not going to really help. So to prove the point that if we start low-dose prophylaxis early, can we change the quality of life and quality of joints? And it became continuous tertiary prophylaxis because all of them had joint bleeds. None of it was primary or secondary prophylaxis. And intermittent tertiary prophylaxis was given to all adults who underwent joint replacement. So there was no point doing a joint replacement unless the muscles are of good size and good volume. And again, that paper we have sent, we have done now 80 bilateral simultaneous TKRs in hemophiliacs using a low-dose protocol. And in fact, only 2 weeks back in hemophilia, we have published the data of invasive procedures using low-dose protocols. So this is the data. We had 114 patients. We have 114 patients. Age group was 3 to 11 years. Prior release was 22. We decided that we'll at least select the patients who have got 20 exposures because then the chances of inhibitor development are less. That was the surmise. This question is asked, why you selected 20 EDs? The reason was that we did not have enough bypassing agents to support if somebody had developed inhibitor. No single joint had a HGHS score more than 5. So they were not bad joints. So this interim assessment was done and these were the parameters assessed. Despite that, 4 patients developed inhibitor. 3 had low titer transient inhibitor, 1 had high titer inhibitor who responded to ITI and he is on an intermediate dose prophylaxis rather than low dose prophylaxis. We had breakthrough bleeds, but they were majority post-traumatic. And IV eloctate used over 12 months was 1100 IU per kg over 12 months. And trough levels were maintained between 2.6 to 3.2. As Dr. Shantanu said, ideally we need about 3 to 5%. But we believe that it is better to give some prophylaxis rather than no prophylaxis. And with that philosophy, we have gone ahead. When you compare, you can see everywhere the prophylaxis has scored, whether the days missed, hemophilia joint score, annualized bleed rates, and the FISH score. FISH score definitely improved over a period of 3 years. And on demand, these fellows who received on demand had a regular follow-up. We use 870 IU per kg per year. So 1100 IU per kg per year in prophylactic group and on demand 870 IU per kg, it is not a big difference. It is not a big difference. So it says that even low dose prophylaxis may be beneficial than giving any on-demand therapy. There is enough data in Western world that even if you use 4000 IU per kg per year as on-demand therapy at age of 20 years, your joint scores are bad. And that data, the Dutch group have presented very nicely, and that is the basis for starting low-dose prophylaxis. Simultaneously, we have 26 patients with hemophilia B on prophylaxis. Again, similar age group was selected, but here we gave Alprolix 20 IU per kg once in 2 weeks. And that came to around 500 IU per kg over 12 months in these 26 patients. This we published last year in World Federation meeting. It was actually accepted as an oral presentation, but because there was no virtual meeting, it became a poster presentation in that. And again, we can very clearly see that once they were put on prophylaxis, these children did better and led far better quality of life. So the current is that you have to give prophylaxis. At least start with low dose prophylaxis and then try to achieve. I agree that we should target zero ABR. And to target zero ABR, we have to convince our authorities to give more supplies. But more important than supplies, we have to collect data. We have to collect data and present to our authorities to form the new policies. As I said, most important complication of hemophilia is inhibitors. And incidence is around 15 to 30% in hemophilia A, if you depends on which study you quote. Luckily, the inhibitor formation is less in hemophilia B. And treatment of this is eradication by doing ITI. And low dose or intermediate dose ITI also works. Whenever we have done ITI, we have given 50 IU per kg alternate day. It is alternate day. It is not 3 times a week. And generally we assess the patients at 3 and 6 months. And we have shown that 42% fellows do respond. And that data was published as a 3-center study between us, CMC Vellore and KEM Mumbai, published 2 years back in hemophilia again. But there are problems with bypassing agent. The efficacy of bypassing agent has been suboptimal. Even 80% only respond, 20% may not respond. And the exorbitant cost. There is a frequent intravenous injections required. And these led to a lot of work done over the last 10 years. Can we have options to these agents? And that led to any treatment that could be possible for hemophilia A or B, and now that is called as a non-factor therapy. And non-factor therapies have definitely changed the algorithm in hemophilia management, completely changed the algorithm. We have 3 non-factor therapies, emicizumab, fitusiran and concizumab. Now, emicizumab is available, it is available in our own country. It is approved drug, whereas fitusiran and concizumab are still at the trial phase. Both these drugs were studied for patients with hemophilia A with inhibitor and without inhibitor. It is also important, can these drugs work very well without inhibitors? It is not a drug only for inhibitors. Emicizumab will work only in hemophilia A. It will not work in hemophilia B, because this is how the drug acts. Emicizumab will bring 9 and 10 together. Once 9 and 10, activated 9 and activated 10 combines, you have thrombin generation. And once the thrombin is generated, it just continues the hemostasis. So emicizumab will not work in hemophilia B because there is an absence of 9. And this is an excellent advantage. It's a subcutaneous injection. And there were a lot of trials showing various treatment protocols like 1.5 milligram per kg once a week, 3 milligram per kg once in 15 days, or 6 milligram per kg subcut once in 4 weeks. And these are the Heaven trials. Our center, we participated in Heaven 3 and Heaven 4 trials. We totally had 12 patients and we had an excellent experience with emicizumab, and we had to use the trial protocol. So these are the trials that led to the rapid approval of emicizumab in the treatment of hemophilia A and in treatment of hemophilia A with inhibitors and without inhibitors. And now the worldwide, the regimen used is 6 milligram per kg of emicizumab once a week subcutaneous. And it is approaching ABR to near 0. These are the dosages. We had 10 patients, 2 patients had to be taken off because one of them had developed thrombotic event, and one patient withdrew the trial from the trial on his own, but we had started with 12 patients. This is our experience with low-dose emicizumab. This is out of the trial. We have total 9 patients, age we started between 8 to 21 years, with inhibitor 3 and without inhibitor 6. We are using dose of 3 milligram per kg once a month. For a 10 kg child, dose comes to 30 milligram. The vial is 30 milligram, which is 52,000 rupees. But there is an access program with the company that you buy 1 vial, you get 2 vials free. So per dose, monthly dose cost comes to 17,000 rupees, which a lot of these IT fellows say that at least child goes up to 40-50 kilos, we may be able to afford. And it will, I have a strong belief that if we can give 4-5 years of emicizumab kind of drug, these children will have far better joints when they are going into the second decade of their life. And by then, probably the cost also may come down because there will be other options. We did 1 grade 2 amputation and circumcision using emicizumab. No factor was used and there was no excessive bleeding. We monitored only PTA and APTT. And now we are in a process of establishing quantitative thrombin assays. Because that is the best way to document the efficacy. But normal PTA, APTT, normal take, we did take of these patients when we took them for surgery. And we went ahead with the surgery without giving any factor replacement. The second drug in pipeline is fitusiran, which is actually a product of a Nobel Prize. It is a small inhibitory RNA. The Nobel Prize was won in 2006 for this discovery. And again, this trial was put on hold because of thrombotic events. And now the trial has reopened and we have restarted. The screening and enrollment is over, but the product has come and the investigations are going on. And by this year end or next year early, the fitusiran trial will get closed. Same thing is with anti-TFPI, and the trials available in India are with consuzumab, which is a product of Novo. Again, the trial was on hold for last 6 months. Again, it opened in January. The reason was again thrombotic events. So you have to be careful when you are using these non-factor therapies. And these are the considerations, though these are the advantages. The long half-life will definitely bring down the number of injections. All these 3 drugs are subcutaneous. So you do not need IV access at all in these patients. There is no immunogenicity against factor VIII, so incidence of inhibitor is going to be 0. It will not develop an inhibitor because there is no factor VIII exposure in this. The capacity to improve thrombin generation is independent to the degree of coagulation factor deficiency. That is the principle. And they may be used in the treatment of rare bleeding disorders. In fact, we have put 2 type 3 von Willebrand disease on emicizumab only 2 months back. They have received 2 doses. They are small girls and family said we will try. And we are using on von Willebrand. It is working. At least they have not bled because otherwise they used to have 8 to 10 bleeds a month. But we have to be careful. We have to ask answer certain questions. Is it applicable? What about long-term safety when we are using this kind of drugs? Because fitusiran especially decreases the antithrombin 3 production. We don't have the data what will happen. So we have to be a bit careful. How to monitor these patients? So at least TEG should be used, or ideally the quantitative thrombin assays should be done to monitor these patients. Management of emergencies and surgeries. So suppose somebody is taking one of these non-factor therapies and comes with IC bleed, post-trauma, you will have to support because these questions are unanswered. Will that cause thrombosis? Because already the patient is on non-factor therapy, you give high dose of factor 8 or 9, will that cause thrombosis of renal vein, portal vein, or a vein in the brain? We have to be a bit careful. So today's data is not mostly on these things, and these questions are unanswered. How safely we can combine the therapies? And testing for inherited thrombophilia is mandatory before you start NFTs. All our patients, we have made sure none of them have any of these inherited thrombotic disorders. Now the last couple of slides I'll talk about gene therapy because everybody wants to have a cure for everything. And with these, the hemophilia has again been on the forefront and there is enough data on factor VIII gene therapy and factor 9. Somehow I missed 2 slides which I had put of Amit Nathwani's paper on hemophilia B because first gene therapy report was in December 2011 in New England Journal of Medicine. And Amit Nathwani gave a plenary lecture in ASH 2 years back on his 10 years follow-up of hemophilia B. Somehow I missed that, miss that slide. All the slides are on hemophilia A. It is very promising, no doubt. But there was a drop in factor 8, and that is a concern. With 3-year follow-up, after gene therapy, the levels which had reached up to 200% dropped down to 27% in majority of the patient. Till 27% is better because you are a mild hemophilia. But we have to watch how long it sustains. This is a 2-year data which WFH published on factor 8 gene therapy, and that is a concern. Okay? But majority of the patients had 0 bleeds in this period of time. So in management of PWH looking forward will be at present time, cures for hemophilia we are not available in our country, but it may happen because we have enough things to do. While it is clear stopping of bleeding is good and preventing bleeding is better, cure remains the ultimate goal, and liver transplant can cure. In fact, we have 3 patients who are virus positive. We are monitoring them, and we have decided, because we have a very busy liver transplant group, and we have keeping this patient, and my gut feeling is within next 6 to 12 months, they are going to need liver transplant because of their liver issue. And in the bargain, hemophilia will get cured. So this is the algorithm. And in conclusion, I would say that hemophilia therapeutics has exploded like anything in last 10 years. There is a maximum development in this field in any branch of hematology. Long-acting molecules are definitely safe, effective, and increase the compliance. Non-factor therapies are very promising, but we have to have more data. We have to be careful. We should not just blindly follow these newer products. And if possible, try to have a gene therapy program in the country. With that, I would quote Stephen Hawking. The life is difficult. There is always something you can do and succeed at it. It matters that you just don't give up. And let me tell you, Dr. Shantanu working in ESIS hospital never gave up. And that's why he could do the prophylaxis for 106 patients. Thanks for your kind attention.
Thank you, Professor Apte. So after prevention, we have learned therapeutic approach in hemophilia in a detailed manner with its features. So question hours will be naturally later on. We will now invite our next panelist and all others.
Hello. Now our a little rise is enough hemophilia. There is a panel discussion. I am inviting, the topic is eradications of inhibitors, how far from reality. Now moderator is Dr. Siddhartha Shankar Rai, and panelists are Dr. Sandeep Saha, Dr. Divyendu De, Dr. Shahija Gulshan, Dr. Devdas Bose. You are requested on the dais.
Each and everyone is very much known to me, and I am tempted to say that one of them, Gulshan, that is Shahija Gulshan, she is my student, MD pathology student.
Okay, good evening everybody. First of all, I would like to thank the organizer for giving me the chance to be here in front of you. So
Please take up your...
Yes. So thanks the organizer for giving me the chance. First, I would like to inform you that one of the panelists, Dr. Devdas Bose, actually who is also my junior colleague at my medical college, ISTM Kolkata, is not here today because of sudden demise of his father actually. So I will discuss with my another 3 panelists. Dr. Sandeep Saha, who is also my junior colleague at Institute of Hematology and Transfusion Medicine. Dr. Shahija, she after passing the DM from NRS Medical College, now practicing as a consultant hematologist in PRLS Hospital. And Dr. Divyendu De, he happens to be one of my students, and he was very good student at the time. Now after passing, he practiced for some time at Durgapur. Now he shifted to Raipur, and he is a consultant hematologist there. Okay, so Today's topic is related to the eradication of the inhibitor in hemophilia. Now we have learned that inhibitor is a really serious issue, so we would like to discuss it as simple way as possible. So to do that, this is a case, 8-year-old male who is already diagnosed case of severe hemophilia A and was put on prophylaxis replacement therapy actually since the age of 4 years when he came to us. Since that, before that he already had 2 or 3 episodes of the joint bleed. After that only he came to us and we started 15 units per kg twice weekly prophylaxis dose. And recently he had developed 2 episodes of the breakthrough hematology of the right knee in the last 3 months. And latest he presented with us sudden onset pain in the right hip joint with inability to stand for 1 day. And he was even in the lying down position in the bed, he is not able to straighten his leg. He kept his right leg in the flex position. And clinically also there was tenderness over the right leg fossa region and some bulk was felt, and we did one USG which showed a significant psoas hematoma of 60 to 5 centimeter size. So my first question is to Dr. Sandeep Saha. So what are the different prophylaxis regimen is already a little bit discussed here, and how will you manage breakthrough bleeding in a people with hemophilia who is already on prophylaxis? Dr. Sandeep, please.
This 8-year girl is actually suffering from severe hemophilia A.
Mic down.
Severe
I think
hemophilia A.
mask is also to be removed.
I think it's audible.
No,
sir, it's audible. She is suffering from severe hemophilia A and on prophylaxis. Even on getting prophylaxis, he developed the joint bleed and as well as the psoas muscle bleed. So for the prophylaxis is concerned, it is divided into 3 main categories: primary, secondary and tertiary. Primary prophylaxis is usually given before 3 years or before second bleed or before the onset of joint disease. Secondary prophylaxis usually it started after more than or equal to 2 joint bleeds, and again this is before joint disease started. And tertiary usually after joint disease started. And the second is the conventional factor prophylaxis with standard half-life clotting factor defined according to its intensity. Usually according to dose, the prophylaxis is divided into 3 categories. One is first the high dose prophylaxis, second is intermediate dose, and third is low dose. Low dose usually from 10 to 15, intermediate dose 15 to 25, and high dose is 25 to 40. And this young child is getting, according to the dose it's shown here,
15.
that is 15 twice weekly, means the patient is getting the low dose prophylaxis actually.
That we are using because of the scarcity of the factor actually. So you are used low dose actually. So now he has developed this psoas bleed, breakthrough bleed. So your question was that how will you manage this breakthrough bleed if a patient, this patient also having twice that knee joint bleed while on prophylaxis. So if a patient already on low dose prophylaxis, he is developing recurrent bleeding, so how will you manage?
If a patient is on prophylaxis and the patient was under control and suddenly she developed the joint bleed, so first thing we have to exclude whether patient is developing any inhibitor or not. First, to rule out the inhibitor, if the patient is even is inhibitor negative, then we have to think of whether the prophylaxis dose we can increase or not. So if a little bit increase can sometimes get rid of the problem. But first we have to rule out the inhibitor is there or not.
Yes, actually, that is really true. So if we can rule out the inhibitor, so these are the few factors which can influence the bleeding phenotype in persons who are already on prophylaxis. Some genetic differences are there, some variants, and also some non-genetic factors like what is the level of activity. Like a person who is very active and who is prone to trauma. So there we should give for high dose prophylaxis, otherwise he will definitely develop bleed. And functional ability and physical coordination, all those, then what is their risk taking behaviors, their body build, what is the muscle status, whether they are strong enough to stabilize the joint and to prevent further bleed. So all those things we should take into our mind in a patient who do not have any inhibitor, and then we can increase the dose, and also we can ask the person to modify the lifestyle so that there should not be any trauma which can prevent, which can precipitate a breakthrough bleed. So next question to Dr. Shadia. When will you suspect inhibitor and perform inhibitor screening? This is your first question. And how will you proceed to diagnose inhibitor after suspecting? So when will you suspect inhibitor, and what are the, basically what are the indications for inhibitor screening?
Okay, thank you, sir. So there are usually two scenarios where you start suspecting an inhibitor. One is clinically when a patient is presenting differently, and secondly we do it in certain circumstances like before a surgery, before any invasive procedures. So clinically, when you suspect a patient who is on prophylaxis and develops a breakthrough bleed, patient who is not adequately responding to the factor replacement which he is receiving, he might, the amount of your factor recovery is not there, or the factor A is more than 7 hours. These are some of the factors, situations where you suspect clinically that a factor might be, inhibitor might be developing in this patient. So what we do next in this situation is we go for an inhibitor screening. So first we do an APTT and a mixing study. Following that, when the APTT is prolonged, you do a mixing study with a 50-50 ratio with pool normal plasma and immediate as well as the 2-hour inhibition, incubation, after 2 hours incubation at 37 degrees. So when the correction is not there, usually in case of APTT, it is said that if the factor correction is less than 70%, then you suspect a presence of an inhibitor.
Yes. So you have suspected that inhibitor. Okay, now will you confirm? But then
yes. So next we confirm the presence of inhibitor by the inhibitor assays. We have the functional assay as the immunogenic assays. You have to do the specific inhibitor assay, and by the urine measurement modification of the Bethesda assay, which is the gold standard at practice at present.
It's actually this key point about this, what she has said, rightly said. So first we have to do the mixing study, and from there we can suspect whether there is inhibitor or not. Then once we suspect there is inhibitor, it is not getting corrected by mixing study, then we will go for factor, there is inhibitor screening by modification of Bethesda assay. And one peculiarity of the factor 8 is that inhibitor are their time dependent inhibitor. So this is the thing that after immediately mixing with the normal pool plasma, there might be correction, but we have to wait for at least 120 seconds because they gradually become active, these factor 8 antibodies. Inhibitors are nothing but the antibodies. So we have to wait for 120 seconds, 120 minutes, and then incubate them at 37 degrees centigrade, then there's all the antibodies, they will get activated and they will destroy whatever the factor 8 is there. So then we will see the actual thing, which is not true in case of factor 9 inhibitor, but in factor 8 inhibitor, this is the peculiarity. And it is WH's guidelines, they said that in those cases where the factor 8 level is more than 5 international units per deciliter, there WHO recommend that prior to testing the sample must be heated to 56 degrees centigrade for 30 minutes and centrifuged at ambient temperature, just to prevent, because many a times if a known patient of hemophilia, they might have received some sorts of plasma or some sorts of factor 8 which could interfere in this inhibitor. So that's why to deactivate that you have to heat it, okay, for 57 degrees centigrade for 30 minutes. And this quantification limit of this Bethesda assay is 0.6 Bethesda unit per ml. So if it is less than that, we cannot detect by this method. And for that is the ideal
mixture, that is after when we mix, that most accurate inhibitor result are obtained when the residual factor 8 or factor 9 activity is close to 50% at the level of the control mixture. Okay. So, but we can do it between 25 to 75%. And for quantification of the low titer anti-factor 8 inhibitor, that is if it is less than 2, WFH recommend that a chromogenic assay method should be done, which are much more sensitive than that what single stage APTT based assay which we usually do. So, now back to the case. So, in this patient we have done that inhibitor screening and it was found positive, then we did the inhibitor titer and it was found 15 Bethesda unit. So, now question to Dr. Dibyendu. So, how frequently will you monitor for inhibitor and what are the risk factors for inhibitor development?
Thank you, sir. First of all, inhibitor testing should be done in all patients who are on prophylaxis. And since the initial days of prophylaxis is the most important point of time periods when the inhibitor development is high. So initial 20 exposure days, the inhibitor screening should be done with every 5 exposure days. And after that, we can do it after every 10 exposure days. And when it goes to more than 50 exposure days, then we can do it once or twice a year. And after that, we can go annually. And also, there are few patients who actually have a higher chance of developing inhibitors. So like, there are different factors which can determine whether these patients may develop inhibitors. Most important is the genetic factors, especially the mutations involved with the hemophilia. If there is a large deletions or large mutations, then chance of inhibitor is high, rather than the point mutations or a missense deletions. The most common mutation is inversion 22, which comes in the intermediate range. Also, the patients who are severe hemophilia, patients who requires high dose of factor 8 infusions for the control of bleeding, those who are having any major surgery or having any trauma or inflammations, then the chance of inhibitor development becomes high. So these are the conditions where we have to be more vigilant to go for a inhibitor screening.
Yes, I agree, with Dr. Dibyendu, 100%. So these are the actual point we should keep in remember. These are the risk factors and that is the frequency of inhibitor assessment in addition to before going for any surgery. So next question is to Dr. Sandeep Saha. How will you manage this patient of psoas hematoma? Now this patient, we know this is a severe hemophilia A with high titer inhibitor. There is 15 Bethesda unit. Now he came to us with a acute psoas bleed. Now we have to manage. Dr. Sandeep.
The patient is inhibitor positive
and
15
titer
BU. Is around
15 BU.
Huh?
15
BU. Okay. The patient is having the psoas hematoma. So it's better to start with the patient with put the patient into recombinant factor 7A or APCC. That means the bypassing agent is the better choice. So whatever agent you can choose, the recombinant factor is usually given around 90 unit per kg or APCC around 50 to 100 unit per kg. But the frequency of the recombinant factor 7 is usually frequent, 2 to 3 hours interval. But in case of APCC, 6 hourly. So it depends on the response of the patient. Sometimes we have seen that was few doses, means 2 or 3 doses is enough for that. And if the second question is, if
inhibitor titer was not 15 BUs, suppose if it is 4 BU or
that
3.
means low titer inhibitor. Two terms we used to know that low titer low responder and high titer high responder. This kind of terminology is there in hemophilia. So if a patient is suffering from low titer inhibitor, we have seen that the patient responds well with the high dose factor 8. So if you give in case of inhibitor even with a factor 8 with a low titer, so the patient may respond.
Yes. So as Dr. rightly said, so actually according to the titer, the people with hemophilia with inhibitor, they are divided into low titer, low responder. It has seen that historically those patients having titer level BU, that is less than 5 BU, they even after exposure to factor 8, their anamnestic response and rise in the inhibitor titer is not too high, but in those patients whose at diagnosis the Bethesda level of the inhibitor titer is more than 5, that is they are called high titer high responder, because even after a single exposure of factor 8 again, their inhibitor titer shoots up very rapidly to too high. So they will be very difficult to manage. So that's why they are basically divided into these two groups. And then it has been seen also that whose titer is low, so we can overcome that inhibitor, that is the antibody, by overwhelming dose of the factor 8. Or if it is a factor 9 inhibitor, then we can give high dose of factor 9. That is also WFHA recommendation, that in low titer inhibitor, in case of acute bleed, we can give factor 8 or factor 9 according to that main primary disease in high dose, that is mean 3 to 4 times of the dose. And then ideally we should check the factor recovery, that is factor level, and also clinically also look for the whether patient is responding or not. And another thing he already said, that otherwise we can give FIBA or Novo-7, and it is already seen and it is proven that if a person is not responding to FIBA, he may respond to say Novo-7, or vice versa, not responding to Novo-7 can respond to FIBA. So we can use any of them. And even in some special center, they can use sequential therapy, like by sequential bypassing agents. So they are giving factor 8 bypassing agent, that is FIBA. After 3 hours, they are giving Novo-7. Then after again 3 hours, giving FIBA, Novo-7, like that sequential. But it has been seen that with this sequential therapy, there is a high chance of thrombosis. So we should be much more careful for sequential therapy, and it should be given only a very higher center only. And another point is, we should be very careful while using APCC in case of factor 9 inhibitor, because they sometimes, we all know that factor 9 inhibitor, exposure to factor 9 can develop anaphylaxis reaction. So, and we know that FIBA has got factor 9 in it. So next question to Dr. Shajia.
Sir, may I add one thing here? APCC is also said to contain some amount of factor 8.
APCC is called FIBA actually.
Yeah.
So APCC actually, the trade name is FIBA. So how will you plan for prophylaxis now? This patient already developed inhibitor. Okay, we have managed with FIBA or Novo-7. You managed the bleed, first bleed is managed. Now how will you go for prophylaxis in this patient?
So in this patient, your it already has inhibitors.
15 BU.
15 BU inhibitors, a high titer inhibitor. The patient is really a difficult situation. So, but since he's having breakthrough bleeds, and so for that he will need some amount of prophylaxis. Although we do not have any consensus right now, but the agents which are commonly used, they are either the bypassing agents, the FIBA or factor 7, or your emicizumab may also be used in these cases.
So that you are already said that we can use FIBA, or there is APCC, or we can use recombinant factor 7 or Novo-7, and both have been shown they are quite effective as a prophylaxis. Here you can see both are effective when we are giving as a prophylaxis. This FENCO study shows, and these are the studies that in the Novo-7, that is the recombinant factor 7A, they have used from 220 microgram per kg daily to up to 200 to 215 per kg per week. And it has been seen that with the lower doses, chances of the breakthrough bleed is high, but with high dose is less. But another thing is that what she rightly pointed out, that we can use the bypassing instead of factor, non-factor we can use, which is emicizumab. That's just before our panel discussion, which is already described by Dr. Apte, that it is non-factor thing which is already recommended for prophylaxis in case of factor 8 inhibitor. Then the dose already also, it is already discussed in my earlier, so I am not going to in details. And thing is that if those patients who are receiving emicizumab, if we want to do factor assay, one-stage factor assay, we cannot do the usual method of APTT and usual reagent. We have to use bovine reagent, and we have to use chromogenic assay. Now next question to Dr. Dibendu. What is the role of immune tolerance induction, ITI, in this patient? And what are the predictor for success for immune tolerance induction?
Yes. So thus far we have discussed about how to prevent and how to treat the acute bleed and how to prevent the further bleed by prophylaxis. But the main concern is the development of inhibitors. So we need to eradicate these inhibitors. That's where comes the immune tolerance inductions. So every patient who is having who have developed inhibitors, they should go for immune tolerance inhibitors, immune tolerance induction. And mostly those patients who are having a low titer inhibitors, they respond very well, especially the factor 8 inhibitors. And also if the titer is less than 5, if the peak titer level never gone beyond 200, then the chance of success is high. But also there are different protocols, Malmo protocols, Bond protocols. So high dose protocols, there the chance of inhibitor eradication is higher. And also there are some genetic factors like the type of hemophilia mutations as well as the different variations in the immune systems in our body. So that predicts how the immune tolerance inductions may go. So thus the immune intolerance inductions can be given.
Yes, I agree with you 100%. So these are the things which can predict whether our eradications, the ITI will be successful or not. So now next question is to Dr. Sandeep Saha. How will you plan for immune tolerance induction in this patient? Means what dose will you start and what are the things you will come? That ITI, when you are practically starting, what will be your protocol?
Usually we follow the protocol. Actually we divide the inhibitor level, the Bethesda unit. If it is less than 5, if it is less than, it is more than 5 but less than 200, and if it is more than 200. So if it is less than 5, we used to do, we used to give the 50 international unit per kg alternate day. Then we follow the case. If we can escalate the dose or the frequency if the patient anything have the breakthrough bleeding in between. But otherwise, we have to follow the patient whether the increment of the dose is 40 or 40 to 50 Bethesda, the inhibitor level is 40 to 40 Bethesda unit or not. If it increases, then we have to again increase the dose up to the 200 international unit per kg. If the Bethesda unit is more than 5 but less than 200, then we start with the dose of 100 international unit per kg per day. Then again the same thing we follow. We have to follow the case according to the Bethesda unit in between. Again, if the increment is 40 to 50 unit Bethesda unit, then we have to increase the dose, or any breakthrough bleeding in between, again we have to increase the dose up to 200, or you can increase the frequency of the dose, not the alternate day, then the daily dose can be given. And if it is more than 200 Bethesda unit inhibitor level, then we have to start the ITI dose straightforward at the level of 200 international unit per kg per day.
Yes, actually just now, just before this, what Dr. Dibyendu said, that depending on the historic peak inhibitor titer, what was the highest inhibitor titer level of that patient, that is a predictor of the success or failure. And also, he said also previously, Dr. Dibyendu, that high doses has got a better result of successful. So that's why this treatment protocol has come. So those patients whose inhibitor historic peak level is less than 5, so it was never more than 5. So there we can start with low dose regimen, and if they are not responding, we can gradually increase the dose. Okay. So this is a very good approach, considering our country has got resource poor country, so we do not have that luxury to have enough of factor 8. So we can go by this regimen. So we can gradually then go up. But one point important thing is that this ITI should not be interrupted, because once it started, it should continue until we know, okay, we can label that, okay, this ITI is failure or ITI is successful. So we should think, keep in our mind, if we stop in between, it is going to fail. So next question to Dr. Sajia. How will you monitor this ITI treatment, and when will you declare that this ITI is not successful, it is failure?
for monitoring of the ITI treatment, what we need to do initially, we do it at the frequency of per week, weekly intervals, till they reach the maximum level, and beyond that, we do it monthly. And it has to be continued as already mentioned. And if we see there is any increase in the dose, increase in your inhibitor titer, and the factor level dosage is less than 200, then we have to escalate that. And if it is less than 200, is already 200, then you have to add another, maybe a immunotherapy you have to add in addition to that.
Yes.
And next question was failure. You mentioned, was it that, sir?
Next question, when ITI failure, when you declare ITI failure?
Yeah, so when do we say it's an ITI failure? So ITI success is when the inhibitor level is gone, means the negative inhibitor titer. Along with that, there is the factor recovery is more than 66%, as well as the half-life of the factor after 72 hours of factor 8 washout is more than 7 hours. Now, if all these three are not there, then we call it an ITI failure. And if the inhibitor level has come down below 5, but other two are there, then we call it a partial recovery.
Okay. So, monitoring already described, and as already told by my previous speaker, that during monitoring, if we show there is an uptrend, means inhibitor increasing or decreasing is not that much, then less than 20 in 6 months, last 6 months. So, we have to increase the dose. Okay. And if Bethesda negative, then we have to taper the dose of the factor 8. WHO is their guideline there, according to them, that ITI is success when we find that the Bethesda unit is negative. And along with that, pharmacokinetics of the factor 8 is normal. And recovery is more than 66%, half-life more than 6 hours of factor 8 after giving. And once we achieve that, we can say, okay, we can again start prophylaxis with factor 8 because we have received what we wanted. Then general consensus that failure is ITI when we inability to achieve this successful tolerance up to 2 to 3 years of initiation of an ITI regimen. Okay, then we can say we have failed, then we can stop the ITI. So question to Dr. Dipesh, this is the last question. So what are the obstacles at present in India to achieve this ITI in our setting?
So we have already discussed a lot of theoretical considerations, but practically it is very difficult to treat a patients who have already developed inhibitors. The most important obstacle, is the lab support. The diagnosis of inhibitor is very difficult. We may screen the patients and we may find that patient may be having an inhibitor, but diagnosis like the Bethesda assay, doing Bethesda assay is not possible in most of the centers, and that is why we may miss a lot of patients with inhibitors. Also, monitoring of these patients with inhibitors, and when we start the ITI, then there is a lot of monitoring is required regarding the Bethesda assay, the inhibitor titers, along with factor assay, factor 8 assay at a regular interval, which is also a cumbersome procedures. Second is also the expertise is also lacking. So when a patient develops inhibitors, these patients are not well managed by general physicians, so that becomes a very difficult. We need a expertise centers, we need a high excellence center where these patients can be treated well. So, and because these patients may have a lot of bleeding episodes and life-threatening bleeding episodes may happen, and these bleeding episodes needs to be managed well to get these patients cured. So that requires our expertise centers to cater. And lastly, obviously the cost, because a lot of factor use is required. The bypassing agents are very costly. So these bypassing agents needs to be given to this patient frequently during the ITI treatment, and also a high dose of factor is used, which is also costly. So cost factor always comes here. So that's why most of the patients with inhibitors, they are not quite treated quite well according to the WFH protocol. So that's what we can find here.
Yes, all the obstacles you have said. In addition, I would like to say that giving factor daily because most of the time if they are not responding, we have to give the factor daily. So giving a factor daily and the patient has to come daily to our center. So many of them, they are not ready to come daily to a center to get factor. Second is the venous access, because if we want to give daily factor, so venous access will be a problematic. So just now we heard that if we are giving twice weekly, it might not be that much problematic, but if we want to give daily factor, the venous access, another problem, another obstacles. So I think that conclude our all the questions. I would like to thank all my panelists.
So thank you very much, Dr. Roy. After one exhaustive discussion on this hemophilia with beautiful case topics, and Dr. Sandeep Shaha, Dr. Dibyendu De, Dr. Shajia Gulshan, Dr. Devdas Bose, thank you very much. And I think though we have planned that we will go for one question sessions, but we are already at the end of the day, so lack of time, we are just making it. Thank you very much.
Thank you, sir.
Do I have any question? One or two questions? No. Just one question is that. Yeah. To that one, to Dr. Apte was.
Dr. Apte.
Was using drugs used for prolonged time. Now, is it open or not? One is, Dr. Apte was using drugs, subcutaneous, which is actually, this is a question to you. So that prolongs the life T-half of factor 8. Okay? Now, how do you control hypercoagulation in this? And secondly, what's the role of, can you use von Willebrand factor to reduce the dose of factor 8 and also prolong the life? There are certain papers which have shown that it prolongs the life even when you use conjunction with factor 8.
No, the answer to the thing that if you have von Willebrand containing factor, which is a standard half-life factor, it doesn't prolong the half-life of transduced factor. It holds the transduced factor for 8 to 12 hours. So by giving von Willebrand factor, you may not be able to reduce the dose. That was your question.
Because there are certain papers which have shown that they have used it to prolong the life of T-half of factor 8.
It doesn't happen because...
Okay. And second is, how do you measure hypercoagulable state in case of when you use a prolonging oral? And lastly, factor 8 laden when you are using factor 9 laden.
Sorry,
do you have the factor 9 laden? Do you have the same protocol factor B?
Factor 9, sorry, factor 9.
Okay, thank you, Professor
So
Sinha
basically,
and Dr. Apte. Thank you very much. Thank you so much.
We'll talk later.
So we are concluding the session. Thank you very much.
Thank you, Chairperson. Thank you, Speaker and panelists. Thank you for this wonderful session. I now invite our next chairpersons for the next session. It's back to basics on lab hematology. And the chairpersons are Dr. Sapan Kumar Sinha, is ex-professor and head, Department of Pathology, IPG MER, and Dr. Devasis Guha, ex-professor, Department of Pathology, NRS Medical College. I invite you, sir, to the dais to carry forward this next session. Sapan, sir.
Hello. Good evening, everybody. We are in the almost last session of today's for this conference. We have a brainstorming session throughout yesterday, throughout this day, and in the last chapter, our topic is back to basics. And there was a theme from old is gold, but new is platinum. In the last day and today, we think we had enough of platinum. In this session, I think we will have perfect combination of gold and platinum. With this introduction, let us start the session. Our first speaker or presentation is Dr. Sudipto Chakraborty, and he will talk on basics of lab coagulation test. Dr. Sudipto Chakraborty, please.
Welcome, Dr. Sudipta. Yes, before going to this, you will talk about the screening tests, I think, okay?
And before Sudipto starts, I will just add a few words. While Sudipto was doing his post-graduation, I was his teacher.
Yes, sir.
Okay, that's an additional information. Sudipto, please. Thank you. Dr.
Thank you,
Sudipto,
sir, for
please.
your kind word. And now, as we learned from the previous discussion, there is a tremendous increase in our knowledge about the different hemostatic disorder. Also, there are numerous drugs are being used, and the monitoring of those drugs are required on a routine basis. In this portion, we shall discuss that the thing that the laboratory must have the setup for this coagulation assays, and for the time constraint, I shall only concentrate on the basic coagulation test. Now, the highlights of the discussion will be the coagulation cascade. They are different in vivo compared to that happens in vitro. There are some pre-analytical issues for this coagulation test, and then there are equipments, both manual and automated instruments are there. Then there are some basic laboratory investigation that we should know, and then how shall we interpret those results of this basic coagulation test, and lastly, some troubleshooting, what if something went wrong. Now, this is the classical coagulation cascade, but this typically occurs in vitro. So, there is an intrinsic pathway and there is an extrinsic pathway. Actually, when we do APTT, we are looking at the abnormalities of the intrinsic pathway, and when we do prothrombin time, we are looking at the abnormalities of the extrinsic pathway. And the common pathway abnormalities are typically detected by the thrombin time test. Now, there is a limited relation between this in vitro model, but this in vitro model is required for our understanding of the basic coagulation test. We can see that both factor 12 deficiency and factor 8 deficiency produces an increase in APTT, but only factor 8 deficiency produces bleeding manifestations. So, in vivo, what happens is that there is an initiation which is done by the tissue factor. This tissue factor causes activation of factor 7. Now, this tissue factor, factor 7 combination is then activate both factor 10 as well as it activates factor 9. Now, then the amplification of this coagulation pathway occurs where the prothrombin get activated to thrombin, and thrombin is a very important molecule in the coagulation cascade. As we can see in this diagram, the thrombin have both pro-coagulant activity. It can activate numerous other molecules, and it also has some anticoagulant activity. It also takes part in inflammation as well as the cellular proliferation. Now, after the amplification, there is propagation of the coagulation reaction occur in vivo with the help of activation of factor 9 by thrombin. And all these reactions occurs in the platelet surface. So, in vitro, when we do the test, we typically add phospholipid to make the surface that looks like the platelet surface. Ultimately, the fibrinogen will convert to soluble fibrin, and they will get stabilized to insoluble fibrin. Now, these are the basic pre-analytical issues. I am not going to all the details in this slide, but there are some requests from the clinician, and the patients are then usually comes to laboratory because this test should be done within 2 hours. But the collection of blood is important, then the patients will the samples will be properly identified. If the samples are collected from outside, it should be properly transported to the laboratory. Then the samples will be processed in the laboratory, and sometimes to cut this, sorry?
No, you continue.
Okay. So to cut this time span, we can directly transfer those samples to the test laboratory where the testing occurs. But before testing, we should properly store those samples. So these are the pre-analytical issues that should always be considered. The collection is always venous blood, even that should be performed from a neonate. The venous sample should be collected without a pressure cuff, because the pressure cuff can sometimes alter the concentration of different coagulation factors. The venipuncture must be clean, and a clean flow of blood should be obtained. The sample from the indwelling line or catheter should never be used, because those lines may have the anticoagulant factors or fluid. A good quality of plastic or polypropylene syringe can be used, but they should be coated so that the contact activation does not occur. Then amount of blood must be optimal. We shall discuss this in the next slide. And the blood should be thoroughly mixed with anticoagulant. Otherwise, the clotting of blood may occur in the collected sample. Now, the most common anticoagulant we use is the trisodium citrate, and that should be of 3.2%, not 3.8%. And the ratio should be 9:1. Why? Because all the test has been standardized with the 3.2% sodium citrate ratio. And then if there is abnormalities in the hematocrit, if the patient is anemic or polycythemic, then we may have to alter the blood citrate ratio to make it a 9:1 ratio of blood is to anticoagulant. The time of sample collection is important, because there is some circadian variation of some coagulation factor like the fibrinolytic activity, and the timing of collection of blood in relation to drug or factor intake should also be taken into consideration. Now, the other pre-analytical variables that are important is the platelet poor plasma preparation. Now, most of the coagulation tests are done by a platelet poor sample preparation by centrifugation to 1500 to 2000 gravitational force, which is roughly 4000 RPM in a benchmark cooling centrifuge. It should be done for 15 minutes to obtain a platelet count which should be less than 10,000 per cubic millimeter. The sample should be kept in room temperature if it is being used for prothrombin time test or lupus anticoagulant test or factor 7 assay, because if we keep the samples in 4 degrees centigrade, then the factor 7 may get activated. Otherwise, the sample may be kept at 4 degrees centigrade, but for all practical purpose, we should complete the test within 2 hours. Now, the water bath is required for the manual assessment of the coagulation test, the basic coagulation test. It can be also used for the incubation steps, the rapid thawing of frozen specimen. The water bath should have a 37 degrees centigrade, and that should be monitored by a certified thermometer. These are very important. Otherwise, you may get altered results, which is due to error of this either equipments or the other reagents, etc. Then their distilled water should be used to fill up the water baths. The other equipments are the refrigerator, the acceptable range is 4 degrees centigrade. Then the freezers, it meets either 20 or 80 minus 80 degrees. Then the centrifuge is also important, as we may have to prepare the platelet poor preparation. The test tube may either be glass framed or for plastic tubes. Usually we do the clotting study with the glass framed tubes, and for plastic tube, we use for the sample dilution, storage, and reagent preparation. The pipettes may be graduated manual pipettes, or nowadays we usually use the automated pipettes. So stopwatch and clocks are required to monitor the time. The end point can be monitored either by the manual method with the help of the water bath, as we are being discussed that. But besides, nowadays, most of the laboratories have some kind of automated machines where you have the electromechanical principle or the photo-optical principle. But there are also percentage detection, rate method, etc. that is beyond the scope of our today's discussion. The control plasma is also important. While the reference standard or calibrator is used for the accuracy, the controls are used for the precision of the test. Control must be included together with the every patient sample. The inclusion, both normal and abnormal controls are required. Traditionally, we use the locally calibrated standard pool. It is usually collected from 20 persons, and they are pooled together to make the control plasma. But nowadays, lyophilized reference standards are now available. We can use that. The phase control is required for some of the studies, like the platelet aggregation test, and appropriate value should be known before using the controls. Now, coming to the basic coagulation test, they are the prothrombin time, the activated partial thromboplastin time, and the thrombin time. They represent the three arms of the traditional coagulation pathways. To measure the prothrombin time, we use plasma which has been pre-warmed to 37 degrees centigrade, where we use thromboplastin. That thromboplastin also contains calcium. After adding this reagent, the thromboplastin reagent, the time taken for the clotting of plasma is measured. It is usually 9 to 15 seconds. Now, this variation of this reaction is depend on the reagent that is being used, thromboplastin. It is notorious for variation because we use the thromboplastin from lot of sources, and it also depends on the instrument that are being used. And the control plasma, we have already discussed, they are prepared from the 20 normal person. To overcome the variation of the prothrombin time result, we are now using what is called the international normalization ratio. The logic behind is that these manufacturers procure the thromboplastin from different sources, and they have different sensitivities. So what WHO did, they introduced a standard sample where the index is 1, and in compared to that sample, every manufacturer will say that their reagent is how much potent against the deficiencies of vitamin K dependent factors. And INR is calculated by prothrombin time of patient divided by geometric mean normal prothrombin time, and it is raised to the power of international standard, international sensitivity index. Now, nowadays the recombinant thromboplastin is used, and for the recombinant thromboplastin, the ISI is close to 1, and the prothrombin time is actually 10 to 12 seconds instead of 15 seconds. The second important test is the activated partial thromboplastin time. Why it is called partial? Because thromboplastin is not used in this test. And why it is called activated? Because the contact activation occurs by the use of silica or kaolin, etc. The phospholipid is added to the sample because we are creating an environment of the platelet surface, and the intrinsic factors are activated when the patient plasma is mixed with the APTT reagent. Here this activation occurs. Then it is incubated for 10 minutes at 37 degrees centigrade, and then the calcium chloride is added. As soon as we add the calcium chloride, the time is noted to clot, and that is typically 26 to 35 degree, 25 to 35 seconds. Now, the expression of all these results are usually mean of paired clot time, and again that it depends on the reagents and the pre-incubation period. The other test which is important is the thrombin time. Actually, thrombin time detects the level of the fibrinogen, and thrombin time is detected by adding plasma, which is pre-warmed at 37 degrees centigrade. This reaction all occurs at 37 degrees centigrade, and then thrombin is added, and the time taken to clot the plasma is measured. It is usually 15 to 19 seconds, and that should be within 2 seconds of the control. Again, the expression is done by a duplicate testing. Now, after doing this basic coagulation test, we should interpret the result. If there is abnormalities only in increased APTT, then we should consider as the deficiency of factor 8 and factor 9 that we have been already discussed. But there is also circulating anticoagulant. Later we shall discuss the importance of mixing study in this scenario. Then if both APTT and prothrombin time increases, usually those are the acquired defect rather than the congenital defect. Then we should first consider about the liver disease, the use of oral anticoagulant, and decrease of vitamin K level or DIC. Rarely factor 10 or factor 5 deficiency may produce this kind of result. If only the prothrombin time is increased, then they are again the acquired disease like the liver disease or oral anticoagulant therapy. And if only thrombin time increases, it is usually due to the low molecular weight heparin therapy or decreased fibrinogen level as in DIC, also in liver disease. Now, as there is increasing use of the drugs in this hemostasis, we should know which drugs causes alteration of this coagulation test. The unfractionated heparin is usually monitored by the APTT level. Then vitamin K antagonist like the warfarin is monitored by the INR, that means the prothrombin time. Then the dabigatran, the newer oral anticoagulants are usually monitored, dabigatran is usually monitored by the dilute thrombin time, and anti-factor 10A assay is done to monitor the low molecular weight heparin or the level of apixaban and rivaroxaban, though this apixaban and rivaroxaban normally does not require regular monitoring. Now, coming to the mixing test, the principle or logic behind this mixing test is that with an increased value of the prothrombin time or APTT or TT whatever, it may either due to deficiency as discussed, as shown in this part of the cartoon. And in the right part of the cartoon, see these antibodies, they are the inhibitors, circulating inhibitors. So, if there is deficiency of coagulation factors, then if we add normal plasma in a proportion of 50% to the deficient plasma, then there will be correction. But if there is a circulating inhibitor, this correction won't occur. So, mixing test will determine whether we are dealing with a low level of coagulation factor or we are dealing with a circulating inhibitor. Sorry. Then we have already discussed this part, I am not going to the details. Then if there is a correction in the mixing study, then either we go for the bioassay or quantitative assay by immunological or chromogenic methods. And if we think that there is a failure of correction, then the circulating anticoagulant should be considered and they should be assayed accordingly. Now, this is the last part of our discussion, the troubleshooting. Now, various steps can produce the abnormalities of this coagulation test, the basic coagulation test, and we should be vigilant about this trouble. Number one is faulty collection. The ratio of blood and anticoagulant, if it is not proper, it may get partially clotted. Underfilling or overfilling of vial or high or low hematocrit ratio, that will alter this ratio of blood and anticoagulant. Then unsuitable anticoagulant like EDTA, collection of blood through a line that has been in contact with the heparin or other infusion, obviously they will get you will get the abnormal result. The lipemic, icteric and hemolytic samples also interfere with the result. And then the contamination of the kaolin platelet substitute reagent with a trace of thromboplastin, they may alter the APTT value. The APTT reagent must not have any thromboplastin. Delay or improper storage in a sample analysis, use of inaccurate pipette, the instrument malfunction, then the incorrect temperature instead of 37 degrees centigrade, and the poor quality of reagents or incorrect concentration. I end my discussion here. This is the institute where I work, and these are some of the instruments that are being used for the coagulation assays there. This is simply the water bath. This is an electromechanical device, and this is the advanced device. It can also do a chromogenic assay. Thank you very much for your patience hearing.
So it is excellence. You have done excellence. So we will have the discussion little later. Before going to that, I must say most of the instruments now used are automated or semi-automated. They require regular calibration. And another defect which I have seen throughout this is the improper ratio, commonest, particularly in pediatric patients where the blood is less, citrate is more. So you are likely to get erroneous results. This is very often, particularly in children. So after this we will have the discussion at the end. So I will now invite Dr. Kollan Kumar Khan. He was also my student as well, and now we may say he was a colleague. It is a great pleasure to welcome him. Before going into that, his biodata will be shown there. I just would like to say that this, what we will talk about is a cell counters. This began with Coulter in 1956, and we have got two principles. One is electrical impedance, another is light scatter. So he will know about what are the advances and what are the latest development, beginning from the last days to the modern technology. So Dr. Kollan Khan will begin now. So, Dr. Khan.
Thank you so much, sir, for your kind words. Good evening and pranam, everyone. Now see, newer parameters in the automated cell counter, or it's also known as novel parameters in the automated cell counter. Although, right now, many of us might be hesitant to some extent to use the term novel, because the ordeal which we are going through for the last 1 year or so, that all started with something novel, isn't it? Novel coronavirus. So, the theme of this conference, it goes, the theme as it goes is old is gold, but new is platinum. So, by going by this theme, should I continue? Thank you so much. So as I was telling, technical hitches always there. Anyway, thank you so much. So newer parameters, as I said, so if we go by the theme of this conference, that is old is gold, but new is platinum. So these are the platinum parameters which we are going to discuss. Now, the quantification and identification of all the cellular or formed elements in the blood, these began manually, we all know, and through the impedance counter, almost universally right now, all of the instruments, they use flow cytometry. Now, here is a question for all of us. Anyone can answer that. Is there any relationship between two very unrelated things, that is the automated cell counter and the atom bombs which were dropped on Hiroshima and Nagasaki in the early August of 1945? Is there any relationship? Anybody? Anybody who knows? These are two very unrelated things. But see, this is the impedance counter. It works on the Coulter mechanism, isn't it? Coulter effect. Wallace Coulter, in late 1940s, he was working on the identification and quantification of the particulates within different types of paints. And he was in the Navy. He saw the aftermath of the atom bombs. And that is the point he decided that his invention should be used in more humanitarian ways. And that is the point we got the Coulter effect and this impedance counter and all of this automated cell counter began. So these two unrelated things are related in a different way. Now see, whenever there is a generation of the cell counters, there is some sort of flagging we all know. These flagged areas, if these can be quantitated, it becomes a new development and a new generation of the automated cell counters, they evolve. With this, we see that there is a 3D approach, the conventional reportable parameters, we all know. And as we all know that these reportable parameters, the state of the art, the accuracy, it surpasses even the clinical requirements, most of the parameters. With this, there are the special clinical parameters, the platinum parameters which we said we will be discussing, and the research parameters which in days to come might be reportable, and the special parameters. Now these can be automatically measured and requires minimal or almost no additional efforts. These are fully reportable. They can reduce the turnaround time as well as the slide review. They have the ability to analyze even cell precursors, not only the mature cells, and the different sort of quality requirements they are also met. Definitely they help in patient flow as well as patient management. And see, almost all the cell counters, they have the different channels. And what I felt is we can divide all these newer parameters into the different channels from which we get them. So initially, if we see the RBC count and the reticulocyte count, these channels, they give the RDW, the HDW, hemoglobin distribution width, the low hemoglobin density percentage, hyperchromic red cells, fragmented cells, NRBCs, the reticulocyte hemoglobin mean, and the reticulocyte hemoglobin equivalent, as well as the immature reticulocyte fragment, IRF. Apart from that, the extended DLC, not only DLC, but extended DLC, these give the this IG automated immature granulocyte count as well as new WBC positional parameters. These are something new which are coming up. Along with that, the platelet gives MPV, PDW distribution with platelet crete and the reticulated platelets. Others like automated instrument graphics, not only the numerical data, but along with that, the scattergram, it can give certain very important inputs regarding different clinical situations. Apart from that, automated, that is, there are image analyzers where a motorized microscope is used, and on the peripheral blood film, the images of different cells, they are captured and analyzed in a artificial intelligence network, and these can give different again, special parameters which can be important. Here again, I have a question. Any of the parameters you know which can be used for detecting doping in the athletes? Any of us? Yes, sir? IRF, very good. Thank you so much, sir. How it is used, we will see. IRF can be used for doping with erythropoietin, which the athletes or the sports person, sometimes they fall prey to. Now, this RDW we all know, it is the degree of anisocytosis, and it can be expressed as the standard deviation as well as the coefficient of variation. But the most important thing is when the MCV is low, it can differentiate between the iron deficiency states as well and the thalassemia traits, we all know. Apart from that, if the RDW is high, if the MCV is high, this RDW can give an idea that it is due to megaloblastic causes or non-megaloblastic causes. And when the MCV is normal, it can give an idea the cause is because of anemia of chronic disease or immune hemolytic anemias. So this is an important parameter we are using in everyday routine practice. Apart from this, we have the hyperchromic red cells. These are cells with less than 28 grams per deciliter, this hemoglobin. These hyperchromic red cells can be a sensitive marker for the availability of iron for erythropoiesis. And these hyperchromic red cells, the cutoff is 2.5%. When it is less than 2.5%, if it is hyperchromic red cells are more than 2.5%, we can say that this is an iron deficient erythropoiesis going on. And these are useful markers, as we saw, for functional iron deficiency. And this low hemoglobin density percentage is basically a sigmoid transformation of the MCHC. But these mean parameters, the hypochromic red cells and the LDH, along with that the HDW, these can give even earlier indications that there is an iron deficient erythropoiesis going on, because these are not the means but specific cells which are deficient in iron. So with this we have the fragmented red cells. These, although these are not very standardized at present, and these fragmented red cells we can get in the scattergram below the RBCs but above the platelets. The automated NRBC counts. These NRBC counts, here we see in the scattergram, if we see the different nucleated cells, these fall at the bottom below the debris. And again, this automated NRBC, that's why I marked it in asterisks in the list, enumeration of the different parameters. These are not standardized at present. They have QC issues, although there are IQCs in some of the instruments, but ICUS is something which we need to work upon, and these are the challenges we might have to face in the days to come. Then there is the mean reticulocyte hemoglobin and the reticulocyte hemoglobin equivalent. Now these are again early detectors. These parameters can detect the quality of erythropoiesis, because see, reticulocyte count gives us only an idea about the quantitative deficiency in the erythropoiesis, but the quality, the CHR as well as the RET-HE, these two are very superimposable, but different instruments give different parameters, different types of instruments. But these are superimposable, and these can give us an idea even up to 3 to 4 days if there is an iron deficiency going on. This can be indicated by the parameters. Very early detection can be done. And you see there are other parameters coming up like the mean reticulocyte volume and the red blood cell size factors, which are correlatable with the CHR. And these also give us ideas, although these are research level parameters at present. IRF, as sir has told, immature reticulocyte fragment, these automated instruments, they provide a measure of various degrees of this reticulocyte maturation. And if the immature reticulocyte fraction is high, see, if it is high and the retic count is also high, it is usually due to acute hemolysis. But if both are low, usually it is a production defect like aplastic anemia, and all in between, like even in megaloblastic and non-megaloblastic causes, can be differentiated by the use of this immature reticulocyte fraction. Not only that, as I said, it can be used to detect doping with erythropoietin in athletes, because there we find that there is a normal total count, but an unexpectedly high IRF, which is due to the use of erythropoietin, artificial use of erythropoietin. So, automated immature granulocyte count, again it is an important parameter, although the clinical use is limited because of the fact, see, immature granulocytes, number one is the different immature granulocytes cannot be separated by any of the automated cell counters right now. And at the same time, this immature granulocyte percentage, it is indicative of different infections, but it is almost similar to the absolute neutrophil count, the clinical efficacy. At the same time, we should say that if the number of immature granulocytes are low, then this automated immature granulocyte count, IG count, it helps because it actually counts a huge number of cells which cannot be done manually, and it is a novel parameter at present. WBC positional parameters, see the numerical data which is generated by the automated cell counters, they give us an idea of the volume, conductivity and the scatter of the cells. And this numerical data is generated from the scattergrams. If we go by the scattergrams themselves, then we can find something very unique. Say for example, the lymphocyte, the positional parameters, where exactly the position of the lymphocytes are there in the scattergram, that can give us an idea that this proliferation of the lymphocytes, is it due to the lymphoproliferative disorders or due to viral infections? At the same time, see, it can be used as a screening test for malaria if we go for detection of the presence of Malarian pigments, which can be found from the scattergram. At the same time, the monocytes, larger monocytes, if we find on the scattergram, it can be a screening test for malaria. These research parameters of the positional ones, these are the plasma cells, the Nutex, then the mean peroxidase activity index, all these things. Mean peroxidase activity index, it gives an idea about the myelodysplastic syndromes, along with that infections, even leukemias. Nutex gives hypogranularity, how much hypogranularity is there within the granulocytes, and if it is used along with anemia and other parameters, then this can give us an idea about myelodysplasia also. Then coming to the platelet channel, mean platelet volume, this is useful because the MPV is usually high when the thrombocytopenia is due to a functional defect or peripheral destruction. But it is usually low when there is a production defect. And we all know that the risk of bleeding is comparatively less if larger platelets are found because they have a better hemostatic capacity than the normal size platelets. So, platelet distribution width, like the RDW, it also gives us, helps us to distinguish between the essential thrombocythemia and reactive thrombocytosis, where the PDW is increased and normal in case of both the conditions, two different conditions. Platelet crete, as I've written, see, it does not appear to provide right now any information of clinical value. But the thing is, see, it gives us an idea about what is the total volume of platelets in a unit volume of blood. That can be important parameter, and we have to work on it, how we can use it clinically in the days to come. Immature platelet fraction, like is called also reticulated platelets, like the reticulocytes and the RBCs. So reticulated platelets, this is a parameter which gives us a very early indication of if there is this platelet production defect is there, and see, it can be used to assess thrombopoiesis, and they can delineate the abnormal platelet populations in AITP, autoimmune thrombocytopenic purpura, and TTP against the production defects like bone marrow failure and others. So, we come to another important parameter. I included it because of that novel coronavirus, because we are now conversant with this neutrophil lymphocyte ratio. This also the automated cell counters, they can generate for us, and this is a parameter which has been used by the clinicians, the people who actually treated COVID-19, and if we use a cutoff of 3.13 and age of 50 years, either low or more than 50 years, even the management protocol can be decided. If the patient can be home isolated or has to be transferred to the ICU, this parameter, NLR, neutrophil lymphocyte ratio, this can determine such important things, and it can be treated as one of the novel parameters or newer parameters of the automated cell counter. Not only blood, even the body fluids, they can be run on the automated cell counters in a different software, definitely, but it can give us ideas about what are the cell types. Along with that, the high fluorescence body fluid cell count, high fluorescence body fluid cell count, if it is available, with a cutoff of 1%, we can use it for detection of the reactive mesothelial cells, the macrophages, synovicytes, etc. So, with this, what holds there for us in the future? What are we going to expect? See, even now, we have to depend upon drawing of blood for this, to get these parameters, either manual or automated. At the same time, there is no real-time identification of the different disorders. So, in the future, what we think, what the experts also think is that there might be coming up more parameters, novel parameters, which were research parameters in yesterday's, and we might be having smaller portable devices, automated cell counters, which can help us for taking these technologies from the bench to the bedside. At the same time, in vivo blood, these are the things, these are the future developments which we hope for, apart from the newer parameters in the cell counters, automated cell counters. So, with this, to sum up, what I feel is, whatever we discussed, our concepts regarding the automated cell counter and the newer parameters, this has been summed up. I would like to sum it up with words from Muhammad Asatullah Khan Ghalib or Mirza Ghalib, we know. It can be said, हजारों ख्वाहिशें ऐसी कि हर ख्वाहिश पे दम निकले, बहुत निकले मेरे अरमान, लेकिन फिर भी कम निकले. Thank you so much. Thank you.
It's an excellent presentation, and I think there were many more questions. Only thing what I would like to say, that this has not been, even you say reticulated platelets has not been commercialized. Possibly the instrument, those who are set for that, and analyzing which is given in a lucid way, in a very nice manner, so that you can use this for almost all hematological diseases to some extent, at least give a professional diagnosis. So nice, we'll have questions after that.
As you have determined, we will have joint question association. There may be lots of questions, but thank you again for this nice presentation. Our next presentation is Dr. Palash Mandal. He will talk on IHC in low-grade lymphoma. I must say that I had a chance to work with Palash in different situation, different platform. I know him personally. He's an excellent laboratory medicine consultant. So I request him to start with his presentation. I must also say that IHC importance cannot be overestimated, but it is especially important in case of low-grade lymphoma. So, Dr. Palash, please.
Thank you so much, sir.
Him here. He was also my colleague there in medical college. It's a great pleasure. He was doing in immunohistochemistry for long, and I wish he will give a nice lecture on this, and it will be a memorable one. Please, go on.
Thank you, sir. And good afternoon, everybody. I know this session is coming to an end, and people are restless also. So I won't take much time. And though the theme is that platinum is new, I will still dwell upon something which is old and gold, because all people cannot afford platinum. And so, though many people cannot afford gold also, but we still would like to stick to the basics, because for that, our main diagnosis and the main choice of parameters or the choice of antibodies will depend. and hence I would like to stick to that and carry forward something which can So I will be actually dealing upon all these basic topics, how to approach the patient of a lymph node pathology, and then something about the morphology in a scanner view. And my topic today is the low-grade non-Hodgkin lymphoma. And of course, we will discuss the various types of non-Hodgkin lymphoma, especially the mature B-cell lymphomas. So when a patient comes to you and we see that the patient is having some kind of lymph node pathology, we start with the basics, because skipping the basics will only give a misdiagnosis or a wrong diagnosis. And this is very well known fact that at times we just get the prescription from a clinician saying that a lymph node biopsy, at times history is not written, at times the age even is not written. We have seen such prescriptions. But we would like always to have a detailed clinical history, and with the physical examination, since always it is not possible, I would request all the clinicians to give us details regarding some physical examinations, whether is a generalized lymphadenopathy or localized lymphadenopathy or so on. And then we come to the microscopy proper. And here FNAC, that is fine needle aspiration cytology, it is important because it is very cheap, it is very fast to diagnose lymph node pathology since it is accessible in most of the cases. And even for a deep-seated lymph node, we can go for a guided biopsy, like ultrasound guided biopsy or a CT guided biopsy. But if the lymph node pathology comes out to be a lymphoma, we would stick to histopathology, that is the gold. Gold standard for a biopsy, gold standard for a lymphoma diagnosis is a biopsy, and not an incisional biopsy, a complete excisional biopsy of a lymph node. And flow cytometry and immunohistochemistry. Immunohistochemistry is very important, I should say, for a histopathologist, and flow cytometry has to be supplemented because flow cytometry is the order of the day. Though I will not be dealing upon the flow cytometric part, analytic, I will only deal with the immunohistochemistry part, but I would suggest, if possible, the hematologist should order flow cytometric analysis, and that will give a good evaluation of the patient. And eventually we can also use cytogenetics, which is also very important, because to prognosticate a patient, important cytogenetic mutations or translocations, they are very, very important. So the approach is basically two things. For a lymph node biopsy, once it comes to our table in a pathology lab, we see the morphology, that is the under the hematoxylin and eosin stain under the microscope, and go for immunophenotyping, which can be either by immunohistochemistry or by flow cytometry. So there are a number of conditions which can actually create confusion when we are seeing a slide. First thing is that a lymph node enlargement, is it always a lymphoma? No, not most cases it is not. So what is the clue? So the clue is the detailed clinical history and a proper examination of the slide itself. Lymphoma versus other solid tumors. Again, you have to rely upon the morphological aspect. The patient of a lymphoma may have B symptoms which can resemble many malignant disorders. So to exclude malignancy, other malignancies, we again have to look at the slide properly. Now if you have diagnosed it as a lymphoma, now the question comes whether it is a non-Hodgkin lymphoma or a Hodgkin lymphoma. Again, histomorphology along with a band of immunohistochemistry markers and even flow cytometry will give you the correct answer. And finally, B cell versus T cell, again with the same battery of tests, we can come to a conclusion. Now, lymphoma versus reactive, there are various conditions which can mislead or mislead the pathologist and make the diagnosis a little tricky. So, these are the various conditions which I have listed. I will not read one by one, but these conditions can at times be a tricky, and especially the old disease, which always is a mystery and has not been conquered fully, that is tuberculosis, is still an enigma because it is coming in various forms, multi-drug resistant tuberculosis and so on. So, this disease itself can mimic lymphoma at times and make the things complicated, especially tuberculosis of unconventional sites like intestinal lymphoma, things like intestinal tuberculosis and so on. And the approach to a slide for a pathologist has to go through this following order, that is the patterns and the colors, the cell size, the shape and the background. Background is very important. You see, Hodgkin's lymphoma has a polymorphous background comprising of various other types of cells other than the normal malignant lymphoid cells, whereas a non-Hodgkin lymphoma, usually the B cell lymphomas usually have a malignant population, maximum malignant population. There can be diffuse pattern, there can be nodular pattern, and there can be other patterns like sinusoidal pattern or Indian file pattern. Now, what are indolent lymphomas or low-grade lymphomas? Initially, the early stage low-grade lymphomas, the stage 1 and stage 2, they may be that. Why do we need to distinguish? Because the low-grade lymphomas are the lymphomas which have a better prognosis. The 5-year survival is maximum, that is more than 85% if they are detected in an early stage disease. Unfortunately, they are detected a little late because being low grade, they tend to keep inside the body. The patient is at times unaware or at times ignores the symptoms. That's why they present at a later stage, stage 3 or stage 4. That's why the disease becomes incurable and a little complicated. But if they can be detected earlier, the cure rate or a long time survival is very good. And advanced stage low grade lymphomas are problematic in any way. In the old classification, that is the working formulation, this was there, that is the low grade, intermediate grade and high grade, which is no more followed, because though there is clinical significance which was there at that point of time, but now that significance as such has been lost and the classification has changed to a large extent. That's why this classification, that is the real working formulation, is not followed anymore. The updated Kiel classification, which was also there and which was quite in vogue at one point of time, which divided into B cell category and the T cell category, and the low grade ones I have only mentioned. The list is there, I am not going to read out. The low grade ones, which the Kiel classification called, some were found to be actually not low grade, especially the T cell ones. Now we are following WHO classification, universally available. The books are there, the PDFs are there. All the students, pathologists, clinicians, they can all refer to this particular classification. And one friend of mine was just asking me, are you dealing the cases, your own cases, or they are all borrowed cases? Well, many pictures I would definitely acknowledge are not my own pictures, but we did have a number of publications. At least this was a large publication from when I was in medical college, so where we did a large study on non-Hodgkin lymphoma patients. So coming to our topic as such, the names of low-grade lymphomas, mature B-cell lymphomas. There are some T-cell lymphomas which also are low-grade, like the cutaneous T-cell lymphomas, but there is some controversy regarding that, and due to paucity of time, I am leaving that category. I will be only discussing my talk, restricting my talk to this particular thing. B cell small lymphocytic lymphomas, very common, seen in elderly people, and when the SLL, that is the small lymphocytic lymphoma, spills into the blood, it resembles a chronic leukemia, that is chronic lymphocytic leukemia. However, if there is no lymphocytosis, that becomes SLL. There is lymph node enlargement without any lymphocytosis in the blood, that is strictly small lymphocytic lymphoma. And there are actually two distinct types of SLL with distinct behavioral pattern, that is one with unmutated gene rearrangement and one with the mutated gene rearrangement. Histopathology, it's not difficult to identify a small lymphocytic lymphoma because the cells are usually monotonous, they are small, they have clumped chromatin, and it is not difficult to identify because they at times resemble small lymphocytes of a normal lymph node pathology. So it's not difficult. It is a diffuse pattern, there is no nodularity. So the first thing here we see is the absence of normal lymphoid architecture and the diffuse arrangements of the lymphoid cells. And the bone marrow as such may have some infiltrate. If it is bone marrow is infiltrated, this is the photomicrograph, the small lymphocytic lymphoma, where it is quite, very common and easily diagnosable. And the immunohistochemistry, you see the B cell markers are positive, and a typical marker of T cell, that is CD5 cell, is positive. And here is the catch, we have to look at CD5 positivity to confirm it is a case of CLL, and there is an important important immunophenotypic marker CD10 which should be negative to call it CLL. And there are other markers which I have listed. I am not going to mention each one of them. This is the typical immunophenotype. You see the CD10 diffuse positivity, CD23, CD5, they are also positive, and the CD10 has come negative. So this was found to be a case of small lymphocytic lymphoma. Coming to follicular lymphomas again are a brand of lymphomas which have a varied pattern, and they have a tendency to go towards transformation. That is, they may become diffuse large B cell lymphomas, they may become this lymphoblastic or Burkitt lymphomas. So that is a problem with these type of follicular lymphomas. They are indolent by nature, but they may transform. So that is their importance. We have to understand that. And they have a typical nodular or follicular growth pattern, and the follicles are similarly sized follicles, and there is lack of tingible body macrophages. Okay, and infrequent mitosis is there. And this is the pattern. The multiple follicles are there, and it can be at times confused with a reactive lymph node. So here we have given the picture of a follicular lymphoma, and here the reactive lymph node with multiple tingible body macrophages. Okay, so that gives us the chance to say that it can be a reactive lymph node or a follicular lymphoma. However, at times it may be very difficult. At times it's the morphology at times may be very difficult when we have to resort to immunohistochemistry. So the immunohistochemistry, this is the immunohistochemistry. See, the CD20 is universally positive, and BCL2, the most important marker for follicular lymphoma, which comes positive in the germinal center cell, and the paracortical area is remaining free. This reactive follicle, on the other hand, shows the reverse pattern. The paracortex shows positivity, whereas the germinal center is negative. So that is very important, BCL2, and here the CD3, BCL6, they are all positive. So there are 3 grades of follicular lymphoma, and depending on the number of centroblasts. And this is the picture, higher grade showing a pleomorphic large cell, that is the centroblast. And immunophenotype is, immunophenotype. So this is the peculiar immunophenotype where it is positive for CD10 and or BCL6 apart from the B cell markers, and cytoplasmic BCL2 is positive and negative for cyclin D1 and T cell markers. Coming to lymphoplasmacytic lymphomas. So this is another category of indolent lymphomas where the cells appear plasmacytoid. They have an eccentric nucleus, abundant cytoplasm, and at times true plasma cells are also present, which give a positivity for the plasma cell marker like CD38, CD138. So that comes in this category, and it is at times associated with paraproteinemias, especially the IgM paraproteinemias and cryoglobulinemia, which can be, the syndrome is known as Waldenstrom macroglobulinemia. Okay. So some studies have found association with hepatitis C virus also, and this particular mutation MYD88 and that is L26P mutation is present. This has been found. Clinical features similar to small lymphocytic lymphoma, that is 60 years is the mean age group, and there are symptoms which can be related to the anemia, thrombocytopenia and so on, and hyperviscosity syndrome like visual impairment, neurological deficits, and bleeding tendencies may be there along with Raynaud's phenomenon. And it may have two patterns, classic pattern and the polymorphous pattern. Classic pattern will have partial effacement of the node, and a polymorphous pattern will have a complete effacement of the node and is a bad prognostic indicator. This is the photomicrograph, low power and high power images. Same, showing the non-neoplastic germinal center, because this is a partial effacement. Okay. And there are some immunoglobulins which are seen normally in plasma cells, the intracytoplasmic immunoglobulins. Okay. Sorry. And the kappa light chain shows focal positivity, where lambda light chain shows diffuse positivity in this index case. It has got a positive immunoglobulin, that is IgM, along with the B cell markers, and also you see this is CD38, a marker for plasma cells, and also positive plasma cells are positive for CD138. This is the pattern, CD20s, IgM positivity. Coming to marginal zone B cell lymphoma, again we have got marginal zone B cell, nodal marginal zone as well as extranodal marginal zone, which have got almost similar immunophenotypic characteristic. Medium sized lymphocytes, round to irregular nuclear contours, and three basic patterns. They can be either the perifollicular type or the circumferential around the germinal center, and also in the interfollicular areas. So this is the marginal zone lymphomas, and this is a low power, high power view. Nodular pattern, you see the nodular pattern can also be seen in a follicular lymphoma. So you have to identify whether it is a follicular lymphoma, whether it is a extranodal marginal zone lymphoma. So that is very important, because at times even a reactive germinal center, which is shown here, can give a impression of a follicle. Okay. And it is positive for the B cell markers along with the another IgM marker, that is lambda or kappa light chain, not IgM, lambda or kappa light chain marker, and negative for CD10, cyclin D1 and CD5. So it is the immunohistochemistry photomicrograph. This is a long list of extranodal marginal zone B cell lymphomas, and it is associated, the good thing about that, it is in many cases associated with some microorganism, and it can be treated with the antibiotic therapy. So H. pylori associated, the Campylobacter jejuni associated, all they are amenable to antibiotic therapy, which can give an added advantage to the treatment protocol. And it can be nodular diffuse pattern there, and here we saw this H. pylori in a gastric lymphoma. This is the H. pylori, and typically the cytokeratin was positive in epithelial cells, negative in the lymphoid cells, and CD20 was positive. And there is a typical pattern of gastritis and lymphoepithelial lesion. This was our case. I am not going to show. This was one case which was misdiagnosed. It came to Thakurpukur Cancer Hospital, that is Sarojini Gupta Cancer Center, where we were there. It was published also. And one of the cases, of the two cases, one case was misdiagnosed initially as a paniculitis, then somebody thought it tuberculosis, then somebody thought it is a extranodal marginal zone lymphoma, and finally we found it to be a case of large B-cell lymphoma. The patient unfortunately did not survive. So this can be the mistakes through which we learn. And we have in last category splenic marginal zone lymphoma, where the white follicles are expanded and the infiltrate is also extended into the red pulp. This is the picture. It is positive for the B cell markers and negative for CD3, CD5, etc. This is the CD20 positivity in the white pulp and BCL2 positivity. So I have come to the end of my talk. So I had to hurriedly tell you because of the paucity of time. So basic thing is that we have to, as a pathologist, we have to look into the slide properly and take the history also. Just looking at the slide will not do. It is not the examination slide where you just see and have to diagnose. You have to see the patient if possible. You have to see the clinical history and then come to a diagnosis. These are my references. Thank you so much. Jai Hind.
So it's an excellent presentation. There will be many more questions, but we are running very short of time. At the end, we may have some time. If possible, we may discuss. So thank you very much for a nice, lucid presentation. And really, this is what we actually do now. We are not going to the future. At the present state, this is what we are doing for lymphoma panel. So thank you very much.
Thank you, sir. Thank you all.
And the last presentation of this session, Dr. Navajit Malik. He is from PGI Chandigarh, and
good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. The topic for me today is benign hematology. Is there a role of immunophenotyping? So, when we think of immunophenotyping, we have immunohistochemistry, we have immunocytochemistry, and then we have the multicolor flow cytometry. And if we think of benign disorders, because we are testing the peripheral blood, we will definitely choose to have multicolor flow cytometry as our modality to test the immunophenotyping. So this is where we'll focus today. So when we think of flow cytometry in hematology, what comes to our mind? Acute leukemias, the BALLs, TALLs, the mixed phenotypic acute leukemias. We think of CLPDs, the 5 positive, 5 negatives, the 10 positive, 10 negatives that we discussed now, the CLPDs. We think of minimal or the measurable residual disease that is so in vogue nowadays in BALLs, TALLs, also in plasma cell myelomas. But benign hematology, really? So now in the next 15 to 20 minutes, I'll try to convince you that yes, flow cytometric immunophenotyping is used in red cell disorders, white cell disorders, and platelet disorders as well. So let's start with red cell disorders. So we have PNH, we have hereditary spherocytosis, we have G6PD deficiency, we have immune hemolytic anemia, and we have hemoglobinopathies, especially the F cell estimation. So we have a list of red cell disorders in which flow cytometric immunophenotyping is used. I will focus on the first two, because this is done, is being done for quite some time now. Even in our department, we have been doing this for the last 5-6 years now. In fact, PNH more than that. And I'll touch upon G6PD deficiency as well, because that is also a topic that is now coming up. So PNH, when we see these 9 tubes and we see in the tube number 5 and tube number 8 the hemolysis, we straight away think of Ham test. This gentleman described in 1937 that PNH RBC is hemolyzed under acidified serum. 50 years later, in the mid 1980s, the defect was found to be the GPI anchor. And among the many genes that are associated with the assembly of these GPI anchors, the PIG-A gene on the chromosome X has been implicated and is mutated in many cases of PNH. So here we can see these two cells. We can see, so we can see a normal cell and we can see a PNH cell. In the normal cell, we can see that there are surface proteins which are both transmembrane proteins and the GPI-linked proteins. However, in PNH cells, only transmembrane proteins are present and the GPI-linked proteins are absent. So that is what happens in PNH. So what are the clinical manifestations? We have hemolytic anemia, we have thrombosis, and we have bone marrow failure in PNH. So who do we test? Do we test everybody? So this was a wonderful paper by Borowitz and group in 2010, where they described the clinical indications for PNH testing. So under the heads of hemolysis, we have to test those patients who have intravascular hemolysis per se, and also intravascular hemolysis which are associated with iron deficiency anemia or abdominal plain or thrombosis. Also other acquired Coombs negative, non-schistocytic, non-infectious hemolytic anemia. What about thrombosis? Do we test all cases of thrombosis? No. Only cases having unusual site thrombosis, like hepatic vein thrombosis or other abdominal vein thrombosis or cerebral sinus thrombosis. And also in bone marrow failure cases, if we have aplastic anemia suspicion, we should definitely do a PNH testing. So how do we test it? Here we see this plasma membrane which has the GPI-linked protein. So we'll do immunophenotyping, which is we'll put an antibody against this protein. We'll add a fluorochrome to this antibody and we'll measure whether this protein is present on the cell or not. If there is no presence or there is absence of this protein on the cell membrane, that means PNH is there because there is deficiency of GPI link. We can do something else as well. We can add something called as flare. What is flare? Flare is basically fluorescent aerolysin. It is, the aerolysin is a pore-forming toxin secreted by Aeromonas hydrophilia bacteria, and it also has GPI as the anchor with which it binds to the cell. So we use this fluorochrome flare Alexa Fluor 488 for measurement of PNH. It is a mutant aerolysin. It will not affect our cells. It will not create pores in our cells, but it will definitely help in detecting the GPI-linked proteins. So when do we call anything positive for PNH? When at least 2 GPI-linked proteins are deficient in at least 2 lineages. So out of RBC and neutrophil lineages, at least 2 lineages should be tested, and at least 2 GPI-linked proteins should be deficient. So this was the date of the ICCS that came out in 2018. It is a wonderful update, and any center which is practicing a PNH testing or is planning to set up a PNH testing by flow cytometry should definitely go through this. It was a 4-part article. Part 1 was clinical utility, part 2 was reagent selection and assay optimization, part 3 was data analysis, reporting and case studies, part 4 was assay validation. So it went very deep into PNH assays. So what about RBC testing? How do we gate RBCs? We gate RBCs using CD235A. And what are the GPI-linked antibodies that we're testing here? Traditionally, if we go back to the textbooks, we remember CD55 and CD59, both to be tested. However, the new recommendations are only if we test CD59, that will do. It is sufficient to test the RBCs. And to get an idea of how deep this article went, they give us an idea of what antibody conjugates and what clones of CD235 and CD59 to be used for PNH testing. For WBC testing, gating antibodies for neutrophils is CD15, and for monocytes it is CD64. What are the GPI-linked antibodies? Neutrophils CD24, monocytes CD14, and both monocytes and neutrophil, flare and CD157. Again, if we go back to the article, you can see that they have given the antibodies, their clones for specific instruments as well. Here you can see it is for specifically for Beckman-Coulter cytometer and also for the BD Biosciences cytometer. They have given the clones that should be used, that is recommended to be used. Okay, so what are the multicolor assays that have been used? So earlier it was a 4-color assay when we had a lesser number of lasers in the flow cytometers. So we had a 4-color assay in which we had to use 2 tubes separately for neutrophils and monocytes, right? So then after that we went on to 5-color assays and 6-color assays. So when we move from 4-color to 6-color assays, we increase the sensitivity of the test, we reduce the cost, and also we reduce the sample requirement, because we must remember that many cases in which PNH testing is required are bone marrow failure cases in which there is already cytopenias. There are very few neutrophils and very few monocytes to be tested in the peripheral blood. So we require a lot of samples. So if we have only one tube instead of 2, that will help us a lot. Right, so this is the three laser 6-color tube that we are using at our center. We use CD45 chrome orange, CD15 Pacific blue. Flare, of course, only has one fluorochrome. CD24 PE, CD14 PC 5.5, and CD64 with APC F750. And let's go on to some cases. So we had a 30-year-old female who had pancytopenia under evaluation. The bone marrow examination revealed hypocellular bone marrow spaces and focal areas of hypercellularity with erythroid hyperplasia. So this is a typical case where we should definitely think of doing a PNH testing, because we have a scenario of probably an aplastic anemia or an evolving aplastic anemia, and we also have erythroid hyperplasia. The final part of the history is that the patient received multiple blood transfusions and last transfused 3 days before the testing. So this is important history. So this is the strategy we use for testing the cases of PNH. We first take all the continuous events, we take only the singlets and rule out the doublets. Then we move on to rule out the debris and take only the viable events, and then we take the CD45 positive the WBCs. Now the neutrophils are gated using CD15, and here we can see that CD24 negative and flare negative, dual negative events are around 10.7% of all neutrophils. Similarly, for monocytes, we get CD64 for monocytes, and we have a CD14 and flare negative events, that is 11.23% monocytes, which are PNH monocytes. So we have large clones of 10% and 11% in neutrophils and monocytes respectively. So there is definitely PNH clone here. We go ahead and tested the RBCs. We gated the CD235A positive RBCs, and here we see that only 0.34% of the RBCs show a PNH clone. So why is this discrepancy here? Why we had 10% and 11% neutrophils and monocytes, but only 0.3%. The first reason is, if you remember, the patient had received blood transfusion just 2 days back. So the RBCs in the patients are not his own, but probably that received from the transfusion. Another thing that you have to remember is that the RBCs that are the type 2 and the type 3 RBCs, they keep getting hemolyzed consistently. So they are not there in the blood to be tested. Only the normal ones are there to be tested. So that is why testing of WBCs is much more important than testing of RBCs for PNH. Another case, 24-year-old male, fatigue for 2 months, history of passing cola-colored urine, typical history, plasma hemoglobin raised. Here we get huge clone in neutrophils. So we get 15 positive neutrophils, and we get around 94% PNH clone here, and we get around 92% PNH clone in the monocytes. And when we go ahead and test the RBCs, here we can see when there are such large clones, here we can see clearly that there are type 1, type 2, and type 3 RBCs, and we get around a clone of around 60–70% here. And if we create a histogram, we can clearly see that 3 types of RBCs, the PNH RBCs, type 1, type 2, and type 3 PNH RBCs. Right, so next we move on to the other RBC disorder, hereditary spherocytosis. We know this osmotic fragility test and the shift to right that is typically associated with it. We know the red cell membrane, that is the disorders of the red cell membranes that are present in HS, and we can see that there are many spherocytes in the peripheral blood. Okay, so where does flow cytometry come in? So in the 2000s, a lot of articles came with EMA testing for flow cytometry in hereditary spherocytosis, right? So what is EMA? EMA is eosin 5 maleimide binding test. The maleimide moiety of EMA, it interacts covalently with Lys430 in the first extracellular loop of band 3 protein. So if you remember, band 3 is one of the important proteins of the red cell membrane. So EMA reacts to the band 3 protein. The partial reductions in the membrane protein occurs in HS red cells, and hence there is reduced binding to EMA. And this reduced binding to EMA is what we test, and red blood cells from patients with HS revealed significantly lower fluorescence in the, for EMA compared to red blood cells from normal subjects. Let's just take a case. This was an 8-year-old male child, had unconjugated hyperbil, peripheral blood showed spherocytes, and incubated OFT showed a right shift or a increased osmotic fragility. So here is what we did. We tested the EMA for the patient, and we see that the MFI in the channel for EMA is 1499. We also always have to take controls. In the controls, it is 2082, but here I'm showing only one control. You have to remember that you have to take at least 4 or 5 controls for EMA testing, because there may be a lot of variation among even the normal people. So if we have to calculate, the MFI of the patient is 1499, and we have taken 5 controls. The mean MFI of the controls is 2019, and we take a ratio of the patient is to control, and the ratio is 0.74 here. So this is very significant. Any ratio of less than 0.8 is significant and is very sensitive to detect hereditary spherocytosis. But you have to also remember that it is not specific for it. Congenital dyserythropoietic anemia type 2 also will show this. Right. There is also another type of test for flow cytometric detection of erythrocyte osmotic fragility. This was the paper by Konjakkya Ghosh sir and his group from NIH in 2011, which described this test. So what is the principle of this test? That spherocytes, due to their low surface to volume ratio, take up less water in hypotonically solution, and before rupturing, so they lyse early in comparison with normal red cells. This is all that we know. So advantage over conventional OFTs is that this does not require the multiple dilutions that we see in OFTs. We don't really need to prepare stocks. It does not have any additional cost. So if you have a flow cytometer, it is a very simple and a very short test. In 4 to 5 minutes, you will get a report in this. So this is the method to do this, and I'll just show you the results here. Here is a healthy control in which we just acquired these red cell lysates, and just after acquiring, for some time we add distilled water here, and then we see if adding distilled water, the number of red cells, some of the red cells should lyse. So the subsequent acquisition should show fewer number of red cells. So here we see in this healthy control, the red cells are slowly getting reduced. However, in a patient, this reduction is much more compared to the normal healthy control. So the percentage of residual red cells is measured. This is the formula. And here we see in the healthy control, the percent of residual red cells is 50.87%, whereas in the case, it is just 6.35%. And the cutoff is around 10 to 23%. So here within 2 to 3 minutes, we can diagnose HS. G6PD deficiency is also something that has been coming up. I'll not go into the details of this, but suffice to say that it is very useful in heterozygotes. So here is a case, a 5-year-old male who is completely deficient for G6PD. You can see that it is showing in the negative area, whereas in the mother you can see the 2 peaks because the mother is a heterozygote. So the RBCs which are staining for, which have G6PD and which do not have G6PD are very clearly delineated here. And this was a paper from our institute evaluating the flow cytometric test for G6PD deficiency in RBCs. Now coming to platelets. In platelets disorders, what do? We look for surface receptors using flow cytometry. So Bernard-Soulier syndrome, Glanzmann thrombosthenia, these are the disorders that can be measured using using flow cytometry, and also sometimes functional assays like HIT and platelet aggregation can also be done. I'll only just touch upon these. So let's take a case, a 13-year-old male child, he was diagnosed as being treated as ITP, but he continued to bleed. He had skin and GI bleeding, and the peripheral blood showed giant platelets. So we gated platelets using CD41, and this is the control, and the control shows CD42B. You can see the fluorescence in the control and in the patient. You can clearly see that in the patients, the control, the CD42B is much more lower compared to the control. And whereas CD61 and CD41 in the control and the patients are more or less similar. So what is it? It is a Bernard-Soulier syndrome because CD42B, it corresponds to GP1BA, and we know that in Bernard-Soulier syndrome, there is a deficiency of GP1B59. So just by this test, we can diagnose Bernard-Soulier syndrome. Another case, a platelet disorder, 13-year-old female, history of bleeding since 3 months of age, platelet morphology was normal. Again, we gated using CD42. This is the control of CD41 and CD61, and we see in that patient the MFI of CD41 and CD61 is markedly reduced compared to the normals, and thus this is a case of Glanzmann thrombosthenia because we know that CD41A corresponds to GP2B, CD61 corresponds to GP3A, and we know that in GT there is deficiency of GP2B3A. So again, using flow cytometry, we are able to diagnose Glanzmann thrombosthenia and other platelet disorders. A very big advantage of this is that even with low platelet count, this test can be done. So even in cases who have thrombocytopenia, this test can very readily be done by acquiring enough events. This case of GT was confirmed by light transmission aggregometry. As you can see, there is no aggregation with either ADP or epinephrine or arachidonic acid, but there is ample aggregation with ristocetin. So this was a case of GT. And now a novel flow cytometric assay based on platelet aggregation has also come, and platelet aggregometry can also be done using flow cytometry. Again, a very big drawback of light transmission aggregometry is that we need a large amount of blood because we need platelet-rich plasma. So we need to draw a lot of blood, and if we want to test the neonates, that is very difficult. So if we use flow cytometry instead of the usual light transmission aggregometry, even with a small amount of blood, this test can be done. So this is the flow chart of how to do a flow cytometric based platelet aggregation assay. We take the whole blood saturated sample, we collect the PRP, and we divide into two aliquots. We label both of them with CD31, one with CD31 FITC and one with CD31 PE. So two different fluorochromes for CD31. We mix them, we incubate with an agonist, and then we rest them for 10 minutes, and then we do a flow cytometric assay. Right, so what do we get? So here, let's suppose this is a normal case. So at 0 minutes without any incubation, we can see different CD31 and CD31 FITC and PE clones. And in the Q2, that is the one which has both CD31 PE and FITC, that is where the aggregation is occurring. So you can see the aggregation here. And at 10 minutes, you can see that the aggregation has increased because the Q2, we can see a lot more events in the Q2. So the percentage of double colored events, that is Q2 divided by Q1 plus Q2 plus Q4, it gives the ratio, it gives the percentage of the platelets that has aggregated. So in the case that we come back to the platelet, the one which had GT, we can see this case at 0 minutes. At 10 minutes with ADP, we can see that only 0.66% aggregation has occurred, which is impaired. With collagen, it is 14.3%, which is impaired. But with restocin, it is 29.6%, which is normal. So with flow cytometric immunophenotyping, we can diagnose the Glanzmann thrombasthenia. Right. The advantages, as I said, that it is useful in thrombocytopenic patient. There is no interference with bilirubin or lipemia, and the tests can be performed on whole blood. Now, I'll end by coming to WBC disorders. I'll just enumerate the WBC disorders that can be tested using flow cytometry. We have PNH, that is we have already covered. We have sepsis, we have PIDs, we have hereditary HLH, ALPS, and sometimes also in inherited bone marrow failure syndromes. So here are papers on sepsis, where early inflammatory markers like increase in CD64 in neutrophils, decrease of HLA-DR in monocytes, and increase on surface CD25 on T lymphocytes are very helpful early markers for inflammation and sepsis. This is the paper which showed a sepsis index also to diagnose these sepsis patients using the neutrophil CD64 and monocyte HLA-DR ratio. So that is sepsis for you. ALPS, what is ALPS? It has defective fast-mediated apoptosis leading to expansion of the autoreactive CD4 negative, 8 negative, or the double negative T cells. So let's just take a look. Here we can see we have gated CD3 positive T cells, and we can see that a lot of them are CD4 negative and 8 negative, and almost all of them are alpha beta type and not the gamma delta type, which are the usual double negative T cells. So if there is more than 1.5% of double negative alpha beta type T cells, so more than 1.5% of lymphocytes or more than 2.5% of CD3 positive lymphocytes, we can diagnose ALPS. So with that, I summarize by saying that flow cytometric immunophenotyping definitely has an important role in diagnosis of numerous benign disorders. Flow cytometry is changing in the paradigm in the diagnosis of benign disorders, and the role is evolving. We are seeing newer and newer tests every day. And immunophenotyping, it is not a domain of malignant hematology alone. With that, I thank you. This is my team from PGI. I must also thank Mrs. Praveen Bose and Mr. Arun, who are my technologists, who give us such wonderful plots to look at. And with that, I thank you for your kind listening.
Thank you very much. It's an excellent presentation. So we have to conclude now, and there will be no question because we are running short of time. Actually, we are 40 minutes late. So I think this can be discussed after the dinner time or on the direct discussion. So thank you very much. Thank you all.
Thank you, Chairperson. Thank you, Speaker. It was a wonderful talk, but although we are running late, so I now invite our organizing secretary, Dr. Prakash Kumar Mandal, sir, for this valedictory speech and prize distribution ceremony.
So I am back again, a very bad person who is standing in between you and cocktail dinner. Anyway, it's customary for the organizing secretary to close the session by validate, and we have had commitments of attractive prizes for our winners in different sections like quiz competition, This time we again had gone for a new type of concept in quiz. Each time we had actually in teams, 3-4 members. This time we thought that maybe it will be difficult for you to come in a group. So at least as individual you can participate. So again the participation was very commendable. And other sections like oral presentation, poster presentation. So we have that. Please stay with us. And I'm just entering into the actual part. I'm giving you a small statistics. We made it possible because of new Moviton, live streaming. The maximum number of viewers at any point of time is 289. 50% have subscribed our channel. And at this point of time before coming, the number is 125 viewers online. So that is what we basically wanted and targeted by making it or by going through a hybrid type of conference. People who are not willing, who cannot make himself possible to come into the hall can enjoy our sessions at home. So I will request President Bengal Society of, President Madam is not there. So I will request Vice President Professor Pradeep Mitro, please come into stage. Secretary Bengal Society of Haematology, Professor Tufan Kanti Doloi. Joint Secretary Bengal Society of Haematology, Professor Pranta Chakraborty. Please come to the dais. Shantanu is there. Oh, sorry. Organizing Chairperson BestCon 2021, Dr. Shantanu Basu. Shantanu da, please. আমাকে লিস্টটা দাও। So first come to quiz competition. It was an open level competition for postgraduates. We didn't allow postdoctorates, DM students, because actually this time postdoctorate students, they prepared the slides and they conducted the slides. So we actually didn't allow the postdoctorates. Sorry for that. So in that session, the first prize, first prize for quiz goes to Joy Rai. Joy Rai is there. Joy Rai. Can anybody identify Joy Rai? So you are Joy Rai. So please come. Many things are odd in this year during post-corona phase. The usual norm is we start with third prize, then come to first prize. We are starting it on a reverse way. So first prize.
Joy, please introduce yourself.
Joy Rai.
My name is Joy Roy. I'm coming from Kolani, Corpus. College of Paramedical and Allied Health Sciences. And I'm a student of Bachelor in Operation Theatre Technology.
Bachelor in Operation Theatre Technology. Very good.
Fantastic. Professor Mitra, please. First prize goes to Joy Rai. BSH, first prize. Prize value is rupees 5,000. Second prize in quiz competition, Dr. Ovilas Chatterjee. Certificate by Dr. T.K. Doloi. So,
Good evening, sir. I am Dr. Ovilas Chatterjee. I am Dr. Ovilas Chatterjee. I did my MBBS from Bakura Shommilani Medical College, and currently I am a second year student in MD Pediatrics in Mednipur Medical College.
Second prize in quiz competition, Dr. Ovilas Chatterjee. Prize value rupees 3,000. 5,000. Third prize in quiz competition, Dr. Neeraj Mukherjee. Neeraj is there. Yes, Neeraj is there. The certificate and prize will be given by Professor Chakraborty. You introduce yourself.
My name is Neeraj Mukherjee. I am from College of Medicine and JNM Hospital, Kollani. I am the Bachelor of Medical Laboratory Technology.
Very good.
Now poster presentation. The third prize goes to Dr. Abriti Baveja. Dr. Abriti Baveja. Dr. Shantanu Basu, please. Raghavendra Mishra. Second prize, Raghavendra Mishra. You give a brief introduction. Okay.
I am Raghavendra Mishra from Anand Mohan College, Kolkata.
Okay.
What discipline? Human physiology.
Second. First prize in poster competition, Dr. Malini Gaur. Dr. Malini Gaur. Oral presentation. First prize goes to Sudeshna Kundu. Sudeshna Kundu. That was an excellent presentation. I think many of you enjoyed her presentation. Go to.
Hello, I am Sudeshna Kundu and I am doing currently PhD from Department of Physiology, University of Calcutta.
Second prize goes to Dr. Dibakar Poddar. Dr. Dibakar Poddar.
Hello. Hello, I'm Dr. Dibakar Poddar from ISTM third year PDT.
In oral session, third prize goes to Dr. Prakash Singh Shekhawat. Dr. Prakash Singh Shekhawat. So other than this prize, additionally I
Introduce yourself, Prakash.
Prakash.
Myself, Prakash Singh Shekhawat. I am a third year DM resident from NRS, Clinical Haematology Department.
So I am grateful and thankful to Bengal Society of Haematology in addition to entrusting me to organize this BestCon 2021. They have given me another opportunity to lead a journal. Second prize goes to Dr. Dibakar Poddar. Maybe one of its unique in Dibakar kind. It's an online and offline journal. And I am very glad to see that many of us present over there are from basic sciences.
And I am doing currently
future,
PhD from
they will contribute
Department of
in our
Physiology,
journal.
University of Calcutta.
So another thing I'm missing perhaps while going through these papers, evaluation sheets, there is almost neck-to-neck competition. So many others are there who actually have the credential and potential that they also should get this prize, but because of certain restrictions, 1, 2, 3 ranking like that, and our limitations, we have restricted ourselves up to 3. In future, I hope you will again join with us, and it's the norm that Bengal Society of Haematology in each year organizes this BestCon conference, usually in 3rd week of February, and I am very sure that will again happen next year in a more vibrant manner. We are already very late, so I just thank you all for everything. Good night. And I invite you all to join with us
And I am doing currently
dinner.
PhD from Department of Physiology.
Dr. Avriti, Dr. Divakar on the stage. Dr. Brijesh, come on the stage.
Hey, Gopinath.